Good morning. The title of this section is The Aspect of BP Variability and its Role in Heart Failure. I'm Dong-soo Kim from the University of Korea, and the co-chair is So-yeon Choi from Aju University, Korea. Today, she's not feeling well, so she's will go online. Yeah. We have four topics in this section. I'm conducting the first two topics, and the other two topic and the panel discussion will be conducted by Professor So-yeon Choi. First, I introduce panelists to you. Mina Kim from Korea University, Kyuchul Ro from Catholic University, Seung Jo from Inje University, Ran He from Hanyang University. Thank you. First speaker is Professor Miguel Kamapoto Babkowski from hospital clinic at the University of Barcelona, Spain. Let me introduce you to his brief biography. He's a member of the executive committee of the Spanish Society of Hypertension, secretary of the working group on hypertension, and the heart of the European Society of Hypertension, and associate editor of Hypertension Research, the official journal of the Japanese Society of Hypertension, and principal investigator of the registry ABPM on HAPEP Global Registry. He will be talking about epidemiology and the clinical outcome of heart failure with hypertension in Korea and other countries with long survival. Please.
Thank you very much, Mr. Chairman. Thank you for your kind words. And thank you to the Korean Society of Hypertension for your kind invitation. Why talking about epidemiology and clinical outcome? As you will see, in countries like Korea and my own country, the prevalence of hypertension and heart failure is very high because of the aging population. But as you know, aging population and most of all frail population has a different characteristics as the usual population because of the widely presence of some phenomena as, for example, white coat hypertension and other phenomena. That means that it has a great impact on their survival. So if we go further, these are my disclosures. And this is the schedule that we will go on through on this morning, in the next minutes. First of all, epidemiology of hypertension, left ventricular hypertrophy, heart failure, and frailty. Why countries with long survival? Here you can see in dark blue the countries that are with the longest survival. As you see, where we are now in South Korea is one of the countries of the longest life expectancy, and in Europe, Canada, and Australia also. And when we go to the European Society of Cardiology members, in the high-income countries, there is a longer survival that goes until 85 years. And the same happens when we look for the expectancy from 2019 to 2100. But let me tell you that that was projected in 2019. But as you all know, we had the pandemic of COVID in the last years, and we had about more than 100,000 deaths in Spain, for example, and most of them were people with high age. So it has changed a little bit, but as you see, the life expectancy is growing in all these countries. And one thing that is very to take into account is what happened in Korea. Korea is one of the countries, South Korea is one of the countries of the fastest aging when we look to all these countries. So we have a high percentage of aging population. Is this important? Yes, because when we look for the prevalence of hypertension in high-income countries with elderly population, we see that in population above 70 years, the prevalence of hypertension is about 74% of all the population elder than 70 years. And on the other side, you can see here that this is also looked on some nice papers, as this paper from the Korean and Haynes, that shows us that there is a very high number of population with hypertension in Korea in people above 70 years. What about left ventricular hypertrophy? When we look on this data from the Italian group from Cesare Cuspidi, you can see that in population above 65 years, the prevalence of mild, moderate, and severe left ventricular hypertrophy together goes up to 60% or more. That means we have population that has a high prevalence of left ventricular hypertrophy, and if we look for the specific prevalence for heart failure per 1,000 inhabitants in South Korea, we see that in population above 80 years, it is a very high percentage of people having heart failure. So it is not only age, it is also the prevalence of hypertension, changes in the heart leads to heart failure and heart failure itself. But what about frailty? Frailty is a question that we have to define, but frailty is very common. As we see in these bars, in Spain, for example, for population dwelling and having more than 65 years, the prevalence of pre-frailty is about 1 for every 2. That means 50% of the population, dwelling population with more than 65 years could be considered pre-frail, and about 27% could be considered frail. That means we have elderly population, we have hypertensive population, heart failure population, and frail population. Why? Because as you know, cardiovascular aging is a question that depends on all these questions: mitochondrial oxidative stress, genomic instability, epigenetic changes, endothelial senescence. And this complicated slide shows you how all these changes interact and conduce to this situation that you know very well as hypertension specialist, that the left ventricle is changing its shape and is changing its function, and also does the circulation, because there is a stiff aorta and a left ventricle that is hypertrophied, and that causes heart failure. These changes are conducing most of all to HFpEF, which you know is very prevalent in this kind of population. But as you see here, these changes are not the same on different ethnicities. Therefore, we have the characteristic of, for example, Asian ethnicity and longer survival that can be a dangerous combination to end on heart failure with preserved ejection fraction. This conduces to, at the end, the ejection fraction that increases, but with a low left ventricular end diastolic volume, conduces to a reduced ejection fraction at the end. And in summary, what we see in these patients is that inflammation, sarcopenia with low muscle mass, subclinical multisystem dysfunction, and cardiovascular disease conduce to the frailty phenotype. I have one recommendation to make. If you treat patients with hypertension and patients with heart failure, it is good for you to stand up from your office and don't wait for your patients sitting on the office. You have to go to the door and see how the patient walks. It is a simple measure to know if it's frail or not, because gait speed, as we will see later on, is very simple to see, and you can characterize the patient as a frail patient. As we have described with Professor Cario, aging, hypertension, heart failure, and other factors can interact by pathogenic pathways, and they conduce to geriatric symptoms as, for example, low gait speed and falls, and all these things then conduce to frailty. and that is a cause of adverse health outcomes. So how we should measure frailty? That is the very important point, because we have a lot of scales and a lot of ways to measure frailty. You see here that there is the physical frailty and the multidimensional frailty. Physical frailty was described to know how you see the patient, for example, the gait speed and the hand grip dynamometer, and how the patient stands up and sits at which velocity. And there are different ways to describe that. And on the other hand, frailty index of accumulative deficit was used in retrospective studies, most of all to know if patients were frail or not. This is a very simple scale that you can have in mind, and you can differentiate patients by the way they come to your office and making very simple questions to your patient and the family of your patients. So you can very simply make a detection of frailty, and you can see which degree of frailty your patient has. And with this simple scale, as I will show you later on, that is the scale that can give you a wide definition of frailty, and this that what is recommended to use nowadays in elderly patients. We have also this recommendation from the Heart Failure Association that I show you because it has to do with the 4 main domains in frailty. That it's clinical, psychocognitive, you have to know about cognitive decline, you have to know about activities of daily living, and don't forget about instrumental activities of daily living, as for example the Lawton scale. It is not useful if you give 10 pills a day to your patient and there is no one that helps him to buy the pills and to organize the schedule of pills and so. And that comes also to the social aspect, because we have to know if the patient can come to our office or not. So as you see here, these are the different instruments of measuring frailty, and here is more detailed the multidimensional frailty. But I recommend the use, as most of the geriatricians recommend the use of clinical frailty scale, what I show you further. So why is frailty important in elderly people? If you look here, you see the 4 types of hypertrophy: the normal geometry, concentric remodeling, concentric hypertrophy, eccentric hypertrophy. If we take all the patients with left ventricular hypertrophy, with concentric remodeling, eccentric remodeling, you can see that in frail people, is about 60% of the people has left ventricular hypertrophy. And from the people in normal range, 20% has concentric geometry. That means about 81% of people that are frail with sarcopenia has a remodeling of the heart, 80%. And what are causing that? In this nice study, the CardioSprint study with frail and sarcopenic patients, they have defined that ABPM, clinical blood pressure, and daily blood pressure, night blood pressure, and model 4 night blood pressure is one of the most important determinators of left ventricular mass. And on the other hand, if we look for the risk of having heart failure and frailty, as you see here, the patients with the lowest values of the ABC battery score, that means the more frail patient, have a highest percentage of having heart failure. That means having frailty, it makes you more tendent to have heart failure. On the other hand, we have, does it work? No. I use that. Okay. If we want to look to the real prevalence of frailty, we can go to a meta-analysis, and I don't want you to go into this very complicated slide and very busy slide. What I want to show you is how different it could be if you measure by one tool or another. This meta-regression has showed that the prevalence of frailty of heart failure in frailty is about 44%, which is a very high number. So almost half of heart failure patients are frail, and the prevalence of frailty is not only related to age and functional class. There is other questions that we have to take into account. And the future work, and I want to consider to work on that, is to measure frailty in heart failure. It is very interesting, and it is a need of broaden our view and go to a broader view and make more investigation in this kind of patients. If we look here, what I want to show you is that clinical frailty scale, what you see in the left part of, in the right part of your screen, and the left part of the left bar is clinical frailty scale, is the better tool to get characterized frailty. So frailty is common and associated with increasing age, comorbidities, and severity of heart failure. And the best way to characterize frailty is the clinical frailty scale. As an outcome factor, you see that having a low activities of daily living can give you a more higher prevalence of acute decompensated heart failure. You see 3.46 times more prevalence of acute decompensated heart failure. And you see that usual gait speed is also related to having more decompensated heart failure. And as you see here, the low group of clinical frailty scale has a more prevalent all-cause death, cardiac death, non-cardiac death, and rehospitalization. Therefore, we see that having a low frailty, having frailty is causing that we have a bad prognosis and bad outcome in heart failure. This is the same for age. You see in age above 80 is an indicator that having high age and frailty is a bad outcome indicator. So to end with my take-home messages, frailty is common in elderly patients with heart failure, and both share common characteristics, including strong relation with the high burden of comorbidities, as you see in your patients, inflammation and sarcopenia. And it has a worse clinical, functional, and quality of life outcomes in all the patients with heart failure. And therefore, it should be considered on your routine assessment on the daily life using a well-validated assessment as clinical frailty scale. And my last slide is this, from this paper I recommend to you, published in 2019 about frailty and heart failure recommendation, that you make potential intervention as multi-domain rehabilitation, diet, nutritional support, and cognitive support. Thank you very much.
Thank you for your excellent and informative lecture. Next topic is pathophysiological mechanisms for the development of HAPEP in hypertensive patients. Speaker is Professor Byung-Gyu Kim from India University. Please.
Yeah, thank you for your kind introduction, Chairman. I'm Byung-Gyu Kim from Sangyebek Hospital, India University. My topic is pathophysiological mechanisms for development of HAPEP in hypertension patients. I have nothing to disclose. As you know, HAPEP is a highly multifactorial disorder, and which is a complex, highly integrated, multi-system loss of cardiac and vascular reserve capacity, affecting the heart structure, function, and autonomic control, vasculature, microcirculation, and the periphery. If the HAPREF is a cardiac disorder with systemic manifestation, the HAPEP can be said to be a systemic disorder with cardiac manifestation caused by multifocal morbidities. Some specific alterations in structure, function, and intramyocardial signaling have been identified in patients with HAP-PAF. This autopsy data shows that red color is HAP-PAF and black one is control subjects. The patients with HAP-PAF have more cardiac hypertrophy and more severe epicardial coronary artery disease and coronary microvascular rarefaction, which means the lower microvascular density, and more myocardial fibrosis compared with the control subjects. So each of these structural alterations may contribute to the LV diastolic dysfunction, which leads to an increased LV filling pressure, thus the cardiac reserve function impairment. And these all structural alterations may be the result of intramyocardial signaling alterations such as endothelial dysfunction, inflammatory reaction, oxidative stress, and the downregulation of myocardial cyclic GMP and protein kinase G signaling pathway. And all these reactions can be accelerated by the comorbidities of HAP-PAF. Various risk factors and comorbidities such as hypertension, diabetes, obesity, kidney disease, and inflammatory disease, COPD, anemia, and aging are associated with HAP-PAF. The most frequent is, of course, arterial hypertension. The data from RCT in HAP-PAF reported a prevalence of hypertension from 64% to 100%. Long-standing hypertension ultimately leads to heart failure. As all of you know, the LV hypertrophy and diastolic dysfunction are known as the key myocardial structural and functional abnormalities induced by arterial hypertension, which are the cardiac remodeling to a predominant pressure overload. When the pressure overload is sustained, HAP-PAF ensues eventually. The findings in the pathologic LV hypertrophy associated with hypertension are very similar with the findings of HAP-PAF. A number of studies of biopsy and autopsy from the patients with hypertensive heart disease shows an exaggerated accumulation of collagen fiber within the myocardial interstitium surrounding the intramural coronary arteries or arterioles, like these pictures. And the degree of fibrosis is significantly correlated with the severity of myocardial stiffness. The excess of collagen is the result of increased collagen type 1 and 3 synthesis by myofibroblasts and decreased collagen degradation by matrix metalloproteinase. A number of factors may account for this equilibrium. Some activation of neurohormonal pathways such as ROS and vasoactive substances, some cytokines and growth factors, pressure overload, sex, and some genetic variation act synergistically to modulate the fibrous tissue formation. Especially ROS increases the activity of TGF-beta, which further induces the fibroblast activation and myocardial fibrosis. A recent study even showed that some ROS gene polymorphism is correlated with the LV hypertrophy in hypertensive patients with HAP-PAF. So such a genetic determinant of LV hypertrophy could be the predictors for HAP-PAF development in hypertensive patients. Beyond the collagen, a number of experiments have shown that the titin is also associated with the myocardial stiffness. Titin is a giant myofilament protein that functions as a complex spring which is responsible for cardiomyocyte passive tension. This figure shows the signaling pathway in myofilament regulation and the titin-based stiffness. The cyclic GMP is generated from the activation of nitric oxide and from the stimulation by natriuretic peptides. And this cyclic GMP stimulates the activity of protein kinase G activity. And both PKG and PKA induces the phosphorylation of titin in the N2B segment, thereby reduce the cardiomyocyte stiffness. The phosphorylation of titin is very important to lower myocardial stiffness. However, low cyclic GMP level and protein kinase G activity have been reported in the myocardium of hypopath patients, which can result in the hypophosphorylation of titin that in turn increases the myocardial stiffness. This experiment also shows that compared with control subjects and hypertensive patients without hypopath, patients with hypopath had decreased phosphorylation of titin site in the N2B segment. In addition, the abnormalities in coronary blood flow also contribute to development of hypopath. In normal individual, coronary blood flow may increase up to 4 to 5 times in response to physiologic demands. However, in patients with LV hypertrophy and ST segment depression, these response is reduced by about 50%. Furthermore, there can be some supply-demand mismatch in patients with LV hypertrophy. So such impaired endocardial, subendocardial coronary blood flow may increase the risk of hypopath. Apart from diastolic dysfunction and LV hypertrophy, several alternative mechanisms seem to be included in the pathogenesis of hypopath. The first one is myocardial contractile dysfunction. Although LV ejection fraction is preserved in patients with hypopath, some data shows that some hypopath patients have some subtle LV systolic dysfunction, which is not reflected by ejection fraction. This data shows that myocardial contractile function measured as endocardial fractional shortening or midwall fractional shortening were impaired in patients with hypopath compared with control subjects or hypertensive patients without hypopath, despite the similar LV ejection fraction. Another study also shows that an impaired global longitudinal strain is frequently seen in patients with hypopath as well as in patients with hypertensive heart disease. In addition, some heart MRI data also shows that the extent of LV concentric remodeling was significantly related with the reduced LV midwall systolic function, which was assessed by myocardial tagged MRI. In aggregate, these data suggest a role of progressive systolic dysfunction on top of diastolic dysfunction in the transition from hypertensive heart disease to overt hypopath. The next is left atrial dysfunction. Left atrial enlargement reflects the cardiac remodeling and is an early sign of hypertensive heart disease and is present in the majority of hypopath. Beyond the left atrial enlargement, left atrial functional abnormality is increasingly recognized in hypopath. These data shows that compared with asymptomatic hypertensive patients with LV hypertrophy, patients with hypopath had decreased late diastolic mitral annular tissue velocity, which means the reduced atrial contractile reserve in response to isometric hand grip exercise or treadmill exercise. More recently, increased left atrial stiffness and greater left atrial pressure pulsatility have been shown in patients with HAPPF compared with the controls and patients with HAPREF. Next one is the systemic inflammatory endothelial activation. Several comorbidities, age, and extracardiac organ involvement, and some acute events induce the systemic inflammation with increased level of inflammatory biomarkers. And by these inflammatory biomarkers, coronary microvascular endothelial cell reactively produce the reactive oxygen species and reduce the bioavailability of nitric oxide and cyclic GMP contents, resulting in the decreased protein kinase G activity. As previously shown, low protein kinase G activity leads to hypophosphorylation of titin and thereby increased myocardial stiffness. Furthermore, endocardial cells attracts the infiltrating leukocytes, and these leukocytes secrete the TGF-beta, which further induce the myofibroblast activation and interstitial collagen deposition. The experiment shows that in myocardium of HAPPF patients and HAPPF rats, the E-selectin and intercellular adhesion molecule expression level were upregulated, and the myocardial concentration of hydrogen peroxidase were raised, and uncouplings of endothelial nitric oxide synthase, which is associated with the low myocardial nitrite concentration, is elevated, and protein kinase G activity and cyclic GMP concentration were decreased. The last one is microvascular stiffening and abnormal ventricular arterial coupling reaction. Increases in peripheral artery tonometry amplitude in response to reactive hyperemia is diminished in patients with HAPPF compared with control subjects. And during exercise, there were blunted increase in LV contractility and blunted vasodilatation and changes in systemic vascular resistance, resulting in abnormal ventricular arterial coupling response in patients with HAPPF. So this picture is the last picture that summarizes the pathophysiological association between hypertension and HAPPF. The pathophysiological association of hypertension and HAPPF is complicated, and their understanding is extending beyond the LV hypertrophy and diastolic dysfunction. Further understanding may provide potential new therapeutic opportunities beyond the reduction of blood pressure, but there's still far way to go. Thank you.
Yeah, thank you for your excellent and informative lecture. Next topic will be conducted by Professor Soyeon Choi.
This is Soyeon Choi. Truly apologize for attending online. I would like to introduce next speaker, Dr. Jin-Sun Park. She will present aspect of BP and its relation with heart failure, BP variability. Please.
Thank you for introduction. I'm Jin-Sun Park in Jeju University School of Medicine, and today's my topic is BP variability and its relation with the heart failure. As all you know, the hypertension is a common comorbidities and risk factors for heart failure. So many data has already confirmed that effective BP control can prevent progress and occurrence of a heart failure. But blood pressure is really dynamic, so it can vary from day to day or from visit to visit. So single BP measurement may not reflect the full spectrum of BP related to cardiovascular risk. In a day, so-called circadian rhythm in a body, there is many different hormonal changes and body temperature changes that happen. So blood pressure is according to the circadian rhythm, so it can be changed. So stress hormone, including plasma adrenaline and plasma noradrenaline, is changed, and blood pressure can be variable according to their hormonal release. But the variation is not always the same according to the person, because they have a lot of other pattern of circadian rhythm. So many ambulatory BP parameters are related with target organ damage. So today I will focus to the BP variability. So what is the BP variability? So blood pressure normally fluctuates during day, can vary from day to day, and pronounced fluctuation blood pressure can occur over short and long term. So this data is about the epidemiologic study, and using the cohort, they said that episodic hypertension is really common. So in their study, the TIA patients had 12% of the patients had stable hypertension. That means their blood pressure was constantly 140 millimeter mercury. That means they're stable hypertension. And 69% had episodic hypertension. That means sometimes their blood pressure is over 140, and sometimes their blood pressure was below 140. So there are lots of BP variability, seasonal and circadian, and hour to hour and visit to visit. But many data are classified this BP variability like this. So one is a very short-term BP variability, bit to bit variability, and second one is a short-term BP variability means over 24 hours, and midterm BP variability is a day-to-day variability, and finally, long-term BP variability, and it is a visit-to-visit variability. And all these parameters have many data about the subclinical organ damage and its relationship. So what caused the BP variability? So many factors are suspected, and many data are shown that these parameters are related with the BP variability. Firstly, sympathetic nervous system activation and last system activation is closely related with BP variability. And decreased parasympathetic nervous system and baroreflex system also can cause BP variability. And finally, atrial stiffness is one of the causes of BP variability. So I will show you the evidence about that systemic nervous system and nervous system activation is a cause of BP variability. This is a rat experiment, and this group is a normal blood pressure without any procedure, and this group is a spontaneous hypertensive rat group, and this group is after SAD. SAD is a bilateral sino-aortic denervation, and that means denervation of a parasympathetic nervous system. And after SAD, so transient activation of a sympathetic nervous system and RAS system activation is observed. After SAD, as you can see, their blood pressure mean blood pressure is almost the same with the rat without SAD, but their variation is really higher than without SAD. And this result is my data about the home BP monitoring data and the relationship with the atrial stiffness. So as you can see, the systolic BP variation was closely related with the higher augmentation index, and it means the atrial stiffness is closely related with the BP variability. And this phenomenon is also seen in a day. So of course, tipping pattern was also dipping pattern was also related with the arterial stiffness. Because arterial stiffness is also, they have a closely related with the last system activation and sympathetic nervous system activation. So BP variability has a common pathway, so they are both cause and result, so they are often vicious cycle, and arterial stiffness also increase the central blood pressure. So finally, they make a versatile hemodynamic stress, and finally, the heart failure and other target organ damage can be happen. And as I mentioned, the baroreflex sensitivity decreases that can make the PP variability. But anyway, arterial stiffness is also related with the baroreflex sensitivity. This group has a distensible artery, and this group has a stiffened artery, so their baroreflex sensitivity has a different. So stiffened with the patient with stiffened artery, they have a lower baroreflex sensitivity. So that makes arterial stiffness also make one of the cause of BP variability. Then how BP variability make the organ damages? Of course, the hypertension, mean BP elevation, there are target organ damage by the pressure overload, but BP variability has a target organ damage is a little different pathway, because a repetitive BP rise makes last system activation and other chronic inflammation happen, and by the chronic inflammation, organ damage is aggravated. This is the result of the rat experiment, as I mentioned. Their pathologic finding was shown. Then after SAD, the prominent fibrosis was shown in their heart, and their heart size was increased. So the BP variability is closely related to cardiac remodeling. And this graph shows the average BP rise make the increase the inflammatory markers. After absolute aberrant BP rise, making last system activation and increase the inflammatory marker like MCP1 or ICAM1 or TGF-beta, and they are usually make fibroblast proliferation and more prominent macrophages. So this was shown also in a rat experiment that I mentioned. So after SAD, this inflammatory marker was prominently higher than without SAD. And BP variability also have endocellular, closely related to endocellular dysfunction. This data shows the FMD parameters, and high BP variability shows the lower change of FMD. That means the endocellular dysfunction is prominent in the high BP variability patient. As you all know, endocellular dysfunction can accelerate the last system activation and inflammation and vasoconstriction, and finally cardiac remodeling and vascular remodeling, and so it is closely related with the occurrence of heart failure. And how about the anti-proBNP? So anti-proBNP is a well-known marker for prognosis of heart failure or the status of heart failure. But as you can see, the many different pattern of BP variability markers are closely related with the anti-proBNP increase. And this slide shows that, and with the BP variability and also combined with the arterial stiffness, their increase is more prominent. So BP variability and arterial stiffness, if it is combined, they have a vicious cycle and more cardiac overload to the heart. So there can be happening with the heart occurrence. They can make a occurrence of heart failure. So how about the clinical outcomes? Like these phenomena, so finally, the cardiac events and stroke and many target organ damage is prominent. The incidence was higher than with the higher BP variability patients. And in case of heart failure, according to the BP variability, the incidence was increased. How about the prognosis? This data was our data. So after ST-MI, so heart failure aggravation or cardiovascular death from the heart failure, it was prominently higher than, more prominent in the high BP variability patients. So can we intervene the BP variability? So it may be yes, because this data show the red experiment that I mentioned. So after SAD, patients have a more prominent fibrosis, but with the RAS blockade, the fibrosis is decreased. So, and the other inflammatory marker was decreased with the RAS blockade. And according to the BP medication, so the standard deviation of home blood pressure, that is BP variability, was decreased. So according to the hypertensive medication or other medication, we can intervene the BP variability. So lots of factors cause the BP variability, and BP variability can cause the many target organ damage, and we can see these clinical outcomes like the congestive heart disease or stroke and many other target organ damage are. So the BP variability is a really important marker for the occurrence, risk factor for occurrence of heart failure and their prognostic factor for adverse outcome. So the BP variability might be more informative for understanding the patients with heart failure than single value of blood pressure. Thank you for your attention.
Dr. Hua, thank you very much for your nice presentation. The last presentation will be from Dr. Hyun John from National Health Insurance Severance Mission Hospital. Please. His speaking is about the spectrum of blood pressure and its relation with heart failure, known before BP pattern. Please.
Thank you for a nice introduction, Chairperson. It is very honored for me to present my topic today. I'm going to talk about the relationship between heart failure and non-deeper blood pressure dipping pattern. I have no disclosure. I will present in this order. First, I will introduce the association of nighttime dipping pattern and heart failure. And I'm going to discuss new heart failure treatment targeting nighttime blood pressure. And next, antihypertensive treatment targeting nighttime blood pressure. As you all know, the effect of hypertension for the incidence and progression of heart failure is well known. It's a very old study. Of 25 years ago, a Framingham study presented that hypertension was associated with increased risk of heart failure. In case of male, the risk ratio was 2 times, and in female, it's more than 3 times, and the attributable risk is very high. And also, as you know, blood pressure lowering treatment can prevent heart failure incidence and progression. It is a meta-analysis which analyzed more than 60,000 patients. And when we treat hypertension in heart failure patients, heart failure incidence can reduce about 30%. So, what is association between heart failure and nighttime blood pressure or dipping pattern? Is there any association? This study can be a hint for us. It is a recent study published in Circulation 2020, and Japanese ambulatory blood pressure monitoring study. It enrolled more than 6,000 patients, elderly patients with hypertension. They had no symptomatic cardiovascular disease. And they analyzed the nighttime BP dipping pattern. And as you can see here, patients with non-dipper or riser pattern had more higher risk for incidence of cardiovascular events than non-dipper, dipper, or extreme dipper. And in terms of heart failure, the trend was similar. The riser and non-dipper had a higher incidence of heart failure. And it's a similar study. This study was based on population cohort study, which analyzed more than 11,000 patients, and it was conducted in Europe, Asia, and South America. As you can see here, the patient with dipping pattern of reverse dipping or non-dippers had more higher incidence of mortality and cardiovascular events. And interesting point is this, when adjusted with 24-hour systolic blood pressure, this trend was maintained. But when adjusted with nighttime systolic blood pressure, the trend, according to dipping pattern, was attenuated. From this result, we can suspect that nighttime systolic blood pressure is more associated with cardiovascular or mortality risk more than 24-hour blood pressure. So what about the difference according to HAPREP or HAPPEP? Is there any difference of association between HAPREP and HAPPEP? This is a small observational study in Japan, and they analyzed 500 patients with HAPPEP and HAPREP. As you can see here, natriuretic peptide or beta-blocker use or high dimension of LV was more associated with HAPREP. But according to ABPM data, rising pattern of dipping pattern was more associated with HAPPEP. And this is another ABPM study. It analyzed 500 patients with hospitalized for heart failure, and 1/3 was HAPREP and 2/3 was HAPPEP. As you can see here, in HAPREP patients, dipping pattern was not associated with outcome. But in HAPPEP patients, as you can see here, risers or non-dippers were more associated with mortality or cardiovascular events. So, what is the mechanisms by which riser pattern or non-dipper pattern of nighttime blood pressure more adversely affect heart failure? There may be two main mechanisms. I can show you, first of all, sodium handling abnormality or salt sensitivity. And another one is increased sympathetic activation. It is very similar as you previously heard from the BP variability in heart failure patients. First, sodium handling, I will show you a small study. As you all know, antihypertensive agent, diuretics, is one of the antihypertensive used in more tendency of salt-sensitive patients. And one study, they administered hydrochlorothiazide in dippers and non-dippers. And they showed that in non-dippers, thiazide use was more associated with reduction in nighttime blood pressure than daytime blood pressure. This is the curve of Guyton pressure natural veracity theory. As you can see, the higher the arterial pressure, the more sodium excretion. Normally, increased blood pressure promotes more natriuresis. So individuals with adequate circulating volume, daytime increase in blood pressure is sufficient to excrete excess sodium. However, in increased circulating volume patients, both daytime and nighttime blood pressure need to maintain elevated to eliminate this excess sodium. So this abnormal handling of sodium and salt sensitivity can induce nighttime blood pressure increase. And another mechanism, increased sympathetic activation. This is the study that showed a riser pattern or non-deeper pattern patient had more increased sympathetic nervous system activity. It is measured with peroneal nerve activity. As you can see, riser pattern or non-deeper pattern had more higher sympathetic activity. And this is an interesting study about the increased sympathetic activation can promote nighttime blood pressure increase. This is the post-hoc analysis from Simplicity study in US and Japan. They analyzed ABPM data, which was composed of 500 patients. They performed renal denervation for these uncontrolled hypertension patients. And they follow up 6 months change in systolic blood pressure. As you can see, morning BP and nighttime BP, daytime BP all decreased more in renal denervation patients. And the decreased amount was prominent in nighttime blood pressure. From this result, sympathetic nerve activity can very associated with nighttime high blood pressure, and it can be a therapeutic target. So I want to discuss the potential heart failure treatment, which can reduce nighttime blood pressure. As you can see, there are many types of heart failure medications, which is a new drug. For example, angiotensin receptor, neprilysin inhibitor, and the famous SGLT2 inhibitor. All of these drugs can be a potential drug for nocturnal hypertension, and ultimately, we want to reduce the incidence of heart failure and progression of heart failure. First, I want to show SGLT2 inhibitor. It is very well-known drug to improve the heart failure hospitalization rate or mortality, and it is very famous drug in many clinical trials and real-world studies. And it is well-known for the mechanism of the drug because it can have a diuretic mechanism, and diuretic mechanism and salt sensitivity or arterial stiffness, sympathetic nerve activity, all can be a target of SGLT2 inhibitor because it has been known to have a pleiotropic effect. So it is a potential drug for nocturnal hypertension. So we can see a study. This is a SACRA study conducted in Japan, enrolled 130 elderly patients, and they were randomized to empagliflozin or placebo drug. They were all type 2 diabetes and uncontrolled nocturnal hypertension. After 2 weeks, daytime blood pressure and 24-hour blood pressure was significantly reduced after the treatment in empagliflozin treatment group. And the nighttime blood pressure somehow decreased, but the clinical significance was not so significant. So the question to SGLT2 inhibitor can induce nighttime blood pressure reduction, the answer is not yet. Let's look at another drug, ARNI. It is a promising heart failure drug, and this is the parameter study conducted recently, and it enrolled the patient with in 12 countries, including Korea. And they elderly systolic hypertension patients were randomized to ARNI or olmesartan-based hypertension treatment. After 12 weeks treatment, systolic blood pressure was more significantly reduced in ARNI patients, and the nighttime blood pressure was more decreased in ARNI patients. So it can be a potential drug for nighttime blood pressure reduction therapy. And this is another option. As I said, renal denervation have several studies which investigated this use of technology in patients with heart failure. This study is a recent study that showed the potential benefits of renal denervation, that anti-proBNP level was reduced after the renal denervation, and the NIHA class was improved, and stroke volume or another diastolic parameter was improved after renal denervation, so it can be potential treatment. What about the hypertensive treatment itself, targeting nocturnal blood pressure? As you all know, hypertension and heart failure is very prevalent, co-prevalent, but there is no optimal target of blood pressure in heart failure patients, regardless of HFrEF or HFpEF. I will show you Dr. Cario's suggestion. First of all, we can control the morning or daytime hypertension, and there are many ways to control the nighttime blood pressure with the specific treatment for each clinical scenario. The patient with higher circulating volume can be treated with ARNI or SGLT2 inhibitor, or patient with high sympathetic activity can be treated with renal denervation. It is just a potential treatment. The ultimate goal is the reduction in incidence of heart failure or progression of heart failure. And this is another interesting study. The time study, which was presented this year, Barcelona. Evening dosing or usual dosing of antihypertensive treatment, is there any difference? The result was no. There was no difference of cardiovascular events according to the timing of antihypertensive treatment. I want to summary. A non-dipping or riser pattern in the tipping pattern is significantly associated with heart failure risk, especially in HFpEF. So ABPM data in patients with heart failure is very important, but if we do not pay attention, we cannot know the masked, uncontrolled nocturnal hypertension in this population. Nighttime blood pressure is an important therapeutic target, and there are many potential treatments. And for this, additional research is needed to determine whether these use of strategies will improve heart failure outcomes. Thank you for it.
Thank you, Dr. Jones. You will summarize the mechanism of non-differ BP and provided promising BP drug in patients with non-differ. Let's start it with panel discussion. We have 4 excellent panels. Kim-Mina, Ugyuchul, Kyosung-woo, Horan, please.
Hello, I'm Ranho from Hanyang University. I have one question to Professor Kamaport, and I really enjoyed your lecture. Thank you. And I agree with you that assessing frailty is really important, especially in elderly with comorbidity patients. And I also agree that checking how patient walk is important, but is
sometimes hard to standardize between physicians. So there are some attempts to analyze their muscle and fat from bioimpedance analysis these days. Do you think that is also we can use in assessing frailty?
It depends on the time that you got for every patient. I mean, with that, in the clinical scenario that most of us have, with a number of minutes that is limited for every patient, I thought that clinical frailty scale is a very simple way to determine it. If you got enough time and you got the measure, for example, we make muscle mass determination by BIA, by bioimpedance. We make also gait speed. We make a multi-domain determination, making some scale like Montreal Cognitive Assessment and activities of daily living, and having also education of the patient. As much as you can do is better for, as you said, recognizing the real scenario, because clinical frailty scale has high specificity, but it's not so sensible to determine all the areas. I totally agree with you.
Thank you.
Thank you. Thank you for your nice talk. I have also a question to Professor Papsky. You know, the most of recently used the heart failure medication is ARNI, and ARNI is the very strong blood pressure lowering effect. So, do you have any different BP target goal in heart failure patient according to frailty? I mean, do you have shared have a higher frailty? Do you use the reduction of the dose of ARNI or something other medications? Do you have can you share your experience of the heart failure management in the frailty patient?
Yes. Our patients with heart failure, the patients that I treat have a mean age of 83 years old. So what we usually do, we have, so we call it day hospital, where they come, they can come every day. So we follow the recommendations from Giuseppe Rossano at the position paper. If they have a blood pressure value that is below 100, we don't initiate until we have the safety to be above 100. So if there are above 100 of systolic blood pressure, we can initiate that, but you have to be sure that there is the real blood pressure. We can take into account that elderly people, at least our data in Spain showed that half of them have white coat blood pressure. So usually what we do is to perform an ABPM to be sure which is the real blood pressure. And then we stop it when they go below and have symptoms. If they don't have symptoms, we take care and go slowly increasing the medication. But as you said, it's a very complicated situation where you have to be cautious and go slowly then in younger patients.
As long as you're in front of the mic, welcome back to Seoul. I really enjoyed your talk on frailty and heart failure. I just have a short question. So you've shown us that frail patients have worse outcomes when they have heart failure, well, even without heart failure. Do you think this is just a phenomenon to these frail patients, because they're frail, they're having worse outcomes, or do you think if we could reverse this frailty, will they have better outcomes, and what kind of measures would be possible? Well, one thing I'm thinking of is maybe cardiac rehabilitations may help them. So do you actually incorporate this in your clinical practice?
Yes, I think that is a very interesting and intriguing question, because there is a lot that we don't know. We know that they have arrived to a frailty status, but we should know how we can measure which frailty is reversible and how can we do it. Because there are simple measures and intervention that can reverse frailty, but those are the most difficult to take into practice, that are a nutritional assessment, and as the panelists before said, we have to take into account how the muscle mass is, and that is sometimes complicated to know. We have to do certain nutritional intervention and exercise. We don't know which kind of exercise, if it is high intensity exercise or aerobic exercise. And most of all, we are not trained to prescribe exercise. So it is a very open question, and in the future we should have a more questions on that, and we can solve this question.
I'm Mina Kim from Korea University. I have two questions to Professor Chin-Sung Park. It is different about the influence of BP variability between the HAP or HAP-LAB. I think the several mechanism you showed to us is closely related to develop and the worsening of HAP. So I think the impact of BP variability might be larger in the to develop in HAP patients. So what do you think about that?
Yes, as you mentioned, so many data are already reported that HAP and HAP BP variability. So less data were shown. The BP variability reduced the HAP value reduced the exacerbation, but more data should maybe needed to confine this relationship, but more prominent because of their pathophysiology, the HAP is more closely related with the BP variability.
And another simple question is, Dr. John showed the effect of SGLT2 inhibitor and RNE improved the nocturnal hypertension. And how about this drug affect the BP variability? Is there any data?
Yes, many data, because BP variability is closely related with the RAS system activation. So ALB also, they are decrease the BP variability, and of course the calcium channel blocker is a more prominent effect on the BP variability, but RAS system activation is also one of the pathophysiology of BP variability. So RAS blockade is one of the mechanism of the prevented BP variability.
Yeah. Thank you.
Professor Park, I think, which one do you think has the most severe target organ damage, large BP variability or mean BP elevation in hypertension patients?
It's a really important question, I think. But anyway, many data are mean BP elevation is closely related with the target organ damage. So compared with the mean BP elevation, so BP variability has less evidence to prevent the heart failure. So first the target will be the mean BP control, and then we should focus it to the BP variability, I think.
In addition to Dr. Kim's question, I would like to ask to Dr. Bag and Dr. Zhang. We have the data that the BP variation is related with adverse cardiovascular outcome, especially development of heart failure. However, there are many kinds of BP variation parameters, and we don't know short-term and long-term BP variation, which is more important. I mean, short-term is tight time, long-term is visit to visit, such as season-to-season variation and so on. So what do you think about what kind of BP variation parameter is important in clinical practice? Dr. Bag or Dr. Zhang?
There is not yet have a comparison data about the short-term BP variability and long-term BP variability, but just the BP variability can cause the target organ damage, but in a clinic, we can check the BP variability, easily check the long-term BP variability. For example, the visit-to-visit variability is more easy to the clinician. So I think in the clinical situations, the long-term BP variability is more benefit for the prognosis factor or other things. Okay.
What about Dr. Zhang?
Thank you for your question, but I don't think I can answer completely, but my opinion is that the difference of BP variability and the dipping pattern is that we cannot know the long-term variability and the short-term variability difference, but we can assess just dipping pattern, just one-time measure of ABPM data. So we can characterize whether the patient have a non-dipper pattern or dipping pattern. So yeah, that's my opinion.
Do you usually prescribe ABP for heart failure patients to detect non-dipper patients?
Excuse me?
Do you usually prescribe ambulatory BP monitoring in patients with heart failure for detection of non-dipping pattern?
Actually, I do not prescribe all the heart failure patients, but if the BP variability is highly suspected, or patient complain with the orthostatic hypotension symptom, I usually prescribe ABPM in my clinic.
Yes, now we have time to close this session. Before closing this session, we will present plaque of appreciation to Professor Kamaput. Professor Kamaput, please proceed forward.
Good morning, everyone. Welcome to this session. The topic of this session is what clinical characteristics should be evaluated in patients with masked hypertension. I am Dr. Jong-Moo Park from Ulju University, Korea. My co-chairman is Dr. Hae-young Lee from Seoul National University, Korea. He will join here shortly after. It is an honor for me to have the opportunity to moderate this important session. I'll chair the first two talks, and Dr. Lee will chair the last talks and panel discussion. We have 4 excellent speakers about this talk. I would like to invite the first speaker. The title of the first talk is Masked Hypertension in Clinical Practice. This talk will be given by Dr. Sang-min Park from Ulju University, Korea. Dr. Park, please. Oh, okay. Yeah, he's not here. So the okay. Yeah.
Thank you, Chairman. Thank you for having me. I'd like to talk about the screening and management of masked hypertension. This is my agenda. I show you the definition of masked hypertension, especially the masked uncontrolled hypertension and clinical significance MOCHI. Then we'll discuss about who should be screened for MOCHI and how can you manage the MOCHI. Hypertension is the most representative risk factor and the risk factor in the cardiovascular continuum like this. There are various hypertension criteria in Korea and US and Europe and Japan. In Korea, this 140 and 90 is based on the office blood pressure monitoring. How do you think about the real baseline BP? I agree to the agreement of Langton's blood pressure points, 150, 75. This is my first part. What's the masked hypertension and clinical meaning of the masked hypertension, especially focused on the place and the white effect. There are various blood pressure monitoring devices, and this is measured in the in versus out of office. In office blood pressure is like this, and out of blood pressure means ambulatory blood pressure monitoring, and home blood pressure monitoring, and self measurements. The 24-hour ambulatory blood pressure monitoring is representative and the gold standard of out of office blood pressure monitoring. From this, we will get the data, the clinical blood pressure, daytime, and home blood pressure, nighttime, and variable blood pressure. How about there is a discrepancy between the in and out of the office blood pressure monitoring due to the white coat and mask effect. So current guidelines recommend the out of blood pressure should be performed before the treatment of the hypertension. I show you the definition of the masked hypertension according to the office and out of blood pressure monitoring. For daytime, the masked hypertension is defined in treated individual on office blood pressure less than 140 for 90 millimeter mercury, and out of office blood pressure of more than 135, 85 millimeter mercury. In treating hypertensive patients, a masked uncontrolled hypertension, I refer the MOCHI, is implied that the further treatment is necessary for the optimal blood pressure control. In COVID era, mask is essential necessary. This is a webtoon in the internet. So the like this. So we call it the magikun. Magikun means markfish. Is referred to when someone wearing the face mask appear to be more attractive with, and than they are without it. So this is published in the cognitive research. It's very important with the effect of the mask. Some people is suffer from the mask victim like this. How about the hypertension era? We should pay attention to mask effect. This is my real face. How do you think I am Magikun or Magaheja? I think the masked hypertension is something like markfish and Magikun like this. So this slide shows the diurnal marked hypertension classification and their courses. This classified that there are morning hypertension and the daytime hypertension and nocturnal hypertension according to their time sequence like this. You know, the white coat hypertension patient, they are safe, but data shows that their cardiovascular mortality is higher than the normal person, like this. How about the masked hypertension patient? They are real safe, but clinical outcomes like MH shows like this. Their cardiovascular event more than twofold compared to the normal intensive patients. Another data shows that the risk of cardiovascular and the stroke in the pre-hypertensive people with the MH approximately doubled compared to the normal intensive people like this, stroke, and especially we focus on the stroke. Untreated hypertension and treated masked hypertension was described in the IDACO database. There are increased cardiovascular risk in both the MOCHI and the untreated MH patients compared with the treated and untreated normotensive patients. MH is very prevalent in diabetic patients like this. And how about the proposed value of MOCHI? This data shows actually there are 6 meta-analyses. This point of plot shows the overall adjustment hazard ratio was 1.8 for MOCH versus chronic hypertension. The masked nocturnal hypertension is another point. We look over this nocturnal hypertension, but the masked nocturnal hypertension and compared to the sustained hypertension, the masked nocturnal hypertension group had a higher incidence rate of the total CVD events compared to the control BP group. And with adjustment to the covariate, both the masked nocturnal hypertension and the sustained group has greater risk for the total cardiovascular event. How can we screen the masked hypertension patients? I'm going to show the prevalence and the predictor. The MOCH in Spanish registry like this. Actually, the treated blood pressure patients, the Spanish registry shows the 31% of the total hypertensive patients. And the MOCH was inversely related to the younger age and higher in male, a longer duration hypertension, and obesity, smoking, and diabetes, and higher clinical blood pressure. This slide shows a general mechanism leading to the masked hypertension, especially the environmental cause. Is almost all like this. Failure to achieve the sleeping and the sleep apnea, and blood pressure in office is usually decreased because the postprandial reduction in elderly patients, and high salts. And some subject is to the mental stress work at home, and elevated blood pressure ambulatory monitoring during the stressful circumstance, and smoking and alcohol, and sedentary and poor exercise tolerance, heavy upper body isometric exercise, and another men and advanced age, like this. So how about the metabolic syndrome is a representative the patient group of the sleep apnea. This is in Korean data. they show there are higher incidence of masked hypertension in obstetric sleep apnea with the metabolic syndrome like this. Another course is subject's personality. In some data, the patient with the consciousness to the physician, they shows the masked uncontrolled hypertension, like this, 70%. In Hanyang University, Hyunjin Kim and Jino Shin shows the much registry in Korea. In their data, the prevalence of the mochi is 45% like this. Mochi was the more frequent in patients with high systolic and diastolic blood pressure. The frequencies of mochi did not differ according to the number of the antihypertensive drugs. However, when the SBP was more than 130 mercury, the frequencies of mochi increased with the increasing number of the antihypertensive drug in the Korean mochi data. They shows the risk factor like this. Antihypertensive drug number is decreased, and the office blood pressure and ambulatory blood pressure and BSA. Another one is another part is male sex and waist circumference, alcohol drinking. They modified the predicting score to mochi like this. It's a point system. A nomogram of the scoring system predicted the masked uncontrolled hypertension. My last part is how can we manage the mochi? I will focus on the home blood pressure monitoring. I cannot stress the home blood pressure enough. In the public, the home blood pressure monitoring is well aware to the primary physician, but as you know, we needed to improve the public awareness of the importance of home blood pressure monitoring. Home blood pressure monitoring is composed of self-measure and recording, and we should do the feedback like this. First, measured in home, and then recording, and we just shoot the feedback the patient recorded. In some case, during the nighttime nocturnal blood pressure monitoring, some device is helpful for the measure the nocturnal much patients like this. So this table shows the comparison of current blood pressure monitoring modalities. We should emphasize the home blood pressure monitoring. They can remove the white coat and masking effect, like this. So I'd like to summary my talk. There are some take-home messages I hope you remember. First, what's the masked hypertension or masked uncontrolled hypertension, MOCHI, is defined as a normal blood pressure and elevated blood pressure out of office reading measured by the home BP and ABP. Then, what's the clinical significance of MOCHI? Were associated with higher rates of the cardiovascular event mortality than in those with normal tension. Third part, who should be screened for MH or MOCHI? High normal office blood pressure in a young consciousness male with alcohol drinking is likely associated with MOCHI. Then, finally, how can we manage the MOCHI? In higher risk of the individual with MOCHI, a prompt screening and with ABP, home BP should be performed and proper treatment initiated to mitigate the future adverse cardiovascular event. And finally, I'd like to introduce the blood pressure monitoring for the patient-centered care by home BP monitoring and reporting to the physician would be greatly helpful. Thank you very much.
Thank you, Dr. Bak, for your nice talk. We have the panel discussion time at the end of this session, so please hold your question at the time. Let's move on to the next talk. The second talk is the alcohol, tobacco, and masked hypertension will be given by Dr. Gyuchul Oh from Catholic University, Korea. Dr. O, please.
Thank you for the introduction. I think yes, thank you. I was asked to give a talk about alcohol, tobacco, and masked hypertension. So Dr. Park gave us why we should look for masked hypertension and masked uncontrolled hypertension. And I'm going to talk about some subgroups, especially patient factors related with this problem. And that will be alcohol and tobacco. So my disclosure, so I'll be talking about alcohol and tobacco and its association with masked hypertension. So first on, I'd like to say something about the difficulties in assessing drinking and smoking. So I'm not really an expert in smoking. I have smoked before, but not now. I do believe I drink pretty much, so I might be a little bit expert on that. But it is very hard to measure the quantity and the quality of drinking and smoking. So for drinkers, there may be individuals who do not drink at all. There may be individuals who drink every day. There is a very wide gray zone in between. And the amount of drink you drink is, it's very common to talk in how many bottles of soju that you might drink. But when we put this into a clinical and a medical matter, we use the standard drink or the unit of alcohol. But even these definitions are not really homogeneous between studies. So it's very hard to measure the quantity and quality. And also for smoking, there are current smokers, ex-smokers, non-smokers. Ex-smokers may have smoked a lot. Ex-smokers might have only smoked a little. And we do have pack years, but 60 pack years does not mean 1 pack per day times 60 years. It may be 3 packs per day times 20 years, and I don't think that will have the same impact on the blood pressure. And the other thing, furthermore, we're not sure if the patient is telling us the truth. Is he really a social drinker? Isn't he a heavy drinker? Isn't he an alcoholic? I would tell people that I drink a little less than what I really drink. So it's not really, we need to there is no really correct specific way to assess these patients' drinking and smoking habits. And these are not also very consistent among patients, individuals. We might have a time when we are drinking every day. We might have a time when we're not drinking at all. And it's all in the same individual. So it's very difficult to assess. And all these studies that I'm going to show you, they have a very vague definition of drinking and smoking. So as I said, 1 standard drink, 1 unit of alcohol. There are so many alcohols to drink, and it's very different. It may be 14 grams, 8 grams. More. Even the standard drink is some studies that definitions have 10, some have 14, so it's not very easy. The way the alcohol induces blood pressure elevation is very complex. It is said to have, it might activate the sympathetic nervous system, the RAS system, the influx of intracellular calcium. They all have shown to increase blood pressure in vivo and in vitro. The role of the central nervous system is also in play here, but there are studies that not alcohol itself, but the way that people do not take alcohol before they're having their blood pressure checked. That's like before coming to the hospital, they are going to have a time of fast, or they'll want to have a healthy. They want to make themselves a little bit more healthy before they come to the hospital. So the alcohol withdrawal itself might increase the central nervous system and have an increase in blood pressure. So there has been a lot of studies that have shown that in consuming alcohol increases blood pressure. So this is for us community-based health checkup data of about 87,000 patients, individuals in the US. You can see here that as the increase in alcohol consumption is related to increase in blood pressure, regardless of the racial ethnicity. So there's a pretty much linear association between alcohol consumption and blood pressure. And as Dr. Park said, masked hypertension. So in a study about 1,800 normotensive patients who were followed up for 3 years to see if they had hypertension or not, the prevalence of masked hypertension was about 10% in this study. You can see here that in patients with at least one day, when they drink alcohol at least 1 day or more, they will have a higher risk of having masked hypertension. If they drink every day, 6 or more days, they do have a higher risk than that. And also for smoking, which I'll be talking later on in my talk. This is the Home study, Finland's Health 2000 study, which enrolled about 1,500 untreated individuals who are not treated for hypertension. You can see here that for patients with masked hypertension, the prevalence of current smoking and excess alcohol consumption is the most highest. This is even more higher than those with sustained hypertension. It's a very significant increase in this prevalence. And when you use this data to look for the factors independently associated with masked hypertension, you can see here that after a multivariable analysis, current smoking and alcohol consumption is actually significantly, it significantly increases the individual's risk of having masked hypertension. So then what about those already being treated for hypertension? So we're talking about much here. The Jichi morning hypertension research from Japan, about 1,000 patients who are on hypertensive medications. You can see here that the clinic blood pressure is normal. It's under 130/85. So these are normal patients who are seemingly having controlled hypertension. But if the individual is drinking alcohol regularly, he has a higher risk of having uncontrolled masked hypertension, much. So even after multivariate analysis, you can see here that drinkers, but not smokers, but drinkers have an increased risk of having masked morning hypertension. We also have a Korean data on that. Dr. Park showed us a little bit on this. It's from the Korean ABPM registry. There were about 850 patients who had much. They were all treated for hypertension, but some of 854 had normal office blood pressure. You can see here that for those with much, there was a higher prevalence of patients who were currently consuming alcohol. I don't know what former alcohol consumption means here, but well, it was also related with an increased risk of having much. But as you saw on the algorithm for the prediction of much, this alcohol intake does not go into play in that time. Now moving on to smoking, I have smoked before, but I'm not really I don't really enjoy cigarettes. Smoking dates back as early as 5,000 BC, so that's 7,000 years in there. It has been rapidly distributed around the world in the 16th century, after Columbus has found the American continent and brought smoking into Europe. So when you burn the tobacco, nicotine, carcinogens, and carbon monoxide, they affect your body. The funny thing is that I never knew this before, but pipes and cigars, they have acidic smoke. So nicotine is absorbed through your oral mucosa, but those cigarettes that we usually smoke, nicotine, they have like an alkalic smoke, and nicotine needs to be absorbed through the lungs. So even though that's why pipe and cigar smokers have a lot more oral cancers. That was a funny fact. So smoking does increase mortality. We all know that. This was one of the first studies that showed that smoking increased death. It was from after World War II in the US, about 200,000 men were followed up for 4 years. And you can see here that there was a higher increased risk of mortality in those cigarette smokers. Mostly were from pulmonary diseases, except cancer, but there was also a 50% increase in heart problems also. And we all know that smoking increases the risk of heart disease 2 to 4 times. It increases the risk of stroke by twice. Even vaping, the electronic cigarettes also have a similar effect in those effects. The way the smoking increases blood pressure is mostly through the activation of sympathetic nervous systems and arterial stiffness. This goes to increase the blood pressure. Hypertension also increases this. It's a very much crosstalk in between a complex lesion. But all in all, we all know that smoking and hypertension, in the end, increases cardiovascular events. So the way we saw that alcohol had almost a linear association with blood pressure. How about smoking? This is from about 30,000 patients in the annual health survey for England. You can see here that this compared to non-smokers, those who smoked, they do not really have a linear association with blood pressure. So there is a very complex association between smoking and blood pressure, and I'll be talking about that. We all do know that smoking increases blood pressure in the acute period. So when you smoke, this was a study done about 30 years ago. I don't think we can do this kind of study in these days. But when an individual was asked to smoke and the blood pressure was taken for 15 minutes after that. You can see here that it's a very acute rise even in the first minute after you smoke in systolic and diastolic blood pressure and also in heart rates. This is after just a single cigarette, and the effect goes on for 15 minutes and more. There's another phase of this study where individuals are asked to smoke about 5 cigarettes in a row, and that effect would go on about 2 to 3 hours. So there is a and when this increase in blood pressure happens, there's also increase in adrenergic hormones such as norepinephrine and epinephrine, which means there is a stimulation of the adrenergic nervous system, which increases the blood pressure. Then how about the effect of chronic smoking on blood pressure, mostly on office blood pressure? This was from about 850 veterans. You can see here that cigarette smokers, ex-smokers, and non-smokers, they were grouped by ages, and you can see this blood pressure here. You can see that for most, in most age groups, especially in the younger age groups, smoking, those who smoked had a lower systolic and diastolic blood pressure compared to non-smokers and also compared to ex-smokers. So there is an acute increase in blood pressure, but the increase in the chronic effect is not so sure. This is also shown in a different study about, I think this was done in Europe. There were about 7,000 women were followed up. You can see here that the smoking rate of current smokers were about 30%. Also, there is a lower value of systolic and diastolic blood pressure, a significantly lower value associated with smokers. So I don't think chronic smoking, we cannot really say that smoking increases blood pressure, but there is a different story to this. You can see here that in a meta-analysis of 28 studies, those with masked hypertension were more likely smokers. So they seem to have a normal office blood pressure, but if you do ambulatory blood pressure monitoring or home BP monitoring, these patients really had masked hypertension. So that's why there seems to be not a really big association with smoking and office blood pressure. Then how about those with smoking, does it affect patients who are already being treated for hypertension? This was a study done in about 600 patients having hypertension and undergoing ambulatory blood pressure monitoring. About 10 to 12% were smokers. You can see here that for smokers, there was an increase, about a 10% increased risk of MUSH in these groups. This was another study done in Egypt. There's not really much data on MUSH and smoking, but about 200 hypertensive patients had a controlled office blood pressure, but when they took an ambulatory blood pressure monitoring, smoking, those who smoked had an increased risk of MUSH. So there must be something going on here. The smoking might increase their home blood pressure, ambulatory blood pressure, or it might decrease the office blood pressure here. So the effect of, there's also a very interesting study on passive smoking on masked hypertension. So this was from 790 never treated patients. All ex-smokers were excluded, so they were very smoke-naive patients. All underwent ambulatory blood pressure monitoring, and a survey was done to see how much secondhand smoke they were being influenced with. And you can see here that duration of exposure and the intensity of exposure, the quantity of secondhand exposure was linearly associated with how much you are going to have masked hypertension. So passive smoking and its intensity had a linear association. This was the figure that Dr. Park showed us. You can see here that for alcohol, patients who take alcohol, they are more likely to have masked morning hypertension. So it's probably it's common. You drink most of alcohol at night. When you get up, the blood pressure goes up. For smoking, it's mostly related with daytime masked hypertension. So as I said, the reasons for normal office blood pressure in these drinkers and smokers. So clinics are mostly smoke-free, alcohol-free zones, so they won't be smoking at that time. And patients tend to adhere to these healthy lifestyles just before visits. That's like patients will not adhere to medications, but they start taking medications a week before they come, so something like that. And patients rarely smoke just before clinic visits. Some patients do smell of smoke, but mostly they just have a cigarette box in their pocket, but they don't really smoke in the 1 to 2 hours before that. And the effect of alcohol on cigarettes and blood pressures may be so that these are the reasons that these effects may be minimized during office blood pressure measurements. And there is also a thing with relatively thin habits of smokers. This is a smoker's paradox and another whole Pandora's box that I will not open. So this all emphasizes the importance of home BP monitoring and ambulatory blood pressure monitoring in these smokers and drinkers. So the recommendations, this is from the 2018 ESH guideline, mostly are the same. It's recommended to restrict alcohol consumption to less than 14 units per week for men. What does it mean? 7 cans of beer, 1 bottle of wine. That's about what you should drink in a week. You shouldn't binge drink, so you shouldn't drink this in one day, and you should have alcohol-free days. For women, it's about half of that. Avoid binge drinking, have alcohol-free days. Smoking should be stopped. Supportive care and referring to a program are recommended. So summary, alcohol and tobacco are both associated with mask hypertension and much. So individuals at risk being treated should be advised to quit smoking and be aware of the secondhand smoke too. And they should also be advised to refrain from binge drinking and have alcohol-free days. Thank you for your attention.
Thank you, Doctor, for your nice talk. I'll hand over the moderation of this session to my co-chairman, Dr. Lee, please.
The third speaker is Professor Kim Hemi from Chungang University. Her title is Obesity and Masked Hypertension. Professor Kim, please.
Thank you for introducing me. I'm Hemi Kim from Chungang University Hospital. Today, I would like to talk about obesity and masked hypertension. What I'm going to talk about today is as follows. As you already heard from Dr. Bang, masked hypertension is characterized by office readings such as normal blood pressure, but out of office reading that are consistently above normal. Since the term masked hypertension were originally defined for people who were not being treated for hypertension, masked uncontrolled hypertension is used for patients who treated hypertension. The prevalence of masked hypertension varies from 15 to 13%, and Korean data showed a similar result. When looking at the prognosis of masked hypertension, the risk of cardiovascular disease and all-cause mortality in persons with masked hypertension is almost similar to those in sustained hypertension. And MUCHI showed a similar result as masked hypertension. The overall adjusted hazard ratio of composite outcome, including cardiovascular and all-cause mortality, was 1.8 for MUCHI versus controlled hypertension. So considering the high prevalence of high CV risk, screening of masked hypertension and MUCH should be done in robust patients. So the guidelines suggest that in population within the pre-hypertensive range, out of clinic BP, ABPM, or home BPM is recommended to exclude masked hypertension. And in patients who treated hypertension and office reading at a goal when they are in the presence of target organ damage and increased overall severity risk, out of clinic BP is recommended to exclude MUCH. Now I'm going to talk about the relationship between obesity and hypertension. Generally, obesity was defined as a body mass index more than 30 kilograms per square meter, but defined as BMI more than 25 in Asian, according to the Asian Pacific criteria. So in Asian, the cutoff value for overweight and obesity are lower than the usual WHO criteria. When you're looking at the obesity prevalence in the US, the obesity prevalence increased gradually, and during the same time, the prevalence of severe obesity also increasing. Although the Asians have a lower rate of obesity when we use the same criteria of BMI, but the increasing trend of obesity is not too limited into Americans, but similar trend is seen in various races. This is the Korean data, and the Korean data also show that the obesity rate is gradually increasing, and this is based on the BMI over 25. And the obesity rate for men reaches about 48%. So now I will talk about the relationship between obesity and hypertension. The previous study showed a linear relationship between adiposity and blood pressure. But not all obese patients are hypertensive. But however, it is clear that excess weight gain shifts the blood pressure frequency distribution toward higher level. In particular, previous studies demonstrate that increased visceral adiposity was robustly associated with incident hypertension. The pathophysiology of obesity hypertension is multifactorial and highly time-dependent. At least three major factors contribute to increased sodium reabsorption and lead hypertension. First, RAS activation, and second, sympathetic activity, increases sympathetic activity, and third, kidney compression by visceral and retroperitoneal fat. First factor is retroperitoneal and visceral fat. Increased visceral and retroperitoneal fat may increase blood pressure by physically compressing the kidney. Excess fat accumulation is associated with increased intrarenal pressure, and this impairs pressure natriuresis and lead hypertension. Indeed, the data from the Dollar Heart study show that the retroperitoneal fat is uniquely correlated with incidence of hypertension. Second factor is RAS activation. Obesity leads to increased renin secretion and formation of angiotensin II. And leptin is also suggested to stimulate aldosterone. So activation of the mineralocorticoid receptor increase and sodium reabsorption in the renal tubule, and it contributes to increase in blood pressure in obesity. And generally, obesity decreases the parasympathetic tone and increase sympathetic activity, so it can cause the high heart rate and high blood pressure. In addition, in obese patients with hypertension, they show the nearly double the risk of the LV hypertrophy, the typical representative of target organ damage of the hypertension. Two conditions are frequently in obesity explain this high LV hypertrophy. First, obstructive sleep apnea, and second is masked hypertension. So then from now on, I'm talking about the masked hypertension and obesity, which are non-causal of the LV hypertrophy in obese patients. This study demonstrates the prevalence of the obesity and the relationship between obesity and masked hypertension. This study includes 251 patients without hypertension. And these studies demonstrate that masked hypertension prevalence is higher in patients with obesity than control group. In addition, according to the subgroup study of the Owasama study, weight circumstance, body mass index, and waist-hip ratio were significantly associated with masked hypertension, particularly in individuals with normal clinic BP. And these results suggest that home blood pressure measurement might be important in especially who are in abdominal obese and for the early detection of masked hypertension. However, recently, the study from China showed that the overweight and obesity were associated with high prevalence of masked uncontrolled hypertension, but not in untreated patients, not associated with masked hypertension. And among treated patients, multiple logistic regression demonstrate that body mass index is determinant for the masked uncontrolled hypertension, but not in untreated group. These results indicate that the clinical BP might be overestimate antihypertensive treatment effect in patients with obesity and overweight. And similar results are shown in various other studies. According to this study, in treated patients, obesity are considered as a risk factor for MUDGE. Then why obesity are associated with MUDGE? It is unclear, but one possible explanation is that clinic BP might be overestimation antihypertensive treatment effects. that is due to the nighttime BP. Maybe nighttime blood pressure control might be the major driving factor. Indeed, previous studies showed that obese patients showed higher nighttime BP and showed a non-dipping pattern. Other possible explanation mechanism is adherence of medication. I'm worried about this is kind of stigma for the obese person, but anyway, the study demonstrates that the patients who are high BMI show the low adherence, drug adherence, after the adjustment. In addition, various pathophysiologic factors associated with obesity, such as renin-angiotensin system, insulin resistance, and sodium volume retention, and renal dysfunction might also render the control of hypertension difficult, especially when blood pressure is measured in an out-of-office setting. On the other hand, there is an opinion that high rate of masked hypertension in obese patients is because of the cup size of home blood pressure measurement is small, considering their arm size. This study insists that use of appropriately sized cups significantly reduce the proportion of masked hypertension in obese patients. And when you're looking at target organ damage in masked hypertension with obese patients, the result is similar in usual general population. Masked hypertension group showed high degree of target organ damage and more severe than normal patients. And so how we treated masked hypertension with obese patients? Treatment is not significantly different for obese patients. Antihypertensive drug up-titration should be considered, and systematic approach of out-of-clinic BP assessment is essential on follow-up and monitoring blood pressure and to respond to therapy. In addition, it is important to lose weight by controlling diet and increasing physical activity. The Mediterranean diet, DASH diet, and intermittent fasting can reduce the blood pressure, and physical activity also affect to the blood pressure. And to summarize, obesity, especially increased visceral adiposity, was robustly associated with incident hypertension, and in obese adults with office blood pressure that are within the pre-hypertensive range, or adults being treated hypertension and office range normal, but in the presence of target organ damage or increased overall CV risk, screening for masked hypertension or MUDge with home blood pressure monitoring or ambulatory BP monitoring is reasonable. High nighttime blood pressure, drug-low compliance, and various pathophysiologic factors are associated with high rate of MUDge or masked hypertension in obese patients. And weight loss strategy is also important to reduce blood pressure in individuals with obesity. And systematic approach of out-of-office blood pressure assessment is essential part of follow-up and monitoring blood pressure. Thank you for attention.
And next, I will introduce Professor Yukjin Chia. It is my honor to introduce Professor Chia. Chia is immediate past president of Malaysian Society of Hypertension, so founding president of Malaysian Society for World Action on Salt, Sugar, and Health. Her title is Blood Pressure Variability and Chronic Kidney Disease. Professor Chia, please.
Yeah, thank you, Hee-Yong, for the introduction. What I'm going to do is talk about blood pressure variability and chronic kidney disease, because most of the talks that we had on blood pressure variability focused on cardiovascular outcomes instead of chronic kidney disease. This is my disclosure. We know very well that patients who start dialysis, the majority of them is due to diabetes, particularly in countries with a high prevalence of diabetes, like my country. I think the majority, 80%, is due to diabetes. And we also know that diabetic patients, 2/3 of them have hypertension. And then we have another further 27% of individuals who start dialysis have hypertension. So all in all, hypertension is very prevalent and it's probably responsible for chronic kidney disease. And so therefore we can see that hypertension and chronic kidney disease are inextricably linked. It is difficult to separate the two of them. And we also know that in a general population, not necessarily a hypertensive or a diabetic population, but in a general population, elevated blood pressure is a major risk factor for both progression of nephropathy and for incident end-stage renal disease. So what my group were interested in was to ask ourselves in daily clinical practice in the real world, especially in primary care setting, what is the development, what's the rate of development of new onset chronic kidney disease in the patients that we are treating? And this was actually a retrospective cohort study, 10 years. We had 460 patients who had hypertension on treatment, but without CKD at baseline. And we defined CKD as an estimated glomerular filtration rate of less than 60 mL per minute. This is the usual sort of age group, a mean age of 55 years, and about 13% were age 65 and over. So over the 10 years, what we see is that the blood pressure was reduced from 145 to 135. Not very impressive figures. So this suggests that nearly half of the patients are still not controlled. What we did see was that there was a reduction of about 12 mils over the 10 years of eGFR. So this means, translated, would be a loss of about 1.26 mils per minute per year. And this is quite high. It's 25% higher than the normal rate of decline with aging of about 1 mil per year. And that brought about new onset of chronic kidney disease in about 31% of patients. So again, this is a relatively high number of people who will proceed to have CKD. And so therefore, the annual rate is 3%. So if you treat 100 patients, you would expect 3 patients over 10 years to develop chronic kidney disease. Fortunately, in my group, there was no end-stage renal disease, and no one went on to need dialysis. We also know that most of the antihypertensive agents, be it ACE or CCB, work very well in reducing major cardiovascular events, both in those who have chronic kidney disease or do not have chronic kidney disease. So therefore, there's no doubt that hypertension needs to be treated whether you have or do not have chronic kidney disease. And this was further emphasized that when we do very intensive blood pressure lowering, you get an even better reduction in cardiovascular mortality than less intensive. Because of this close link between hypertension and CKD, that treatment results in reducing major cardiovascular events, we assume that aggressive lowering of blood pressure reduces the progression of chronic kidney disease. And the evidence that supports the recommendations that are made in all the guidelines, hypertension guidelines, to tell us to lower blood pressure aggressively to slow down progression of chronic kidney disease is actually based on observational studies and secondary analysis of clinical trials. In observational studies, we know that the lower blood pressure that was achieved during treatment resulted in a slower decline in eGFR, and that the reductions in renal events and all-cause mortality was also seen. However, in clinical trials in patients with established CKD, they actually failed to demonstrate consistently that lower blood pressure targets slow down the progression of CKD. And this is illustrated in 2 trials. One is the African American Study of Kidney Disease, the ASK, and the MDRD study, where aggressive lowering of BP to a mean arterial blood pressure of less than 92 millimeters did not show the slowing progression of CKD. So while the slowing of the progression of kidney disease is a critical goal for CKD patients, and therefore we do it by lowering blood pressure, and it is important, it may not be the only target that needs to be addressed. So we need to ask ourselves, is there anything else besides the mean blood pressure that is associated with progression of CKD? Of course, there are many, many other factors that cause a progression of CKD, not necessarily blood pressure. Diabetes is one of the more important factors, and many others. But for today's purpose, I will focus more on blood pressure elements. And this, of course, leads us to the point about blood pressure variability, where I think earlier today we have already seen all the mechanisms, but I'll just go through them very quickly. We know that blood pressure is dynamic. It fluctuates throughout the day, depending on what you are doing. It fluctuates day to day. This is done on one of my patients, where we can see there's lots of fluctuation on a day-to-day basis, and also on long-term basis over years. This is every year's blood pressure variability. So we can see whether it is hour to hour, day to day, or even long-term blood pressure variability exists. And how we monitor blood pressure variability, if you're looking at hour to hour, obviously we need to do the ambulatory. If it's day to day, the home, and visit to visit will be based on clinic measurements. So this is longer term blood pressure variability. This, of course, is beat to beat, second to second, not practical in daily clinical practice. And how blood pressure variability is measured, usually in research, is using the standard deviation or the coefficient variability as a measure of blood pressure variability. There are multiple factors that are involved in blood pressure variability: sympathetic nervous system, humoral, environmental, baroreflectors, and many, many other things. But whatever the mechanism is, and we know that for short term, it's usually the sympathetic system and the humoral system, environmental, that are at play, whereas in the medium to the longer term, it is usually more of aging, increase in arterial stiffness, and even not taking the drugs, not being adherent to the drugs, or the drugs are not titrated. But whatever the mechanism and whatever the type of blood pressure variability, they all cause target organ damage, they all cause an increase in cardiovascular events, and they also cause mortality, and cardiovascular mortality are all increased. Very nicely illustrated is this hour-to-hour blood pressure variability, where we can see that the greater the blood pressure variability, the greater is the likelihood of all-cause mortality, cardiovascular mortality, and all the cardiovascular events, including stroke, including other cardiac events. The day-to-day blood pressure variability has been looked at in the Ohasama study, where the residents were asked to measure their blood pressure for 26 days. That's a very big feat. I couldn't even get many of my patients to do a week's blood pressure measurements. Be that as it may, what was shown is that there was a significant hazards ratio, an increase of 1.27 for cardiovascular mortality, stroke mortality 1.4. And then variability in terms of medium term, this was from the UK TIA study, where the study was not on hypertensive patients alone, but on patients who had stroke or TIA. And what was found is that when they look back at their blood pressures, we can see that the greater the standard deviation, in other words, the blood pressure variability, the greater is the risk of getting a stroke and a TIA. And what was very interesting in this study, I think this was alluded to in the earlier speaker, is that in this group of study patients, even in those without hypertension, which means to say their mean blood pressure was less than 140 by 90, many were noted to have spikes of elevated blood pressures of systolic more than 160. And so this may suggest that it is blood pressure variability that may be causing this TIA and the stroke. And I think in clinical practice, we would have also realized that there are patients who come to you with a stroke or TIA, and they don't seem to have hypertension. So you ask yourself, what's the cause of the stroke? Of course, there may be many, many other reasons. Mass hypertension is one of them. Or it could also be because of blood pressure variability that has caused the stroke or the TIA. We were also interested in looking at long-term visit-to-visit blood pressure variability, because at the time when we reported this, there wasn't much data on this, to look at renal function over a period of 15 years. This is, again, is a retrospective study on 825 hypertensive patients. We took the readings of blood pressure every 3 months from the 15 years record, and we estimated the eGFR at baseline, 5 years, 10 years, and 15 years. And what was found is that the variability, the standard deviation, was actually 14.2 millimeters of mercury, and the rate of decline in eGFR was about 1 mil per minute. And there was a significant relationship between the blood pressure variability and the slope of the estimated eGFR. And this still remains significant after adjustment for mean blood pressure and other confounders. And so this tells us, as again, that visit-to-visit long-term blood pressure variability does impact the way our kidneys is going to decline in its function. Recently, a systematic review also looked at visit-to-visit blood pressure variability and the risk of CKD, and clearly, again, it shows that the greater the blood pressure variability, the greater is the risk of stroke. So I think there's very little doubt about this. And the relative risk was about 1.69 for every 1 unit standard deviation in blood pressure variability. Now, knowing all about blood pressure variability, how can we apply this in clinical practice? What can we actually do about it? I think one thing that we all know is that if you have a low mean blood pressure in treated patients or even not treated individuals, you have lower risk of any cardiovascular event. In this instance, it's the white matter, and here is the infarct. If you have, compared to someone with a higher mean blood pressure. But even amongst those with a low mean, the people who have a high standard deviation, high blood pressure variability, have a much greater risk of any cardiovascular event compared to those who have a low mean and a low standard deviation. And this should bring to mind patients that we see, that this is again 2 patients of mine, where the mean blood pressure was 122.7, 127, nearly the same mean. And yet, if you look at it graphically, I think you don't need to be a rocket scientist to know that this patient has got much higher blood pressure variability than this patient. And of course, this is shown in the standard deviation and the coefficient of variation higher, and therefore this individual stands to have greater cardiovascular risk in spite of having very similar mean blood pressures. And then we also know about the different effects of antihypertensive drug classes on blood pressure variability. One study that compared the blood pressure variability of a RAS blocker, a diuretic, and a calcium channel blocker found that when compared to placebo, the CCB, amlodipine in this instance, was much more favorable in terms of being associated with lower blood pressure variability, whichever time we measure it, whether it's daytime, nighttime, or daily. So therein lies some evidence about the different effects of antihypertensive agents on blood pressure variability. Very nicely illustrated is this individual who we can see very clearly has got huge variations in blood pressure. When amlodipine 5 milligrams was added, immediately you can see that the mean blood pressure has gone down, the blood pressure variability has narrowed considerably, and similarly with the 10 milligrams, mean blood pressure goes down further, and the variability remains very much less than in the early before amlodipine was given. And again, when we look at meta-analysis comparisons of trials that use CCBs in all the different trials versus other agents, the risk of reducing stroke is much better with the CCBs. We know this very well. And we also know that the blood pressures, when we look at the variance ratio, which is also a measure of blood pressure variability, it's all in favor of the CCBs. And so therefore, just to summarize that very quickly, is that the CCBs and the non-loop diuretic have a better favorable profile on blood pressure variability than the other agents. We also decided to look at blood pressure variability in individuals who have mass hypertension. And here, when we grouped our patients into the controlled, fully controlled, the uncontrolled, the white coat, and the mask, very clearly we can see that the blood pressure variability is the highest in those who are uncontrolled. And then the white coat, of course, white coat, that's why they vary, because they are abnormal in your clinic, they are normal at home. And then the mask hypertension. So herein lies some information that tells us that some of these individuals, if I have to decide whether to put someone on treatment, in say someone with white coat or mask, I would then begin to look at other risk factors like blood pressure variability, whether it's increased or not. Your own group in Korea have also looked at the blood pressure variability in patients with white coat as well as mask from your Korean ambulatory data. And again, showing very much the same pattern, slightly different perhaps, that the blood pressure variability is highest in the white coat, followed by sustained mass hypertension, and then the normal groups. So to end, I think we all know that blood pressure variability is associated with an increased cardiovascular events associated with progression of CKD. And the management of hypertension definitely requires controlling the mean blood pressure, but we also need to pay attention to blood pressure variability. We need to pay some attention to the class of antihypertensive drugs that we use. And although blood pressure variability is not currently in the guidelines as a target for high blood pressure measurement, I think it's beginning to be recognized as a potential target for the improved management of hypertension to prevent cardiovascular events, particularly stroke. Thank you very much for your attention.
Thank you very much. Now we have 15-minute panel discussion time. We have 3 panelists, Professor Kim Bong-jun from Kosin University, Kim Hyun-jin from Hanyang University, and Professor Kim Hyung-yoon from Jeonnam University. Please.
My name is Bong-jun Kim from Kosin University. I have one question to Professor Cha. Thank you for your nice presentation. I have one question. As you show the data, there are BP variability in CKD patient, especially the patient undergoing hemodialysis. There are short-term fluctuation in home BP, especially before and after the hemodialysis. We have a concern for the hypotension when we treat antihypertensive drugs in patients with high BP variability. Please comment on how should we interpret their true BP and how we establish the target of a home BP in hemodialytic patient.
That is indeed a very difficult question to answer. We all know that the interdialectic blood pressure is an issue. But I think what we need to think about is what is the main effect of the blood pressure? It is the mean load of it. So the mean blood pressure over 24 hours will give us the mean load. The variability could be in between. So therefore, we also know that those who have good mean blood pressures have lower blood pressure variability as well. So in other words, go for the mean blood pressure first, and then only look at, once you've got the mean well controlled within the range you want, then look at the blood pressure variability. I think in patients on dialysis, it's a very difficult issue. You just have to do the 24 hours, look at it and see where the spikes are and see what you can do about it.
Thank you for your comment.
I'm Hyun-jin Kim from Hanyang University. I have a simple question to Professor Hemi Kim. Central obesity is very important cardiovascular risk factor, and actually BMI cannot reflect the adiposity adequately. Is there any data about the effect of central obesity on vascular hypertension or association of fat distribution and blood pressure variability?
Yes, thank you for your question. As I present in the presentation, the weight circumference and hip waist ratio is also associated with vascular hypertension. And some data show that BMI, it's a little bit different according to the studies. So some data show that there was no relationship between BMI and vascular hypertension, but some data show that BMI and vascular hypertension is associated, and especially the visceral adiposity or abdominal adiposity is more closely related to the vascular hypertension.
I'm Hyung-yoon Kim from Jeonnam National University Hospital. I have one question to Dr. Sang-min Park. Thank you for your generous lecture. And what do you think the reason for the differences in the prevalence of masked hypertension and masked uncontrolled hypertension among studies?
Okay, it's a great question. as you in the point indicated, the prevalence of the masked hypertension and mercury is very various in according to their study style. But I think their researchers have has different blood pressure management guideline based on the office and then out of office blood pressure. Out of office blood pressure usually the ambulatory or home blood pressure. In real practice, ambulatory blood pressure is not recommended for the older patients. So I'd like to recommend the older patients using their home blood pressure monitoring for the patient to screen the masked hypertension. I think the home blood pressure monitoring is a key component of the managing of the hypertensive patient. I cannot stress it enough. Thank you.
Then how do you think about the wearable device?
Yeah.
The effect of a wearable device?
Actually, it's a very interesting question. I think the wearable device is out of my expertise. So how can I take over the mic to the Professor Lee? He's the main writer of the clinical hypertension white paper. Can you?
Yeah. A smartwatch wearable device blood pressure measurement may be certainly the way we should come, and the future will come regardless of whether we accept or not. But the problem is we have scanty of data among hypertensive patients. The Samsung Galaxy data, the data is quite reliable in the normotensive range, but over 135 millimeter mercury, or not 150, 135 millimeter mercury, the line begin to deviate in the lower portion. And the low diastolic blood pressure, there is also deviation of blood pressure compared to the standard blood pressure measurement. So certainly it is not applicable for hypertensive patients until yet, but our society thinks we should more positively approach and gathering data to expand the function among hypertensive patients. It is my opinion. And let me ask one thing, Professor Chia. I absolutely agree with your opinion. Your lecture, blood pressure variability is important in clinical management. But the problem is we don't have a normal range of blood pressure variability. So how can you apply blood pressure variability in your clinical practice?
Yeah. As I said, the first thing I do is get the mean blood pressure in place first. That's the most important thing for reducing cardiovascular events. Once I've got the mean in, then I begin to look at other risk factors, and one of them will be blood pressure variability. We do not have what is the normal, so-called ideal blood pressure variability, because there's actually no data and not big enough like the Mr. Fit and the Framingham that tells you at the blood pressure of 140, there's an exponential rise in cardiovascular events, and that's why we choose 140 over 90 as the cutoff point for diagnosis of hypertension. Similarly, BPV is like that. It's not going to be a flat, a straight line, but a curvilinear. So we don't know where the cutoff point is. My own guess is around 7. Anything more than that probably isn't very good for you. But I'm basing it on data that I see and look at the rise in events, because I showed you just now the cardiovascular events that you see also a sharp rise at a certain variance. So that is roughly the point that I think we should be more aggressive in trying to tackle the blood pressure variability. So there is actually no data. There is no outcome data as well. People are looking at trying to use intervention in terms of drugs, comparing the drugs on blood pressure variability, but I don't think there's been any outcome yet.
Thank you very much. We have 5 minutes to discuss and question from the audience. Is there any comment or question from the audience? Okay, then before we wrapping up this session, we hope to present our plaque of appreciation to the Professor Chia. Professor Chia, please proceed the podium.
Good morning, everyone. I would like to welcome you all to the plenary session on the Hypertension Seoul 2022. I'm Professor Sang-Hyun Nim, the president of Korean Society Hypertension. It is a great honor to introduce Professor Reynold Hugo Gruch. Actually, Professor Gruch had completed his training in internal medicine and clinical pharmacology in Cologne, Bonn, Heidelberg, Boston, and Berlin. Now he is the director of the Department of Clinical Pharmacology and Toxicology at Charité Universität Medizin, Berlin, Germany, and professor of hypertension clinical pharmacology. His main research interests include clinical pharmacology of cardiovascular drugs, clinical experimental hypertension with a focus on genomics of hypertensive target organ damage, pharmacogenomics, and drug therapy in the elderly. The Professor Gruch is actually editor of blood pressure and an editorial board member of the Journal of Hypertension, Journal of Clinical Hypertension, High Blood Pressure, and Cardiovascular Prevention. And he is immediate past president of the European Society Hypertension. Now, today, his presentation title is Renal Protection Matters in the Management of Arterial Fibrillation. Professor Gruch, please.
Dear Professor Im, dear President, dear colleagues and friends from the Korean Society of Hypertension, it's indeed a great pleasure and honor for me to join your exciting meeting and to talk to you today. So why should we care about the kidneys and atrial fibrillation? I will try to discuss this with you and also discuss how anticoagulation actually affects the kidneys. But because you have been so generous to me to giving me quite some time, and this is a hypertension meeting, also I will start to give an update also on blood pressure monitoring, blood pressure phenotypes in atrial fibrillation and the important role of overall blood pressure control in atrial fibrillation. So I will start with the first topics related to blood pressure measurement. And we have heard a lot exciting data and discussions about blood pressure variability. Certainly, this applies to atrial fibrillation. If even more so, if you look at this nice graph here from George Stajou, who is the was the lead of the working group of the European Society of Hypertension on this topic. You see on the very left sinus rhythm, and you see the beat-to-beat blood pressure variability in intra-arterial blood pressure measurements. And if you look to the right, you see the higher variability beat-to-beat. That is also important for blood pressure measurement because if you use automatic oscillometric measurements, which we can do now, I will come to this later, there's a preference to pick up the higher levels and thereby you may overestimate the blood pressure you measure with the oscillometric devices. So if you look into our guidelines, there's a note of caution that additional blood pressure measurements may have to be performed in patients with unstable blood pressure values, such as in patients with AF, in whom manual, the old method, auscultatory methods, should be used as most automated devices have not been validated. Now, in our recent paper where we recommend for practical use several issues and address several issues, there's also one statement that selecting reliable devices is very important, and we should not confuse this. There are devices that we can use, oscillometric devices, to detect in an opportunistic way atrial fibrillation, and they have been approved or validated, but still, unfortunately, there are no validated devices to measure and monitor blood pressure and atrial fibrillation with oscillometric devices. If you go to the website of Stride BP, which is very important, you find the resources, all the devices, and you look for atrial fibrillation, you don't find anything, and there's also nothing recommended actually so far. That's still an ongoing unmet need for research and clinical research and validation. And I know the team with Professor Day2 is working very hard on this to try to address this issue in the future. If you look, for instance, the British, Irish Hypertension Society, they recommended some and discouraged some devices which are inaccurate, but officially no validated devices yet. Nevertheless, you know, I'm not an expert, but Professor Day2 and the working group, they are experts. They at least recommend that we should use triplicate measurement on each occasion, particularly in those patients with atrial fibrillation, and that several automated electronic oscillometer devices have some reasonable accuracy, particularly to measure systolic blood pressure, which is very important. Therefore, we can also use them potentially for home blood pressure measurement and ABPM in these patients, particularly if the AF patients are stable. So this is, I think, very important. Now, the overall risk is important in patients with atrial fibrillation. Blood pressure lowering, also pharmacology blood pressure lowering, is very important and beneficial, has been also addressed by the blood pressure lowering treatment trialist collaboration. And the most important actually finding, again emphasizing the high risk in patients with atrial fibrillation is shown here in this Kaplan-Meier curves, the cumulative incidence of MACE, stroke, ischemic heart disease, and heart failure. Apologies for the typo, something is missing here in my text. But you see the patients with no atrial fibrillation, RCTs, and the patients with atrial fibrillation in RCTs, you see the higher, or about twofold higher risk in the patients with atrial fibrillation for MACE. So these patients are at very high risk. If you compare the red lines with the darker bluish black lines, you see also that in these trials, the intervention introduced some benefit in these patients, both patients group obviously, and that was a matter of, of the analysis and the BP LTTC collaboration. However, I would also like to inject a note of caution here into this meta-analysis by the BP LTTC team. Recently, they claimed that blood pressure lowering drugs could be actually used in individuals with systolic blood pressure even lower than 120 millimeter mercury up to the age of 84 and irrespective of presence of cardiovascular disease, suggesting that if you use blood pressure lowering drugs and you lower blood pressure by 5 millimeter mercury, you get a benefit in almost every adult individual around the world. And we criticize this for many reasons from the methodological point of view and rejected this hypothesis. Even the hypothesis that has been put forward in editorials that the definition of hypertension should be also abolished because based on this data. Now, coming back to the potential to use oscillometric devices and to do home blood pressure measurement, and there's a very important study, large study from Professor Cario in the ANAFI, the All Nippon AF Elderly Registry, elderly patients over 75 years, a huge, very important study. And in this number of patients, 32,000, he in a certain number of patients with his team could also do home blood pressure measurement. The mean age was 81.5 years. Majority were anticoagulated, and they measured home blood pressure with oscillometric devices that were not specified, to my knowledge. So, and they also could address, therefore, the question how these blood pressure phenotypes apply to these patients with AF, the elderly patients. And actually what they could show, as shown in this slide, there is some patients, as we might expect, with white coat hypertension, sustained hypertension, well-controlled hypertension, but particularly also masked hypertension quite frequently, particularly masked hypertension in the morning, up to 26.9%. So the question is whether masked hypertension in AF patients also impacts on the risk. And very recently, they published the data. First of all, I would like to mention that the risk factors they also identified in this registry is that the prevalence was very high of masked uncontrolled morning hypertension in patients, the elderly patients, as I mentioned already, current smoker status was important, diabetes was important, COPD patients, but also patients, which I obviously will address in my presentation as well, with CKD or decreased renal function. And now just recently in hypertension, they published the outcome data in this observational registry and showing that home systolic blood pressure was associated with all these events, the net cardiovascular outcome, major bleeding, stroke, and also all-cause death, in a way that this smaller group of patients in the overall cohort of patients where home blood pressure was available, only 440 patients, but still those that had home blood pressure above or equal 145, you see a significant increased risk for all these outcomes. Also, again, a note of caution, it could be reverse causality, coming back to lowering blood pressure even below 125 in home blood pressure. There seems to be, again, here also a U-shaped or J-shaped, U-shaped curve in the way that the lower systolic home blood pressure is also associated with higher risk or higher all-cause death or mortality at least. There was no relation with office systolic blood pressure. You see all these patterns. No significant association was found with office but home blood pressure. Again, with the exception that all-cause death was increased in those with lower office systolic blood pressure below 130 millimeter mercury in AF patients. Again, a note of caution, lower blood pressure could be associated with mortality. If they calculated the hazard ratios in relation to home systolic blood pressure, you can see again the finding I have shown to you already, increased hazard in those patients with elevated home systolic blood pressure in atrial fibrillation. So masked hypertension might be important, and home blood pressure monitoring very important in patients with atrial fibrillation. Again, this confirmed hazard ratio is also supporting a J-shaped or U-curve for all-cause mortality. This is an important study from your country, Korea now, in anticoagulant-naive AF patients, a huge population-based study looking into the risk of these AF patients, not yet anticoagulated, and with regard to hypertension status, and you see for stroke and also intracranial hemorrhage, which is very important, those with hypertension, blood pressure 140/90 over or higher, you see the increased risk, while at the lower end there is no significant difference in the range between 120/30 or even lower. So, but clearly, hypertensive patients with AF are at high risk for both stroke and also intracranial hemorrhage, which is not surprising, but again, also with lower blood pressure, higher risk or the incidence of death from all causes was higher in those patients with low blood pressure below 120/80 millimeter mercury. So how about now anticoagulation? The problem is obviously we need to control blood pressure, but we also have a risk potentially for intracerebral bleeds. We know, if we look at the bleeding risk of the patients with atrial fibrillation, we have the Hess-Bled score, that hypertension, as it has been actually identified in the Hess-Bled score, systolic blood pressure above 160 millimeter mercury is a risk factor for bleeding and is an important modifiable factor by controlling blood pressure to reduce the bleeding risk, for the risk for major bleeding events. In addition, with modification of drugs intakes, in this case it's alluded to or to anti-platelet drugs or NSAIDs, and alcohol use. So these are the modifiable risk factors for bleeding we can address in clinical practice. So, and therefore, we were very excited when we had and focused for many years, for 1 decade, on the development of new oral anticoagulants, NOACs or DOACs. And the major benefit, as shown in the meta-analysis of the pivotal trial, was that not only all-cause mortality was reduced, but also intracranial hemorrhage is reduced. And that's the reason for the 1A recommendation in preference of the NOACs. I think one of the reasons to start with NOACs these days, when you start treatment in patients with atrial fibrillation, that the risk for intracranial hemorrhage is reduced almost by 50%. Nevertheless, it was somehow forgotten, and Professor Manolis, who is with us also in the room, pointing out that in these trials, we somehow, because of potentially the excitement with the NOACs, have forgotten to look into the blood pressure issue, and we have forgotten to control also maybe blood pressure within even the trials. And also, surprisingly, actually blood pressure levels were not really reported consistently, the measurement, how it was measured, and how blood pressure was, or hypertension was treated was somehow forgotten. And in a subsequent analysis also, George Day2 looked at all these studies, and you see blood pressure was not appropriately addressed in many of these trials, or not even considered in the trials. But nevertheless, if you look into elevated versus low blood pressure as available in these trials, you see that those with uncontrolled blood pressure or elevated blood pressure in this meta-analysis in the forest plot have a high risk for stroke and systemic embolism. And we knew already from a post-hoc older analysis of the SPORTIVE trial from Greg Lipp and his group in 2007 reported, SPORTIVE was this trial there where ximilegatran, the first oral anticoagulant, was tested, that those patients, when they looked at blood pressure, dissected the blood pressure in quartiles with the higher blood pressure, the highest quartile, basically patients with hypertension, had a twofold higher risk also for hemorrhagic stroke. So we know, it has been confirmed also in this trial already, that anticoagulated patients with uncontrolled hypertension have a higher bleeding risk. So what did we say in the guidelines? Blood pressure with very high blood pressure, patients with very high blood pressure, systolic 180, diastolic 100. We should not start oral anticoagulants. We have to first control blood pressure, and the target should be definitely below 140 or even below 130 millimeter mercury if tolerated. Now, I would like to come also, obviously, to talk about the kidneys. Why should we care about the kidneys in this setting? First of all, CKD is highly prevalent in patients with AF. Depending on the definition, if we go with the definition eGFR less than 60 milliliter per minute, about 30%. We have already impairment even with 80 or 70, even higher, up to 50%. And we know that these patients are at high risk for both thromboembolic event, strokes, or cause mortality, but also even further bleeding risk, particularly if anticoagulated these patients. So this is a problem in patients with atrial fibrillation and CKD. That brings me also to the great Professor Rudolf Virchow from the Charité in Berlin, who at the age of 25 formulated the Virchow triad. At the age of 25, I always tell the students, at the age of 25, he formulated the Virchow triad. And the Virchow triad, you know all the three mechanisms. I don't want to go into details. Blood constitution, as Virchow said, the viscosity, the blood flow, stasis, as he termed it, and injury of the vessel wall are the three elements that cause thrombosis. And that applies also to atrial fibrillation patients, not only in the atrium, but also in other vascular beds. And all these factors are increased, activated in patients with CKD by various mechanisms I don't want to discuss, but there's a very nice review by Kuma and co-workers, for instance, in the JAG published on this issue. We know also in the pivotal phase 3 trials, in this meta-analysis from Christian Ruff from Boston, that those patients with renal impairment, as shown here in the circles in the meta-analysis, if anything, they have even a greater benefit in terms of stroke and systemic embolism, thromboembolic events, or major bleeding events as compared to those patients with a normal renal function, which was measured in all these trials based on creatinine clearance. Also, formally, there was no significant interaction between renal function and outcome in the overall meta-analysis. But if anything, the CKD patients have clear benefit also in favor of a NOAC treatment as compared to a vitamin K antagonist, which was in almost all these trials warfarin. So therefore, in the ABC pathway, taking care of the patients with atrial fibrillation, taking care of the comorbidities is very important. Hypertension treatment is very important, but also treatment and looking into chronic kidney disease is very important in the management, in addition to anticoagulation to avoid stroke in these patients. Recent, very nice and important study, again also led by Greg Lipp and the team here in Korea. They looked actually on the importance of blood pressure control and the risk to develop end-stage kidney disease in a national, again, population-based study where they identified 130,000 patients and looked in those patients that had at least 2 health checkups within 2 years and measured normotensive status versus hypertensive status during these checkups and could clearly find with a mean follow-up of 3.2 years that first of all, that the hazard ratio to develop end-stage kidney disease is increased, starting with an average blood pressure above 110 millimeter mercury in these patients, as you can see with atrial fibrillation. And also, if you look at the hypertensive versus normotensive status, you can see those individuals that were hypertensive at both visits had a significantly higher risk to develop end-stage kidney disease as compared to the normotensive group. So hypertension and or uncontrolled hypertension very important for a risk factor for the development of end-stage kidney disease. Therefore, blood pressure control is important in patients with newly diagnosed AF to prevent renal failure. Confirmed also in patients now for the atrial fibrillation community, very important. Now, how about the target blood pressure in AF? Really, we lack data, but we know at least in the overall population, for instance, with the most prevalent disease, diabetic nephropathy, from the recent trials that we have made major achievement in terms of blood pressure reduction and preserving renal function, starting, 10 years back when we had the IDNT RENARD studies and the RAS inhibitor actually were introduced, ACE inhibitors, angiotensin receptor blockers, and you see the blood pressure achieved, the lower, the better the renal preservation was, which is the decline on the y-axis here, milliliter per minute, and starting actually from 8 milliliter per minute per year loss of renal function in diabetic nephropathy. By introducing these drugs and targeting blood pressure, we are now in the range of loss of renal function in the range of minus 2 milliliter per minute. And there are new drugs, SGLT2 inhibitors and also finerenone that have, set the point, the latest point, and there are new studies potentially coming in the future. So the question is, what will be the ideal blood pressure target in these patients, and also in atrial fibrillation patients, which has not been addressed in dedicated trials. And the question I would like now to discuss with you, does anticoagulation, oral anticoagulation, have a differential impact on the decline of renal function in AF patients and the risk to develop end-stage kidney disease? One issue, and it's maybe one important, but not the only important mechanisms that we know that could be related to this topic, is that calcification of the arteries and vascular injury is linked to oral anticoagulation with vitamin K antagonists. We know a lot about the biology of vascular calcification, particularly in the media, and we have factors promoting vascular calcification. We have factors that protect against vascular calcification, and among the factors that protect against vascular calcification, there is one important protein, which is the matrix Clar protein. If you knock out this gene in a mouse, for instance, and you have the wild type mouse here, an aorta of the wild type, and the knockout mouse and you do a specific calcium staining imaging, you see the, compared to the wild type in the knockout mice, the homozygous knockout mice, you see a pronounced calcification. So these have calcified arteries and also aneurysms, and the lifespan is massively reduced, and these mice die very early because they have rupture of the arteries and aneurysm, for instance. So this is a clear mouse experiment showing that the MGP protein is very important to protect against vascular calcification. The issue is that the matrix Clar protein belongs to the vitamin K dependent proteins. So we have vitamin K dependent proteins, not only the coagulation factors 2, 7, 9, and 10, protein C, protein S. We have also other coagulation proteins that depend on gamma carboxylation, and therefore, you know, this factor normally protects against vascular calcification in the media. We didn't know, maybe even also in the intima, where inflammation and atherosclerotic plaques are the major drivers. But you know, imagine if the MGP is really important to protect against vascular injury and calcification, and we use a vitamin K antagonist, we have the uncarboxylated MGP, and it needs vitamin K dependent gamma carboxylation to be active and protect against vascular calcification. And we use a vitamin K antagonist. We inhibit the activation of MGP and thereby can promote properly vascular calcification, which is known by the angiologist. If you long-term have patients on a long-term treatment, you can see an increased risk of vascular calcification in large arteries just by simple X-ray analysis observation studies. For instance, if you do X-rays in the lower extremities, you see more calcifications. So basically we know vascular calcification is the patients with CKD, and particularly diabetes and CKD, intrinsically at higher risk for vascular calcifications. There are several factors we know that can contribute this in diabetes and CKD. Also age, male sex, hypertension also, and smoking status has been also associated with vascular calcification. And now also the treatment with a vitamin K antagonist could induce a risk factor for calcification. A recent interesting study, observational study from Denmark, looked into 17,254 patients where CT calcium scanning data were available, and looked whether the use of VKA or NOACs had a differential impact on calcium score and vascular calcification in the coronary arteries. The mean age was 67 years. And they showed in this graph here the distribution of calcium scores. Green, low, no calcification. Red, high plaque formation calcification. And you see those patients that were treated with vitamin K antagonists long-term, up to 5 years or longer, you see the distribution pattern, more calcification, more patients with calcification, less patients with no calcification. And there was a significant association with age and treatment with vitamin K antagonists, calcification in the coronary artery bed, while no correlation was observed between calcification and NOAC treatment. So vitamin K antagonists might promote vascular calcification, not only in the vascular bed of the coronary arteries, but also in the kidney, and thereby also may promote the decline in renal function, because we know the major driver in the decline in renal function in the diabetic nephropathy or hypertensive diabetic nephropathy is vascular injury potentially. And the NOACs obviously do not impact on vitamin K dependent proteins, and there are even some data that the NOACs might even have protective effects against vascular injury. And particularly for the factor 10A inhibitors, such as rivaroxaban, there are experimental data and other data, clinical data, indirect data, even supporting the notion that independently from inhibition of factor 10A, they also inhibit platelets activation by PAR receptor signaling. And you may know the COMPASS trial where low-dose rivaroxaban has been used, and other trials on the arterial side to protect progression against the progression in atherosclerotic disease and also peripheral artery disease. So for instance, also the antiplatelet effect or the inhibition of the activated platelets might even be protective by using these drugs and even by also inhibiting the inflammatory processes that are also brought about by activated platelets. So this is some experimental and clinical data supporting hypothesis. The hypothesis that has been derived so far from observational studies. One of the most important observational studies was this paper in JACC by Yao, who looked in the real world in the United States, the use of NOACs, apixaban, dabigatran, and rivaroxaban as compared to warfarin, and looking into renal endpoints. Classical renal endpoints, decline in eGFR, doubling of creatinine, acute kidney injury, and kidney failure. You see no significant effects for apixaban were found in this analysis. Dabigatran and rivaroxaban, favorable effects at trend or at least a trend or significant risk reduction to develop kidney failure, acute kidney injury, or doubling of serum creatinine. And the idea was that this is brought about by using vitamin K antagonists, that they are actually promoting vascular injury and thereby also kidney injury, while the NOACs are not inducing this effect. There's another study by Craig Coleman, real-world study from the United States, patients that had not yet developed CKD stage 5 or were on hemodialysis. You see large group in the propensity score matched analysis, 36,000 patients with warfarin as compared to the 10A inhibitor, significantly less AKI, 90% risk reduction, 18% risk reduction to develop end-stage kidney disease. We did a study in Germany, a large observational study, 65,000 patients almost, comparing two 10A inhibitors again against vitamin K antagonist. We do not use warfarin in our country. We have another vitamin K antagonist called finprocomomun, but what you can see again, the risk to develop end-stage kidney disease, AKI, was significantly reduced, not AKI with apixaban, but overall you see again the confirmed observational confirmation of a beneficial effect of NOACs as compared to vitamin K antagonist in patients with AF, protecting the kidney. So we know that we need renal function monitoring for any drug treatment. I always mention this, but particularly also for NOAC dosing. And we have some national regional differences in approving the NOACs. So we need the renal function and we need to adjust the dose, and we can use them with some different labeling information down to 50 milliliter per minute. So in patients without end-stage kidney disease, we can use them, and that was the basis for the observational studies, because they are in the market and they are available to check whether they can protect against the development of end-stage kidney disease or renal failure, and the observational data confirm this. So putting this together in this graph, it seems that there are less AKI events and a slower progression of renal function decline over time, and a lower risk for development of end-stage kidney disease if you compare patients that are treated with vitamin K antagonist versus patients that are treated with a NOAC or a DOAC. We are running right now, and we are finalizing the data analysis of a prospective registry. Most of the data have been, I mentioned to you, by retrospective real-world database analysis. We did a prospective, non-interventional, registry, but with blinded, adjudicated outcome analysis, comparing vitamin K antagonist treatment versus factor 10A inhibition with rivaroxaban. Also, we have a third arm where patients were not anticoagulated based on the discretion of the attending physicians. And we present preliminary data. Right now, we are analyzing the final data after follow-up of more than 2 years. And it seems that the hypothesis I presented to you could be confirmed that factor 10A inhibitors protect the kidney in this setting. So I would like to summarize my presentation. First of all, with regard to blood pressure control, high blood pressure in AF patients is common and increases the risk of MACE, major adverse cardiovascular events, also in intracranial bleds, and also end-stage kidney disease. Therefore, blood pressure monitoring and follow-up is very important. We can also use home blood pressure measurement. As we have seen, it could be very important also because of home blood pressure measurement has been associated with increased risk, as you have seen in the paper observational study by Professor Kario, very recently published from Japan. Mass hypertension seems to be also quite frequent, up to maybe 27% of the patients. How far shall we lower blood pressure? Definitely below 140, even 130 if tolerated. We do not know the safety margins that will be discussed, I think, also with Professor Manolis. And when we are writing now, developing the new ESH guidelines, we have to take into account also the high age of these patients. Now in the Japanese study, 80 years. In our study, we do in Europe with CKD patients, the mean age is 78 years. You know, CKD is enriched in the elderly, so it's also an issue of how to treat the elderly. And we have to take care of these patients and also the risk to develop potentially hypertension. We may use oscillometric devices, although they may overestimate a little bit the blood pressure we measure. And also there's an increased mortality in patients with very low blood pressures. Could be reverse causality, but nevertheless we should be at least aware of this association. With regard to renal protection, I think oral anticoagulation is very important in patients also with CKD, including stage 4. And we can, you know, these patients have a high risk to develop end-stage kidney disease, and many elderly will develop this, and therefore the differential impact of the anticoagulation is also important because NOACs not only can reduce the intracranial hemorrhage risk, but also maybe protect the kidney based on the observational data. Overall, renal function is very important to monitor per se in patients, our cardiovascular patients, but also very important in AF patients, and we should avoid the use of nephrotoxic drugs in these patients who are anticoagulated and elderly with CKD, because we can promote end-stage kidney disease and also have to adjust the NOAC dosing according to the label. With this, I would like to end and thank you very much for the invitation again and your attention. And if you may come to Berlin, I would be very happy in 2024 to see you at the European Society of Hypertension meeting there. Thank you very much.
Thank you very much. So fantastic talk regarding the atrial BP issue, anticoagulation drug in patient to atrial fibrillation, and also bidirectional link between CKD and atrial fibrillation. We have a little time, so any other short question or comment from the audience? Oh, okay. Tomatevsky.
Reinhold, congratulations. One quick question, if I may. I mean, if the NOACs are nephroprotective, which is very interesting, what about the kidney function spectrum, not at the lower end, but the upper end? So they seem to be nephroprotective for patients with CKD stage 3, 4, and up to perhaps 5. But are there any data showing that, for example, NOACs could show some level of nephroprotection in patients who are at stage 1 or 2, and in relation, for example, to a little bit to measures such as microalbuminuria, for example?
I'm not sure about whether or not albuminuria is the right phenotype, because it's more related to glomerular dysfunction, hypertension, so not to the vascular injury type, to answer the last aspect of your question. But the question is very important. I mean, in many of these, I just picked up 2 or 3 of these observation studies. They included also patients at the higher spectrum. Okay, they included all patients, even without, or sometimes they included only CKD patients, but also CKD 2 or 3. So which is starting at 60 or even even higher, and patients without CKD if you define it only by EGFR. So, but obviously to develop end-stage kidney disease in patients with a CKD stage 1 or even normal, CKD stage 1, which means filtration over 90, or 2, you need a longer follow-up, you know, a long-term follow-up. And most of these studies shorter, maybe up to 5 years or whatever, you need a longer follow-up. Also the risk, another surrogate is AKI. But again, the patients with more advanced kidney disease have a higher risk to develop AKI. But interesting question whether we can even, you know, promote maintaining renal function longer in those patients who have not yet even developed CKD. But in real life, the majority, vast majority, I mean real life, the mean age of these patients in these real life studies is close to 80. In the pivotal trials, the mean age, they included also other and excluded high-risk patients. The mean age in the pivotal, all this phase 3 trial was 71 years. But we have younger AF patients also, and they could actually be in long-term on a NOAC, and most of these young, they don't even want to use, you know, blood monitoring with INRs anymore. It could add a benefit for the kidneys also during long-term treatment in the future. Yes, that's an important point.
Before wrapping up this plenary lecture session, on behalf of our society, Professor Im will present a piece of plaque of appreciation to Professor Kreutz. Plaque of appreciation.
네, 고혈압학회 두 번째 날 점심 세션 시작하도록 하겠습니다. 이번 세션은 런천 심포지움 다섯 번째가 되겠고요. 대웅제약과 한국 다이치 상교 산학 심포지움이 되겠습니다. 심포지움의 주제는 아마 인텐시브 BP 트리트먼트 관련된 내용이 되겠고요. 연제는 두 개가 준비되어 있습니다. 먼저 첫 번째 연제는 노인 고혈압 환자에서 BP 컨트롤 스트래티지에 대한 업데이트 되겠고요. 연자는 가천의대 위진 교수님이십니다. 위진 선생님은 쪽에 좀 여러 방면에서 좀 박학다식하고 또 활발한 활동을 하고 계시는데요. 연세대를 나왔고 연세대 세브란스 병원에서 뭐 심장 중환자실 실장, 또 저체온 치료팀 팀장, 심폐소생술 디렉터 등을 역임한 바 있고요. 현재 가천의대 길병원에서 심장내과 부교수, 또 심혈관계 중환자실 실장으로 재직하고 계십니다. 네, 유진 교수님 준비되셨으면 부탁드립니다.
네, 소개 말씀 감사드립니다. 오늘 이제 식사하시면서 편하게 들으실 수 있도록 저희가 이제 고혈압을 가진 고령 환자들한테 있어서의 BP 컨트롤을 어떻게 할지, 그리고 실은 저희가 이제 BP 컨트롤만 중요한 게 아니라 항상 BP 컨트롤을 하다 보면 생기는 사이드 이펙트 같은 것들을 좀 어떻게 대처해 나갈지 그런 내용들을 조금 말씀드리고자 합니다. 먼저 저희가 이제 오늘 주제가 엘더리 페이션트니까 노인의 정의가 어떻게 되느냐. 저희가 뭐 노인의 정의는 여러 가지가 있죠. 뭐 저희가 65세 이상을 얘기하기도 하고 뭐 여러 가지 얘기들을 가지면서 저희가 뭐 고령 사회냐 초고령 사회냐 얘기를 하겠지만 한번 놓고 보자면 저희가 당사자들은 요즘 워낙 건강들도 좋아지시고 관리가 잘 되다 보니까 70세가 넘어도 노인이라는 말을 듣는 거를 썩 내켜하시지는 않는 것 같습니다. 뭐 저희 부모님만 하더라도 할아버지 할머니 소리는 잘 나오시면서도 노인이라는 얘기 들으시면 굉장히 뭐 기분 나빠하시는 약간 그런 게 있어가지고요. 다양한 가이드라인을 보면 그렇지만 보통들은 보면 한 65세 정도쯤을 노인이라고 얘기를 하는 것 같고 very old는 한 80세 정도를 이렇게 얘기를 하는 것 같습니다. 이제 점점 보면 우리가 이제 생존 기간이 길어지기 때문에 고령의 고혈압 환자분들이 많아질 수밖에 없는 상황들이고요. 실은 제가 고혈압 이제 강의할 때마다 많이 하는 내용들이지만 저희가 이제 한번 보면은 고혈압 같은 것들이 나이가 들면서 어떻게 기전상으로 좀 변해가는지를 볼 필요가 있을 것 같습니다. 저희가 보통 이제 고혈압 환자들이 보통 고혈압이 생기기 시작하는 한 40대 중후반 정도를 보면 그때는 유로 휴모럴 이제 하이퍼텐션 정도 주로 이렇게 라스라든지 교감신경통이 높은 그런 상태로 시작을 하다가 점점 나이가 들어가면서 혈관이 딱딱해지는 어떤 스트럭처럴 하이퍼텐션의 과정이 걷게 되고 또 그와 동시에 우리가 오토노미 너버스 시스템의 그런 펑션들이 조금 떨어지고 또 이런 바로 리셉터 같은 것들의 기능이 떨어지니까 소스 센티비티가 올라가는 상황들, 그러면서 점점 진행하는 그런 양상들이 보이는 것 같습니다. 그래서 앞에서 말씀드렸던 것처럼 우리가 SBP는 나이가 들면서 계속 올라가지만 다이아스톨릭 BP는 보통 50대, 60대를 정점으로 해서 이제 꺾여 나가니까 그 차이인 펄스 프레셔가 점점 벌어져 나가는 그런 양상들을 보이게 되고요. 결국 그 펄스 프레셔 차이가 결국은 여러 가지 CV 아웃컴과도 관련이 되어 있다는 사실들은 이미 많이 알려져 있습니다. 그러면 노인 고혈압의 특징들은 뭐냐? 방금 말씀드렸던 것처럼 다이아스톨릭 BP는 떨어지면서 SBP만 올라가는 아이솔레이티드 시스톨릭 하이퍼텐션 양상을 보이고요. 또 환자들이 BP의 베리어빌리티가 굉장히 큽니다. 높았다 떨어졌다. 결국 이것들도 다 오토노미 너버스 시스템에 문제가 좀 생기니까 그런 걸 조절해주는 능력들이 떨어지는 거고, 여러 가지 뭐 키드니 펑션의 저하 같은 것 때문에 사이드 이펙트가 많이 생겨서 방금 말씀드렸던 것처럼 우리가 이제 이런 특징들, 다양한 또 동반 질환 또는 여러 가지 고혈압 치료를 할 때 발생하는 그런 부작용까지도 같이 가지고 치료를 진행해야 되지 않을까라고 생각을 하는 것들이고요. 그래서 아까도 말씀드렸던 것처럼 나이가 들면 코모비디티들이 당연히 많아지고 약을 드시는 복용 횟수도 많아지잖아요. 그러면 같은 혈압이라 할지라도 연세가 높은 분들이 그만큼 코모비디티가 훨씬 많기 때문에 모탈리티라든지 이런 여러 가지 아웃컴이 더 안 좋다라는 것들은 많이 알려져 있는 사실들입니다. 그럼 우리가 이제 이런 약들을 쓰는 것들을 보면 아까 우리가 그런 기전들을 꼭 이해하고 쓰는 건 아니지만 젊었을 때의 비율이 주로 AC미터, ARB의 비율이 높다면 연세가 드시면 이런 비율들은 조금 떨어지고 이뇨제 같은 것들의 비율이 좀 더 올라가는 것들이 현재 이렇게 팩트시트에 나와 있는 그런 소견들이 되겠습니다. 그래서 실제 제가 봤던 환자를 한번 보여드리면 73세 여자 환자가 한 번도 뭐 진단되지 않았던 환자인데 이게 디스니아를 주소로 이제 들어왔습니다. 이니셜 BP가 170에 90으로 굉장히 올라 있었고요. 심전도를 보시면 환자가 사이너스 리듬이긴 한데 환자가 굉장히 이렇게 프리퀀트한 APC 리듬들이 많이 있고요. EKG를 보시면 굉장히 심한 LVH, 우리가 보면 스트레인 패턴이라고 하는 그런 LVH의 소견이 보였습니다. 환자는 디스니아가 너무 호소하고 엑스레이상에서 펄모널 이데마가 굉장히 심했기 때문에 오자마자 인투베이션을 진행했었고요. 에코를 보면 환자는 시스톨릭 펑션은 굉장히 보존이 잘 되어 있지만 심장이 굉장히 두꺼워져 있는 LVH가 있고 LA 사이즈도 많이 커져 있는 그런 환자가 되겠습니다. 이 환자는 여러 가지 검사를 진행하다 보니까 여러 가지 플렉, 멀티플한 캐로티드 플렉들도 굉장히 많았고요. PWV도 보면 2,000이 넘을 정도로 굉장히 진행이 있는 상황이었고, 여러 가지 검사를 하다 보니까 콜레스테롤 레벨도 엄청나게 높고 당뇨도 있는, 그러니까 모든 걸 다 모르고 있었던 처음 진단된 그런 환자들이었습니다. 우리 심전도 볼 때 프리퀀트하게 APC가 있으면 항상 숨어있는 AP를 의심하라라는 명언이 있잖아요. 그래서 이 환자 같은 경우도 저희가 굉장히 고위험군이기 때문에 홀터를 진행했고 환자가 APB 진단이 됐던 그런 환자. 그렇기 때문에 이렇게 연세가 많은 분들은 단순히 고혈압만이 아니라 이렇게 멀티플한 코모비디티들을 같이 확인해서 같이 치료하는 과정들이 조금 필요하다고 생각이 됩니다. 그러면 이런 연세가 많은 분들한테서도 하이퍼텐션 트리트먼트를 좀 더 잘하는 게 필요할 것이냐? 우리 이제 스프린트 스터디 같은 경우들은 보면은 우리 당연히 DM도 빠지고 스트로크 같은 경우도 빠져서 좀 한계가 있다고 되어 있지만 거기서도 75세가 넘는 시니어 그룹들만 봤을 때 보면은 통계적으로 조금 유의하지 않은 것들도 있긴 하겠지만 인텐시브하게, 그러니까 SBP를 거의 120 근처까지 맞췄을 때도 아웃컴이 좋다는 연구 결과들이 나와 있었고요. 그렇지만 이제 노인성 고혈압의 특징이 다이아스톨 BP가 좀 떨어져 있기 때문에 다이아스톨 BP를 55세 60 정도는 최소한 유지하는 상태에서 보는 게 낫지 않겠느냐라는 얘기들이 나와 있었고요. 그 뒤에 나왔던 메타아날리시스 같은 것들을 보더라도 고령 환자들하고 인텐시브하게 BP 컨트롤하는 것이 거의 30% 가까이의 CV 아웃컴을 좋게 만드는 효과가 있지만, 그렇지만 어쨌든 키드니 펑션의 문제라든지 다른 하이포텐션 이런 것들은 조심을 하라라고 이렇게 되어져 있습니다. 그래서 그동안 보면 여러 가지 가이드라인 상에서 고령 환자들한테 있어서도 제시를 하려고 했지만 뭐가 딱 떨어지는 것들은 아니고요. 우리 이번에 고혈압 학회에서 2022년 바뀐 것들도 일단 고혈압은 노인성 고혈압에서 140에 90 정도를 유지하는 것들은 그대로 유지를 하고 있습니다. 그런데 이제 작년 8월쯤에 저희가 이제 NEJM의 스텝 트라이얼이라고 하는 딱 제목 자체가 고혈압을 가진 고령 환자들한테 있어서의 어떻게 인텐시브 컨트롤을 할 것이냐라는 것들이 논문이 발표가 됐고요. 이 연구는 어떻게 보면 우리가 기존에 나왔던 스프린트라든지 다른 다양한 연구들이 이제 외국에서 진행됐고 BMI가 굉장히 증가되어 있는 그런 환자들인데 60에서 80세 사이의 중증인 고혈압 그리고 BMI가 거의 25 정도니까 거의 우리나라 사람들과 거의 비슷한 정도의 그런 것들을 가지고 있었고요. 이제 인텐시브 그룹 자체를 BP를 130에서 130 이하 정도로 맞추는 것들이 조금 이제 차이가 있었습니다. 그래서 여기 연구 디자인을 보면 주로 혈압을 조절하는 것들은 주로 올메살탄과 암로디핀 계열들로 이제 혈압을 조절을 했었고요. 그래서 여기 보시면 거의 한 60% 가까이가 이제 올메살탄 베이스드 약제를 복용하면서 인텐시브하게 이제 그룹을 진행을 했었습니다. 그래서 아까 잠깐 베이스라인 캐릭터리스틱스를 보시면 고령이라고 하긴 하겠지만 평균 나이는 한 66세 정도 되고요. 70세가 넘는 사람은 한 4분의 1 정도를 차지하고 있고 아까 말씀드렸던 BMI는 동양 사람들과 비슷합니다. 그리고 스프린트에서 빠져 있었던 당뇨 환자가 한 20% 가까이 여기에 포함이 되어 있는 그런 특징들이 있었고요. 그래서 연구 결과를 보시면 인텐시브한 그룹은 아까 SBP를 보시면 한 126, 107 정도, 그러니까 우리가 저기 보면 스프린트에서 SBP가 120, 121 정도였으면 한 5, 6 정도 높은 정도의 타겟을 이제 유지를 하게 됐었고요. 그렇지만 프라이머리 아웃컴, 세컨더리 아웃컴을 보시면 카디오베스큘러 리덕션 레이트는 거의 30% 정도로 스프린트와 거의 비슷한 소견들을 보입니다. 저희가 항상 이 에피커시 아웃컴을 보게 되면 반드시 봐야 되는 게 세이프티 아웃컴이라면 우리가 이제 스프린트 같은 경우는 AKI라든지 그런 것들의 비율이 높았던 반면에 이런 세이프티 아웃컴도 인텐시브 그룹과 스탠다드 그룹 사이에 그렇게 큰 차이가 보이지 않았던 그런 상황이 되겠습니다. 그래서 이제 이렇게 한번 스프린트 스텝 트라이얼이 발표가 되고 나서 이 내용을 가지고 이거는 이제 우리가 RCT를 진행한 거고요. 그게 아니라 그 기준을 맞춰서 한번 고혈압이 있는 환자건 없는 환자건 간에 한번 130 이하로 맞췄던 그룹과 아닌 그룹들을 한번 쭉 비교를 한번 해보면 리얼 데이터가 올해 이제 발표가 됐었는데요. 그거를 보면 여러 가지 카디오베스큘러 디지라든지 아니면 올코즈 모탈리티 가까이가 거의 한 10에서 20% 가까이가 꼭 고혈압이 있고 없고를 따져서 혈압을 한 120대 중후반 정도로 유지하는 곳에서 더 좋은 아웃컴 결과를 보였다는 것들이 나와 있었습니다. 그렇기 때문에 실제 뭐 스텝 트라이얼 또는 이번 리얼 데이터를 통해서도 연세가 많은 분들도 그렇게까지 펑셔널 캐퍼시티가 떨어지거나 그런 게 아니라면 한 120대 중후반 정도의 혈압을 유지하는 인텐시브 그룹들이 좋은 예후를 보인다라는 그런 결론을 낼 수가 있었던 것들이고요. 앞에서 잠깐 말씀드렸지만 스프린트 트라이얼 같은 것들을 보면 아까 제가 말씀드렸던 세이프티 아웃컴이 뭐 AK라든지 이런 것들이 많았잖아요. 근데 대부분 여기를 많이 보다 보면 밑에를 잘 안 보는 경향이 있는데 이게 오르소스태틱 하이포텐션에 대한 내용이고 당연히 우리가 이걸 보면 그랬거니 생각해서 인텐시브 그룹이 더 높을 거라고 생각하지만 잘 보시면 오르소스태틱 하이포텐션이 인텐시브 그룹이 스탠다드 그룹보다 더 낮습니다. 높은 게 아니고요. 그래서 전체적으로 보면 더 이 비율이 더 적은 걸로 되어져 있고요. 그래서 실은 앞에서도 제가 처음 말씀드렸지만 워낙 이제 우리가 인텐시브하게 치료하는 환자들한테서 걱정되는 것들이 항상 이렇게 하이포텐션, 그 중에서도 오르소스태틱 하이포텐션이고 특히 연세가 많은 분들한테 있어서는 조금 걱정이 많이 되는 부분들 중에 하나인데 우리가 이제 기립성 저혈압을 보자면 이게 기립성 저혈압의 정의 자체가 뭐 누워 있거나 앉아 있다가 서서 1분에서 3분 정도 사이에 SBP가 20 이하 또는 다이아스톨릭 BP가 뭐 10 이하 떨어지는 것들로 되어 있는데 실은 이게 뭐 제너럴 파퓰레이션 정도에서도 연구를 하다 보면 많게는 30% 가까이 보고가 되기 때문에 그렇게 드문 질환은 아닙니다. 근데 이게 특히나 노인들에서 문제가 되는 이유는 꼭 약제가 아니더라도 앞에서 제가 말씀드렸던 것처럼 노인들은 오토노믹 너버스 시스템에 문제가 있고 그다음에 바로 리플렉스 같은 기능들이 떨어져 있기 때문에 이런 것들을 보상하는 그런 기능들이 많이 떨어져 있다는 것들이죠. 쉽게 말씀드리면 기립성 저혈압이라는 게 뭐 앉아 있거나 누워 있다가 딱 서는 순간 우리 흉부 체스 쪽에 있던 피가 가령 500에서 1000cc 정도가 이 아래쪽이나 로어 림 쪽으로 확 이동을 하면 우리 몸이 그걸 보상하기 위해서 그러니까 하트레이트가 빨라지고 시스테믹 베스큘러 레지스턴스를 올려주는 그런 일련의 과정들이 이어져야 되는데 그게 노인들에서는 쉽지가 않다라는 것들이죠. 그리고 이제 여러 가지들을 보면 아까 말씀드렸던 것처럼 여러 가지 원인들이 많이 있지만 오르스타틱 하이포텐션을 일으키는 가장 많은 원인은 볼륨 디플리션이 가장 많은 원인인 것 같습니다. 그래서 그 중에서도 또 보면 우리가 고혈압 약제로 쓰거나 다른 약제로 쓰는 이뇨제 같은 것들이 많이 들어가 있게 되고요. 또 거기에 방금 말씀드렸던 것처럼 베타 블로커를 먹는 경우에 이렇게 타키카디아가 생겨서 보상하는 기능들이 이게 상쇄가 돼 버리니까 또 그런 문제들이 많이 생기고 또 실은 많이 보다 보면 우리가 고령을 얘기할 때 남성분들 같은 경우는 BPH가 있는 남성분들은 알파 블로커를 복용하는 경우들이 굉장히 많이 있거든요. 그러니까 이런 경우들이 오르소스태틱 하이포텐션을 일으킬 수 있는 또 많은 원인들이 되기 때문에 이게 우리가 그냥 BP만 볼 게 아니라 이런 내용들을 같이 판단하는 것들이 필요할 거라고 생각이 됩니다. 그래서 얼마 전에 실렸던 메타아나리시스를 보시면 여러 가지 아까 보여드렸던 스프린트뿐만이 아니라 9개 스터디들을 다 정리를 했는데 보면 결과적으로 통계적으로 유의하게 오히려 인텐시브한 그룹에서 오히려 더 오르소스태틱 하이포텐션이 더 적더라. 그렇기 때문에 너무 이걸 걱정할 필요는 없고 그렇다고 하면 우리의 궁금증은 아니 왜 인텐시브하게 조절을 했는데 더 안 생기느냐. 이 연자들의 디스커션 부분들을 읽어보면 우리가 이제 연세가 많은 분들일수록 고혈압이 좀 오래되고 그러다 보면 LV가 좀 두꺼워지는 아까 보여드렸던 뭐 LV 하이퍼트로피라든지 이런 게 생기면 LV의 필링 프레셔가 올라가고 그런 경우들이 많이 있는데 오히려 에프트로드를 좀 줄여줌으로 인해서 오히려 적절하게 혈압만 유지시켜주면 오히려 필링 프레셔가 더 좋아지니까 카디악 아웃풋이 늘고 그런 효과가 생기는 것이 아니겠느냐 이런 얘기들을 하는 것들이고요. 또 연자들이 달고 있는 얘기가 우리 클리니션들이 걱정하는 거 안다. 근데 여기서 우리가 보여주는 효과라는 건 다 롱텀 효과인데 우리는 어떻게 보면 조금 치료하다 말고 환자 약 주고 환자가 어지럽다고 그러면 약을 다시 바로 끊어버리고 하니까 우리가 어떻게 보면 환자의 몸이 어댑테이션 하는 것들을 시간을 벌어주지 못한다. 그렇기 때문에 조금 어댑테이션 하는 시간을 조금만 가지고 약을 조금 천천히 조절만 해주면 충분히 좋은 효과를 누릴 수 있을 것 같다라는 결론들을 이렇게 내고 있어서 그런 기전적인 내용들을 조금 말씀드렸고요. 마지막으로 제 환자 케이스 하나가 있었습니다. 환자가 외부 병원에서 이제 고혈압으로 이미 뭐 여기 발살탄 80과 암로디핀 5mg을 먹고 있던 환자였었는데 여러 차례 싱코피가 생기니까 뭐 외부 병원에서 여러 가지 뭐 검사들을 다 했지만 이상이 없다고 했었고요. 근데 이 환자가 저한테 매래 와서 보면 하트레이트 굉장히 빠르고 혈압이 굉장히 높았습니다. 그래서 뭐 여러 차례 조금 쉬다가 재보고 1시간 가까이 쉬었는데도 계속 혈압이 높은 거예요. 근데 이때까지는 아직은 뭐 알 수가 없었겠으니까 일단 약은 복용하는 채로 한번 집에서 자가 혈압 같은 것들을 홈 BP를 재보게끔 했고 제가 24시간 BP 같은 것들을 검사를 했었는데 환자가 보니까 여전히 다음 LA 때도 보면 오피스 BP는 높지만 24시간 BP를 해보면 평균 혈압이 한 100대밖에 되지 않고요. 자가 혈압도 보면 거의 SBP가 110밖에 되지 않습니다. 근데 이제 이런 환자들의 특징이 뭐냐면 연세가 많으시기도 하고 여자분이시고 환자분이 굉장히 긴장도가 높고 까탈스러워서 아무 때나 막 새벽에 깨가지고 혈압 재다가 뭐 꿈자리가 안 좋으면 새벽에 깨서 혈압 재고 그럼 그럼 이제 혈압 높으면 다음 날 병원 와서 혈압 높으니까 약 달라고 하고 이런 식으로 계속 조정이 됐던 것들이었죠. 그래서 이 환자를 잘 설득을 해서 혈압약을 끊어보고 그 다음에 한 번 더 몇 주 가까이 한번 혈압을 측정했더니 SBP가 120 정도밖에 되지가 않는 분인 거였던 거예요. 그러니까 어떻게 보면 이분은 고혈압이 오히려 없던 분인데 고혈압으로 잘못 착각해서 줬을 가능성도 있어서 이분은 혈압약을 다 끊어버리고 오히려 혈압이 높아지면 자가혈압을 꾸준히 재서 오시라 말씀드렸는데 거의 뭐 6개월 1년이 되도록 안 오시는 걸 보면 조절이 잘 되고 있는 것들로 생각이 됩니다. 그래서 한번 정리해서 말씀드리면 노인 고혈압에서도 그러니까 방금 케이스를 보여드렸던 것처럼 적극적인 혈압 조절이라는 게 누가 너무 낮게 보지 말자는 거지 아까 스텝을 따르자면 한 120대 중후반 정도의 적극적인 혈압 조절은 심혈관계 위험도를 감소할 수 있는 어떤 좋은 길인 것 같고요. 그렇지만 과도한 혈압 저하는 아까 신장 기능 저하, 실신 같은 것들이 부작용이 생기기 때문에 동반 질환, 식사 상태 같은 것들을 조금 꾸준히 확인하시는 특히 우리나라 분들이 보시면 연세 많아지시는데 식사는 거의 막 어떻게 보면 컨디션이 안 좋아서 2, 3일 동안 안 먹었는데 보면은 환자가 약은 또 꾸준히 먹다 보니까 그럴 때 꼭 싱코페해서 응급실에 실려오시고 이런 것들이 있기 때문에 그런 것들을 조금 잘 한번 문진을 하시거나 하는 게 중요할 것 같고요. 확실히 좀 어떤 어댑테이션 하는 것들이 좀 떨어지기 때문에 젊은 성인들에 비해서 용량 같은 것들을 조금 조절할 때도 조금 천천히 그리고 용량도 좀 적게 하시는 게 필요할 것 같고 아까 제가 이렇게 하이퍼텐션이 진행되는 기전을 말씀드렸는데 저는 그래서 개인적으로 굉장히 복합제를 쓰는 걸 좋아합니다. 그래서 환자가 이게 어떤 기전에 의해서 혈압이 올라가는지를 정확히 평가하기 어렵다면 뭐 ARB와 CCB의 복합 용법 같은 것들을 적절하게 섞어 쓰시면 도움이 될 것 같고요. 말씀드렸던 것처럼 환자의 개별 상태, 특히 BPH가 있는 남성들 같은 경우는 오히려 이뇨제가 포함된 경우에 혈압을 떨어뜨리기 위해서 포함을 시켰는데 환자가 소변 보기가 너무 힘들어서 되려 그것 때문에 나는 혈압이 더 올라가는 것 같다고 불평하시는 분들이 많이 있거든요. 그래서 그런 것들까지도 같이 판단하셔서 노인 고혈압을 조절하시는 게 도움이 될 거라고 생각이 됩니다. 네, 강의 여기까지고요. 경청해 주셔서 감사합니다.
네, 좋은 강의 감사드립니다. 결국 이제 노인 고혈압도 일단 기본은 좀 엄격한 혈압 조절이 필요하다는 것이지만 노인 자체가 가지고 있는 여러 가지 한계를 잘 평가해서 개별적인 어프로치도 필요하다라는 이야기를 해주셨고요. 두 번째는 이제 조인정 이화의대 교수님께서 당뇨 환자에서 그럼 혈압 조절을 어떻게 할 거냐. 최근 저희 5월에 개정된 고혈압 가이드라인에서 당뇨 환자에서 조금 더 엄격한 BP 컨트롤이 요구된다라고 이야기를 하신 것 같은데 조인정 교수님은 이화의대를 나오셨고요. 그 연세대 세브란스 병원에서 임상 저교수를까지 꽤 오랫동안 하시다가 최근에 서울의 이대 서울병원으로 옮기셨습니다. 한국심초음파학회에서 젊은 연구자상을 2차례 수상하신 적이 있고 고혈압학회에서도 좀 활발하게 활동하고 계시고요. 현재 이화의대 서울병원의 순환기내과 부교수로 재직 중이시고 학회는 심초음파학회에서 뭐 평의원, 지침재정위원회, 고혈압학회에서 기획위원회, 근거창출 태스크포스팀 또 그리고 여러 가지 홍보 학술 정책위원으로 활동을 하고 계십니다. 네, 교수님 부탁드립니다.
소개 말씀 감사합니다. 제가 말씀드릴 내용은 당뇨 환자에서 고혈압이 있을 때 어떻게 치료할 것인가에 대해서 말씀을 드리고자 합니다. 여러분 새로 받으셨겠지만 팩트시트 2002년이고 보시면 고혈압이 사실 프리벌런스가 전체적으로 약간 주는 듯 하다가 좀 비슷하게 가고 특히 남자들은 이게 코로나 때문에 그런지 많이 늘어서 혈압이 굉장히 많습니다. 그래서 한 29% 정도로 지금 이제 고혈압이 좀 늘어서 좀 걱정스러운 추세인 것 같습니다. 이제 이런 환자들에서 보시면 고혈압 치료자 중에 당뇨가 얼마나 있나 보시면 당뇨가 있으면 또 고지혈증이 많기 때문에 당뇨랑 고지혈증 모두 같이 치료하는 환자를 더하게 되면 전체 고혈압 환자의 4분의 1 이상이 지금 당뇨를 동반하고 있기 때문에 당뇨 환자에 대해서 항상 신경을 좀 쓰셔야 될 것 같습니다. 당뇨는 생각보다 프리벌런스가 좀 굉장히 높다라고 생각을 하셔야 되고 이제 30세 이상으로 놓고 보면은 뭐 13.8이지만 이게 고령 환자 아까도 나왔지만 65세 이상으로 놓고 보면 거의 27.6%이기 때문에 우리나라 사람들이 말랐음에도 불구하고 당뇨가 굉장히 프리벌런스가 높다라고 생각을 하셔야 되고 일단 당뇨가 있게 되면 고혈압은 굉장히 흔합니다. 그래서 30세 이상으로 보게 되면 이건 당뇨학회 이제 팩트시트인데 당뇨가 있으면 고혈압이 한 60%, 61%, 65세로 이상으로 가게 되면은 거의 4분의 3은 당뇨 있으면 고혈압은 있다라고 생각을 하셔야 돼서 당뇨 환자에서 고혈압을 어떻게 치료할 것인가는 굉장히 중요한 문제입니다. 이제 여기에 같이 공동되는 여러 가지 팩터들이 있고 사실 뭐 당뇨랑 고혈압 얼핏 생각해도 뭐 이렇게 비만하고 이런 사람들이 많으니까 이제 그 리스크 팩터를 같이 공유한다고 생각을 할 수가 있고 그거 외에도 이제 인슐린 리지스턴스 자체가 하이포글라이세미아, 디스리피디미아, 하이퍼인슐리네미아를 만들고 이거 자체가 소듐 리텐션을 일으키면서 하이퍼텐션이 되고 바스큘라 디스펑션도 일으키고 뭐 이러면서 여러 가지 심파스틱 톤, 라스 액티베이션 등을 해서 비셔스 사이클을 통해서 당뇨가 있으면 고혈압이 있고 고혈압이 있으면 당뇨가 잘 생기는 이제 이런 상태가 된다고 할 수 있습니다. 물론 혈압 조절 잘하는 게 굉장히 중요하다는 거 잘 알고 계실 거고요. 당뇨가 있으면 심혈관 질환이 잘 생긴다. 이거는 아주 먼 옛날부터 굉장히 93년 데이터인데 우리는 모두 잘 알고 있습니다. 그래서 당뇨가 카디오바스큘러 리스크의 고위험이고 이러한 사람들의 고혈압이 있으면 더 나쁘다. 이런 사실은 잘 알고 있던 그런 사실입니다. 그리고 실제로 이제 그 당뇨 환자들이 두려워하는 거는 사실 당뇨 환자 이제 거의 스테이지 이제 컴플리케이션이 심장병, 스트로크도 있고 결국은 눈 멀고 이렇게 다리 앰퓨테이션에 투석 돌리는 환자들이 많습니다. 근데 이게 이러한 컴플리케이션이 오는데 하이퍼텐션이 얼마나 영향을 미치는가 보면 대략 막 거의 50%, 35%, 많게는 75%까지 영향을 미쳐서 이 당뇨는 그냥 당뇨라고만 보시면 안 되고 혈압 조절을 굉장히 신경 써야 한다라고 생각을 하셔야 됩니다. 그래서 최근에 이제 2022년 미국 당뇨학회에서는 이제 이런 식으로 이렇게 포퓰러 이제 이렇게 필러 세우는 걸 되게 좋아하는데 이렇게 포퓰러 이제 스트래티지를 얘기를 하는데 여기 보시면 당뇨 조절 그리고 여기랑 똑같은 이제 필러 하나로 블러드 프레셔 매니지먼트가 들어가 있습니다. 그리고 리피드 매니지먼트도 굉장히 중요한 이제 그 필러가 하나가 되겠고 또 하나는 약을 쓸 때 가능하면 카디오바스큘러와 키드니에 베네핏이 있는 그러니까 뭔가 프로테인 유리아를 줄여주는 뭐 이제 그런 약들로 쓰는 게 좋겠다라고 생각을 해서 이제 이런 걸 다 고려해서 이제 당뇨를 치료하는 게 굉장히 중요하다라고 이렇게 이런 식으로 그림까지 그려서 설명을 하고 있습니다. 그럼 이제 목표 자체가 옵티멀 BP니까 그럼 당뇨 환자에서 BP를 어떻게 옵티멀하게 이제 꼴이 있어야지 저희가 어치브를 할 수 있으니까요. 이제 꼴에 대해서 보시게 되면 이제 사실 이게 옛날 어드밴스 BP 트라이얼이라고 이 옛날 데이터이긴 한데 당뇨 환자들을 대상으로 해서 이제 카디오바스큘러 아웃컴을 봤는데 결론은 이렇습니다. 142보다는 136이 낫더라. 그래서 140보다 높은 혈압보다는 이제 140 이하로 유지하는 건 좋겠다. 이거는 모든 사실 굉장히 옛날부터 잘 알려진 사실이죠. 그리고 이제 이걸 에비던스를 좀 더 낮추면 어떨까? 그래서 타겟을 120으로 해서 어코드 BP가 2010년도에 나왔는데 이게 이 데이터가 아쉽게도 스트로크는 줄였지만 프라이머리 엔드 포인트는 줄이지를 못했습니다. 그리고 이제 결국은 어드버스 이벤트가 훨씬 더 이 인텐시브 BP에서 좀 더 많아서 당뇨 환자는 고위험군이니까 혈압을 120 이하로 뚝 떨어지면 좋을 것 같은데 이게 안타깝게도 네거티브 스터디가 나와버렸습니다. 그래서 결론은 135보다 119로 조절하는 게 좋지가 않더라라는 이제 결론이 나와서 그래서 당뇨 환자는 140에 뭐 이제 이런 식인가 이제 이런 식으로 데이터가 나왔고 이 HOT 트라이얼이 아주 옛날에 98년에 나온 데이터인데 이건 다이아스톨릭 BP 고를 본 연구로 이제 90보다 낮은 거랑 80보다 낮은 거를 목표로 했는데 결론적으로는 85대 81 정도의 비교 연구였습니다. 이때 이 낮은 81로 유지하는 게 훨씬 좋기 때문에 그래도 85보다는 낮은 게 낫겠다라고 해서 기존 예전의 데이터에서 이제 140에 85라는 좀 이제 약간 다이아스톨릭이 왜 85일까 뭐 이제 이런 데이터가 나왔습니다. 그런데 아까도 보셨듯이 이제 스프린트 데이터가 모든 고혈압 가이드라인을 엄청나게 바꿔놨는데 여기는 이제 당뇨 이 어코드 BP가 실패했기 때문에 당뇨가 빠졌습니다. 당뇨를 빠진 환자를 대상으로 해서 비교를 했더니 136보다는 121이 훨씬 좋더라라는 데이터를 보여줘서 이 당뇨가 고위험인데 왜 당뇨는 빠지고 딴 애들만 이게 좋은 건가라는 이제 의문증이 날 수밖에 없죠. 그래서 또 나온 데이터가 그 어코드 BP 트라이얼 환자 중에 스프린트 엘리저블 파티시펀트 그러니까 여기 그 당뇨 환자들 중에서도 조금 이제 고위험군으로 뽑을 수 있는 그룹만 뽑은 거죠. 카디오바스큘러 디지즈가 있는 환자나 CKD 환자 75세 이상 프레밍함 리스크 스코어 10이어가 15% 이상으로 고위험군 환자만 뽑아서 여기를 스탠다드 인텐시브로 비교를 했더니 여기서는 확실히 아웃컴이 차이가 났습니다. 그래서 아, 당뇨 환자에서도 인텐시브가 좋겠다라는 이제 서포티브 할 수 있는 데이터가 나왔다고 할 수 있겠습니다. 그래서 이제 이 뒤로 나온 데이터들에서는 이제 혈압을 낮추라라고 얘기를 하고 있고, 당뇨도 당당하게 이제 다른 그 고위험군과 마찬가지로 이제 130배 가깝게 낮출 수 있으면 좀 더 낮춰보자, 뭐 이제 이런 식으로 당뇨 이제 타겟이 좀 낮아졌습니다. 그래서 ESC에서도 여기 당뇨가 있는 환자들은 혈압 타겟을 뭐 이제 이런 식으로 해서 130 정도 할 수 있으면 130, 80 정도 더 낮출 수 있으면 낮추는 방향으로 가고 있고, 이제 그 레코멘데이션 하는 약물은 라스와 CCB 또는 thiazide-like diuretics 쪽으로 해서 이제 레코멘데이션이 되고 있습니다. 뭐 이 표는 예전부터 많이 보셨겠지만 뭐 이런 식으로 약은 ACE 이니비터 ARB 또는 더하기 CCB 또는 다이우레틱스 이제 이런 식으로 사용을 하실 거고요. 이제 요거는 예전에 나왔던 이제 고혈압 학회 가이드라인, 아까 말씀드린 대로 당뇨병이 심혈관 질환이 있으면 130에 80, 없으면 140에 85, 이제 오히려 굉장히 저희가 당뇨가 고위험군이라는 건 잘 알고 있는데, 이렇게 좀 타겟 자체가 사실 좀 저희가 마음에 들지 않던 상태였는데, 다행히 이제 서포팅한 데이터들이 있어서 이제 올해 5월에 발표가 됐고, 지금 올해 받으신 아마 그 이번 학회에서 받으신 그 가방 안에 고혈압 진료 지침이 있습니다. 그래서 이걸 좀 읽어보시면 도움이 될 것 같고요. 여기서 보시게 되면 가장 큰 뭐 여러 가지 전반적으로 타겟이 좀 낮춰진 것도 있고요. 특히 당뇨병에 같은 경우에는 당뇨가 있는 환자, 합병증이 없는 고혈압 당뇨 환자에서 고위험도 당뇨병으로 되는 환자는 130에 80까지 낮추는 것으로 이제 레코멘데이션을 하고 있고, 기타 이제 중저 위험도가 아직까지 그 에비던스가 좀 명확하지 않아서 140에 90으로 이제 되어 있기는 합니다. 그래서 이제 당뇨 환자가 당뇨 외에 심내혈관 질환 위험인자가 한 개라도 있게 되면은 그때는 고위험군으로 들어가게 되니까 이런 리스크 팩터를 잘 따져서 타겟을 좀 더 낮추는 방향으로, 그러니까 너무 막 이렇게 나이가 많고 뭐 이렇게 배들이 든 상태인 사람들까지는 아니더라도요, 가능하면 혈압을 좀 낮춰주시는 게 좋을 것 같습니다. 그래서 뭐 이제 미국 당뇨학회에서도 역시나 마찬가지로 타겟은 이런 식으로 130에 80, 리스크 팩터가 높은 사람의 경우에는 130에 80으로 얘기를 하고 있고, 10year 리스크가 15% 미만으로 이제 고위험군이 아닌 경우에는 아직은 140에 90 정도로 얘기를 하고 있습니다. 약은 뭐 아까 말한 대로 기본적인 ACE 이니비터 또는 ARB, 뭐 그다음에 이제 그런 식으로 얘기를 하고 있고요. 그래서 이런 식으로 이제 돼 있고, 그 우리나라 사실 당뇨학회가 작년에 이제 당뇨병 진료 지침이 나왔는데, 여기 보시면 사실 여기는 저희 옛날 2018년도 고혈압학회 가이드라인하고 똑같이 돼 있어서 조금 혼란스러우실 수 있을 것 같아서 일단 얘기를 조금 드리는데, 사실 당뇨학회에서 이 지침을 만들 때 사실 같은 나라에서 서로 다른 이제 레코멘데이션을 하면 안 되니까 사실 저희 고혈압학회 지침을 따라서 좀 만든 게 있습니다. 그래서 아마 여기도 좀 시간이 지나면 다시 변화가 되지 않을까라고 생각이 되고요. 기본적으로 새로 이제 저희가 업데이트된 그 데이터에 따라서 좀 타겟은 낮춰야 되지 않을까라고 생각을 하시면 될 것 같습니다. 그래서 이제 근데 과연 이제 고위험군은 130에 80으로 하는 게 맞는데, 그럼 고위험군이 아닌 로우 인터미디에이트 그룹은 140에 90이 괜찮나에 대해서는 사실 아직 연구가 좀 더 필요한 건 맞고, 이제 이런 데이터들을 좀 보시면 당뇨 환자를 이제 기준으로 해서 이제 그 리스크를 본 건데, 사실 보면 고령보다 오히려 나이가 젊은, 아무래도 좀 더 그 로리스크가 더 많을 이런 환자들인데, 여기가 혈압이 낮을수록 리스크가 좀 더 많이 스티프하게 올라가는 걸 볼 수가 있어서, 사실 이런 환자들이야말로 혈압을 좀 더 잘 조절해 줘야 되는 그룹이 아닌가라는 이제 우리나라 데이터도 있고요. 최근에는 아까 보신 그 스텝하고 이제 어코드 BP는 페일했지만 어코드 BP와 스텝을 이제 풀드 아날라이시스한 데이터를 좀 보여줬는데, 아까 보시다시피 당뇨가 너무 데이터가 다이버스하게 나오니까 이제 타겟도 사실 그때까지 좀 이제 되게 다양하게 나오고 하니까, 이거 옛날 데이터들은 빼고 최근에 어코드 BP와 스텝 이 연구에 들어갔던 사람들을 이제 인텐시브하고 이제 스탠다드 BP로 이제 뽑아서 보고, 이 두 개 데이터는 사실 네거티브, 그러니까 스텝은 포지티브인데 여기서 당뇨 환자만 보게 되면은 뭐 인터액션은 없지만 약간 좀 애매하게 좀 걸리는 면이 있습니다. 그리고 어코드 BP는 네거티브였고, 근데 이 둘을 풀드 아날라이시스를 해서 분석을 이제 하였더니 136과 이제 인텐시브는 127 정도, 이제 한 10 정도 차이가 나는 이제 민 SBP 값이 나왔고, 이거를 비교했을 경우에는 프라이머리 아웃컴이 한 23% 정도 이제 좋아지는 것을 보여줄 수가 있어서 이런 그 전반적인 당뇨, 이제 고위험군 외에도 전반적인 당뇨에서도 타겟을 조금 낮추는 걸 고려할 수 있지 않을까. 뭐 이제 아직은 뭐 확실하게 컨펌되거나 RCT로 지금 뒷받침이 확실히 되지는 않지만 이런 RCT들을 풀드 아날라이시스 결과에서도 조금 혈압을 낮추는 것을 얘기를 하고 있어서 이제 좀 고려를 해보실 것 같습니다. 사실 가장 차이가 난 것은 이 스트로크를 굉장히 많이 줄여줬다고 되어 있어서 전반적인 프라이머리 아웃컴에서 이제 스트로크가 그 감소하는 효과가 굉장히 컸다라고 얘기를 할 수가 있겠습니다. 사이드 이펙트는 아까 스텝에서는 사실 당뇨병 환자만 봤을 때도 뭐 크게 문제는 없었고 아까 어코드 BP가 사실 혈압이 조금 더 낮게 측정이 돼서 그런지 아무튼 하이퍼텐션이 조금 더 많았던 것으로 되어 있습니다. 그래서 이제 혈압은 가능한 한 당뇨 환자들에 있어서 지금 현재까지는 고위험군은 130에 80, 이제 고위험군이 아닌 경우에는 140에 90 정도로 되어 있는데 아마도 이제 톨러러블하고 환자가 그러면은 추후에는 좀 더 낮출 수 있는 방향으로 좀 더 약을 써서 잊어버리시지 마시고 그냥 내버려 두지 말고 항상 혈압을 좀 더 컨트롤을 잘 해야겠다라는 생각을 좀 갖고 계셔야 될 것 같습니다. 마지막으로 이제 이거 좋은 자리 마련해 주신 이 올메살탄 얘기를 조금만 드려보면 사실 올메살탄 그 아까 당뇨 환자에게 컴플리케이션이 제일 중요한 게 레날 컴플리케이션입니다. 그래서 레날 컴플리케이션을 줄이려면 마이크로알부민유리아를 줄여야 되는 거죠. 그래서 올메살탄이 이 마이크로알부민유리아를 당뇨 환자에서 줄일 수 있는가에 대한 이제 RCT 데이터 조금 보여드리면 이제 4,447명 환자 당뇨 환자에서 올메살탄과 플라시보로 나눠서 이제 얘기를 했고 처음에는 이제 마이크로알부민유리아가 없었던 이런 환자를 대상으로 해서 했고 사실 혈압은 그 연구 내내 잘 유지가 똑같이 비슷하게 유지가 됐던 그런 군입니다. 그런데도 놀랍게도 3년 정도 팔로우를 했더니 올메살탄 사용군에서 이 마이크로알부민유리아 발생이 훨씬 적어서 역시 이제 이 약을 쓰는 게 그 마이크로알부민유리아를 줄일 수 있고 결국은 컴플리케이션을 좀 줄일 수 있지 않을까라고 생각이 되고 이제 ARB가 사실 그 알부민유리아를 줄인다라는 건 잘 알려져 있는데 이 알부민이 모두 다 같은 ARB인가에 대해서 한 번만 조금 보시면 사실 이 마이크로알부민유리아를 줄이는 효과를 프로테인 유리아를 줄인 효과를 보시게 되면 이 안지오텐신 리셉터에 바인딩하는 거에 따라서 이 ARB라고 해도 다 같은 ARB라고 해도 포텐시가 좀 다르기 때문에 다른 로살탄, 발산탄, 칸데살탄에 비해서 올메살탄이 훨씬 더 프로테인 유리아를 효과적으로 더 줄여주는 걸 알 수 있어서 약을 같은 ARB를 고르실 때도 혈압 강화 효과, 이제 이런 마이크로알부민 유리아 등을 생각하셔서 약물을 좀 고려해 주시면 될 것 같습니다. 네, 그래서 경청해 주셔서 감사합니다.
네, 굉장히 많은 내용을 잘 정리해 주셨고요. 점심 세션이긴 한데 혹시 플로어에서 질문 있으실까요? 그러면은 간단하게 제가 정리를 좀 하겠습니다. 오늘 점심 세션은 대웅과 다이치 상교에서 제공해 주셨고요. 노인 정의가 제일 중요하지 않을까 싶고요. 노인 고혈압에서 나이를 흔히 뭐 60세로 잡는데 지금 뭐 노인은 이미 75세라고 해야 되지 않을까 싶고 지금 스텝 연구가 여러 번 등장을 했는데 저도 이제 스프린트 연구에서 과연 고령 고혈압 환자에서 특별한 부작용 없이 아웃컴을 줄일 수 있겠는가 한 의문이었거든요. 근데 이번에 스텝 연구를 통해서 60세에서 80세까지 한족이긴 한데 그래도 동양인이고 그 와중에 이제 26% 정도의 프라이머리 아웃컴을 줄였고 상당히 의미 있는 데이터고요. 저도 올드 에이지에서도 적극적인 좀 혈압 조절이 필요하겠다는 것을 좀 받은 아주 중요한 메시지였고요. 그 중에서 사용된 약의 60%가 올메살탄 베이스로 이용이 됐고요. 올메살탄과 암로디핀, 그다음에 그 다이아자이드 이뇨제, 그러니까 세비카 HCT, 올메텍 이런 식으로 이 약들이 60% 이상이 사용이 돼서 긍정적인 효과를 얻었기 때문에 아마 선생님들 치료에 활용을 해주시면 아마 좋지 않을까 싶습니다. 두 번째는 아마 고혈압처럼 아마 엑스퍼트들의 어떤 개인적인 경험이 중요하게 작용하는 그런 임상 영역도 없다고 보거든요. 그러니까 뭐 당뇨 환자 저는 개인적으로는 140에 90이긴 한데 뭐 예를 들어서 55세 당뇨 환자다 그럼 140에 90으로 조절하실 겁니까? 저는 130 타겟팅 해야 된다고 보고 있고요. 그런 여러 가지 뭐 가이드라인이 나와 있지만 여러 선생님들 필드에서 엄격한 혈압 조절의 혜택을 보실 수 있기에 기대하고요. 그런 측면에서 이제 올메텍과 다이치 산교의 그 세비카 HCT가 저희들이 초이스해 볼 수 있는 약 중에 하나다. 그렇게 정리하면 될 것 같습니다. 네, 장시간 경청해 주신 청중 여러분께 감사드리고 두 분 연자쌤들께도 감사드립니다. 자리 마련해 주신 대용과 다이치에도 감사드립니다. 네, 이번 세션은 마치도록 하겠습니다. 감사합니다.
네, 안녕하십니까. 점심 맛있게 드시고 좀 쉬셨는지 모르겠습니다. 이제 스페셜 렉처 세션을 시작하도록 하겠습니다. 오늘 스페셜 렉처는 일본의 아주 저명하신 이토 교수님을 모셨습니다. 잠깐 소개를 해드리겠습니다. Let me introduce the professor, Dr. Satoyoshi Ito. He is graduate from Tohoku University and get a PhD in same university. He done fellowship in Henry Ford Hospital. Since then, she moved to Tohoku University School of Medicine and working at professor same hospital. As a professor and head division of nephrology, endocrinology, and hypertension. Now she's a professor emeritus in Tohoku University. His topic today is I'm sorry.
MR blockade.
MR blockade in hypertension treatment.
Thank you. Thank you, Chairman and ladies and gentlemen. 안녕하세요. 저는 이토 사다요시입니다. 초대해 주셔서 대단히 감사합니다. I'm speaking MR blockade in hypertension treatment today, and this is my COI. MR blocker. It's well known that MR plays important roles in various physiological and pathological conditions. It has been shown that spironolactone and eplerenone, which are steroidal MR blockers, are effective in the treatment of heart failure, treatment-resistant hypertension, and chronic kidney disease. For example, this is a very famous study by Dr. Pitts that adding spironolactone to the standard therapy of the heart failure reduced mortality about 30%. This effect was shown independent of plasma aldosterone concentration. So it's not level of aldosterone that affect this effect. In addition, Brian also showed that spironolactone compared with doxazosine or bisoprolol reduced blood pressure much more effectively in resistant hypertensive patients. Also, spironolactone in CKD patient, Bianchi et al. Showed that in the standard treatment therapy with there was no change in proteinuria over 1 year. However, in spironolactone, 25 milligram reduced proteinuria to the half as compared with standard therapies. And GFR reduced temporarily in the first month and then recovered over 12 months. And finally, GFR was even better in the spironolactone treatment group as compared with standard treatment. So, however, studies have also elucidated limitation of these steroidal MRBs, including both renal-related, like hyperkalemia, and off-target side effects, sex hormone-related, such as gynecomastia. And continuous effort to achieve more safe and efficient inhibition MRs have advanced toward development of a novel class non-steroidal MR blocker, such as esaxerenone, which is approved for hypertension, and finerenone for type 2 diabetic CKD patients. These new non-steroidal MR blockers has a very strong binding to the MRs as compared with non-steroidal MR blockers, such as IC53.7 and 18 compared with hundreds or over. And there's no sex hormone-related side effect, and also have very, very long half-life. Interestingly, hypotensive effect was stronger in esaxerenone compared with phenylalanine. However, recent study, I talked about Louis Lope. He analyzed that, and then nighttime blood pressure was effectively reduced by even phenylalanine. So this blocker is very different from the other MR antagonists. It's not a competitive antagonist. It's a blocker. It's bind to the receptor very deep inside, and then the bulky style of blockade. So it's very strong, and there is no side effect compared with mineralocorticoid receptors or no steroidal MRBs. Today, I will talk about clinical study with esaxerenone and also clinical study with phenylalanine. So in the clinical study of esaxerenone, we studied essential hypertension, placebo-controlled, combination therapy with other antihypertensive drugs, in comparison with eplerenone. And also we studied type 2 diabetic patient with microalbuminuria and macroalbuminuria. Also studied the CKD patient with eGFR 30 to 60 millimeter per minute, and grade 3 hypertension and primary aldosteronism patient. Let me show a couple of studies. First, this is an essential hypertensive patient. Blood pressure, baseline blood pressure is 155/100, and eGFR was 78. And compared with eplerenone, esaxerenone 2.5 milligram showed similar or even slightly better antihypertensive effect. And 5 milligram showed about much stronger effect, about 70 millimeter mercury reduction of systolic blood pressure. And interestingly, we studied many of the analysis, and we have shown that PAC, plasma aldosterone concentration, does not affect the effect, antihypertensive effect of esaxerenone. Even lower, normal PAC patient has better response as compared to higher PAC patient. And in contrast, PRA, which matters very much, the patient who had a low plasma PRA patient had better response, suggesting that like a sodium intake, low PRA patient has a characteristic like a diabetic patient, older patient, high salt intake, obesity, or so on. So this patient is very responsive to the esaxerenone. Also, Dr. Carrillo showed analysis of 24-hour blood pressure and showed that they normalized diurnal pattern of blood pressure. So riser, they reduced the morning surge, and deeper did not affect very much. Non-deeper and extreme deeper. Non-deeper, they reduced blood pressure to the deeper patterns. We studied not only these subgroups, but also other groups, and they all show that diurnal pattern was very much improved by the MR blockers. And problem is the incidence of hyperkalemia. We compared with eplerenone, esaxerenone had slightly higher incidence of higher hyperkalemia. However, there was no dose response between in esaxerenone groups, 2.5 and 5 milligram, did not change very much. And it's only about 0.3% or 0.6%. So this shows that esaxerenone is relatively safe and very effective in the essential hypertensive patient. We also study in the type 2 diabetic patient and microalbuminuria. These are randomized, double-blind, placebo-controlled clinical trials. And maximal RAS inhibition was also, this patient had a maximal RAS blocker. And then we, on top of that last blocker with added placebo or esaxerenone, 2.5 milligram for 52 weeks, 52 weeks. So that means about 1 year. So number of about 200, little bit over 200, and age is 76. Systolic blood pressure is 140, so it's relatively good for the patient with microalbuminuria and diabetes. UACR is 100, and eGFR is about 70. And then in this patient, remission, that means albuminuria, microalbuminuria became normal albuminuria, and also more than 30% decrease in UACR. Remission rate is 22%, and UACR decrease more than 30%. It's not about 70% of patients achieved 30% of microalbuminuria reduction. And ratio, baseline and after treatment, the baseline ratio is about 0.60%. So virtually, on average, about 60% of microalbuminuria reduced, reduction of 6%. And discontinuation is about 4%. So it's very strong for antiproteinic effect has, these MR blockers. And this change in UACR is very important in terms of the future of this patient, because many studies have shown that reduction of UACR in the first 2 years or 1 year will predict the future of that patient, like end-stage renal disease. When UACR decreases about 30%, about 20% of patients is actually saved from end-stage renal disease. And also, we have shown that in the study in the CKD, diabetic nephropathy, and grade 3 hypertension, because I just summarized it as only a result. In CKD, about 30 to 60 ml of eGFR, baseline, last inhibitor was baseline therapy, and 160 and 92 the baseline blood pressure, 18 millimeter mercury reduction was observed. And diabetic patient 14, and grade 3 hypertension, that means 180 or 100 millimeter mercury, and there is 21 millimeter mercury. So this MR blocker seems to be very strong in hypertensive, lowering the blood pressure in many conditions. From my experience on this esaxerenone, you can expect about 15 millimeter mercury of decrease, regardless of the patient condition, whether the patient has diabetes, CKD, or they are treated with ARBs, beta blocker, anything. It's about 50 millimeter mercury. It's a consistent decrease in blood pressure on average. Now I'd like to talk about phenylalanine on chronic kidney disease. This is published in New England Journal of Medicine. This study with Dr. Bakris includes a patient with micro or macroalbuminuria, but HFrEF was excluded. And the patient has 25 to 60 when they have microalbuminuria, reduced GFR. And also macroalbuminuria, they extend to 75 millimeter ml per minute in these populations. And then study, as you know that they have many good renal event. It's about 15% decrease renal event. There was a little blood pressure decrease, and the hyperkalemia was not so much. And also, this study also showed that very strong reduction of UACR. They also study much better GFR patient with macroalbuminuria. In this study, this was actually aimed for the heart event rather than renal event. In this study, primary event was a cardiac event. And they have shown that significant reduction of cardiac event. Renal event was unfortunately did not reach statistical significance. And then they combined all of these studies and they analyzed together. So remember that microarrhythmic patient, they have eGFR 25 to 90, and macroarrhythmia patient 25 over. And then this study showed that actually cardiac event was reduced significantly. Renal event was also reduced significantly when then combined two data together. Especially renal event, more than 57% decrease in GFR was significantly lower in the finerenone group as compared to placebo, and also more than 40% decrease in GFR event was lower in the finerenone group as compared with placebo group. And Louis-Rope analyzed this Figaro DKD studies with about the renal event. They study whether the UACR matters for the renal event. Then here, UACR more than 300 macroarrhythmia and microarrhythmic patient. They have shown that when the patient had macroarrhythmia, finerenone had much better, strong effect as compared with microarrhythmic patient. But remember that in this Figaro studies, eGFR of the macroarrhythmic patient is higher than 60. Again, here, this patient had a higher eGFR, and macroarrhythmic patient had higher GFR. A microarrhythmic patient had lower GFR. So we have to remember this point very clearly. So renal event, urine protein matters rather than baseline GFR. Here, again, microarrhythmic patient higher than eGFR, higher than 60, they had a less event than those with microarrhythmic patient. So why this occurred? There is many speculation of the mechanism consideration, and MR is involved in inflammation and also metabolism, the hemodynamics. And then inflammation may be a very important issue. Dr. Nagase, Shibata, and Fujita et al. Have shown that MR is actually activated not only by the ligand aldosterone, but also other mechanisms like LAC1s, especially when they have a dyslipidemia, obesity, hypertension, and diabetes. This study is a study published a long time ago. It's a very important study, I think, when they study MR expression, SGK1 expression, which is downstream of MR activation, show that very strong relationship with albuminuria and MR activation. So especially when they have a high proteinuria or proteinuria, it is very likely that MR is activated. Therefore, MR blockade is very effective in this situation. Indeed, this study of Dr. Bakris have shown strong reduction of UACR without change in blood pressures. Why that's happened? So decreased albuminuria may be due to inflammation, but this decrease is very quick. So it has to be some hemodynamic mechanism also should be involved. So especially tuberoglomerular feedback is one of the mechanisms which I think is involved in this mechanism. Here I have shown that a long time ago that increasing NaCl concentration at the macula densa actually constricts afferent arteriole. And this tuberoglomerular feedback is actually maintains glomerular capillary rhythm. As NaCl concentration increases in the macula densa, the GFR decreases, right? Then when the NaCl concentration increases, then GFR decreases. So there is a very nice synchronization, the rhythm of glomerular capillary pressure. So this is a curve of tuberoglomerular feedback generated by the micropuncture study. So basically, glomerular capillary pressure is actually oscillating between small range about this. How about in diabetes? In diabetes, it's been shown that diabetes proximal tubular reabsorption is increased. Therefore, less NaCl concentration at the macula densa. Therefore, SGLT2 inhibition is actually restores TG feedback. This is a mechanism Dr. Chani et al. Wrote in the review paper, which is generally believed good. So, there are 3 alterations in TGF in the diabetes. First, is difference in the operation point. In diabetes, there is increased proximal tubular reabsorption, so decrease NaCl at the macula densa, which will increase glomerular capillary pressure, but also make less oscillation at this point. Here you will have this kind of normal oscillation, but there is less oscillation over here. And for example, this increased proximal tubular pressure reabsorption can be mimicked by furosemide. There's an interesting study where they gave furosemide and measure efferent arterial blood flow. So when they giving the furosemide, there was a nice oscillation before furosemide, and then after furosemide, GFR increased, and there was no oscillation anymore. So aldosterone actually affect this tuberoglomerular feedback. There is a decrease in GFR, constriction with afferent arteriole when the NaCl concentration increased. But when aldosterone was added in the medium, there was less decrease in luminal afferent arteriole diameter. So aldosterone attenuates TGF. So this means that TG feedback in the CKD or loss inhibition or MR activation, curve itself is upward and shifted, and less decrease, this less slope in the MR activation. The DKD patient has operating point here, and there was less oscillation. If you gave SGLT2 inhibitor, it will shift over here, but still there was not not normals yet. When you gave MR blockers, now you will normalize this TG feedback toward the normal directions. So DKD here and MR blocker alone will reduce, make this curve like this and reduce over here. When you give SGLT2 inhibitor, it will reduce over this. So there's a possibility that a synergistic effect, SGLT2 inhibitor and MR blockers, which is theoretical consideration. However, recent study, theoretically, in the DKD, you will have a glomerular capillary pressure like this, high and less fluctuation. RAS inhibitor will make efferent arterial dilation. So we will have a less glomerular capillary pressure, but not normal oscillation rhythm. When you give MRV and SGLT2 inhibitor, you will have this way less glomerular capillary pressure and normalized rhythm over here, normalized rhythm of the glomerular capillary pressure. So this is only a theoretical consideration, but this study, like Rossing et al., recently published a very interesting sub-analysis, phenylalanine in patient with chronic disease and type 2 diabetes by sodium glucose, SGLT2 inhibitors. They have shown that without SGLT2 inhibitor, eGFR decreased 3.69. Difference is 3.69. But after 4 months to the end, there was a significant decrease in GFR reduction. So seems that GFR reduced much in the short time, it decreased, but stabilized thereafter when they combined. This is very interesting studies. FT confirms this observation with much more many patients probably, and also need some studies, clinical and physiological studies as well. So in conclusion, non-steroidal MR blocker seems to be a very promising antihypertensive and organ protective agent. Further study with non-steroidal MRBs are expected to clarify important role MR in various physiological and pathological conditions. Proper use of MRB in combination with ARB, any SGLT inhibitor, and other medicine may help us control blood pressure and metabolic diseases. 현종회 주셔서 감사합니다.
Thank you very much, Dr. Ito. Your lecture is very nice and informative. It's very recent MR blockade and hypertension, also cardiovascular field. Is there any question or comment in the floor? No, we have time to plaque of appreciation.
이제 시간이 돼서 세션 시작하겠습니다. 저는 가톨릭의대 김재형이고 오늘 같이 좌정을 봐주실 분은 이화의대 편욱범 교수십니다. 오늘 4개 발표를 듣고 그 다음에 4분 패널리스트의 패널을 듣고 그 다음에 여기 오신 분이라든가 온라인으로 접수하신 분의 질문을 받도록 하겠습니다.
예, 안녕하세요. 이대 서울동아리에서 근무하는 편욱범입니다.
예, 그럼 시작하겠습니다. 첫 번째 연자는 을지의대 박상민 교수께서 General Principles of Central Venous Blood Pressure Measurement에 대해서 강의를 해주시겠습니다. 박상민 교수는 세브란스를 졸업하시고 지금 현재 노원 유니버시티의 교수로 재직하고 계십니다. 박 교수 부탁드립니다.
소개 감사합니다. 제가 오늘 올릴 말씀은 주로 센트럴 블러드 프레셔의 그 원칙과 임상적인 적용에 대해서 그 인트로덕션을 하는 자리로 좀 삼아보도록 하겠습니다. 첫 번째 부분에서는 우리 알고 있는 말초 혈압 측정의 한계와 중심 혈압 측정의 어떤 필요성에 등을 좀 언급을 할 거고요. 두 번째 파트에서는 중심 혈압 측정에 있어서 실제로 어떤 부분이 좋고 어떤 부분이 문제가 있는지를 좀 스터디 위주로 좀 소개하고 마지막 부분에서는 중심 혈압의 임상적 적용 범위에 대해서 말씀 올리도록 하겠습니다. 네, 지금부터 한 117년 전에 그 니콜라이 크로토코프가요, 군대에서는 군 세미나에서 처음으로 이렇게 브라키알 그 청진법으로 해서 이렇게 혈압을 측정하기 시작한 지가 됐습니다. 이것이 앞으로 이제 거의 120년 가까이 지금 현재 전통적으로 이어지고 있고, 최근에 이 청진법의 변화가 있긴 하지만은 여전히 그런 청진이나 이제 말초 혈압, 브라키알 블러드 프레셔 측정의 중요성은 굉장히 강조되고 있는 것 같습니다. 우리가 실제로 재고 싶은 혈압은 사실은 이제 브라키얼 아터리의 프레셔가 아니고 그 에올틱 심장에 가장 가까운 쪽에서 측정하고자 하는 프레셔이죠. 그래서 하지만 이게 1, 2, 3단계로 건너가면서 약간 변형이 되기 때문에 우리는 가급적이면 말초지만 최대한 중심 혈압 쪽에 가까운 혈압을 재는 게 우리가 목표가 되겠습니다. 그 이유는 선생님들 다도 공유하시겠지만은 이 시스톨릭 블러드 프레셔가 2mm만 떨어져도 스트로크에 의한 사망률과 기타 심장병에 의한 사망률을 약 10% 7% 이상 줄일 수 있기 때문에 이 혈압 2mm이 사실 별거 아닌 것 같지만은 굉장히 중요한 받침이고요. 정확한 혈압 측정이 매우 중요할 거라고 생각이 됩니다. 센트럴 블러드 프레셔가 처음 이제 언급된 스터디는 소위 카페 스터디가 되겠습니다. 2000년 초반에 아테놀하고요, 그 CCB 베이스로 이렇게 스터디를 했는데 브라키얼 BP가 오히려 CCB가 좀 높고 다이아스톨은 그 반대였고요. 그런데 실제로 이벤트는 CCB가 스트로크 프리벤션에 훨씬 유리한 그 데이터를 얻었습니다. 그래서 여기서부터 도대체 왜 이럴까 고민하는 과정에서 바로 센트럴 블러드 프레셔의 개념이 등장했습니다. 그래서 보다시피 심장을 떠난 피가 이렇게 여행을 하면서 대동맥을 거쳐서 이 페리페럴 아터리에 이렇게 멀어질수록 이렇게 파형이 점점 달라지는 것을 이렇게 가리켜서 우리가 페리페럴 블러드 프레셔의 패턴과 센트럴 블러드 프레셔의 차이가 있다는 것을 우리가 컨셉으로 해서, 원래 측정은 사실은 이제 인베시브하게 프레셔 와이어를 통해 재는 게 맞겠지만은 이렇게 할 수 없기 때문에 넌 인베시브하게 우리가 측정을 하는 방법을 고안하게 된 것 같습니다. 젊은 이제 대동맥과 나이가 먹은 스티픈 대동맥 탄력이 있냐 없냐를 따지는데요. 이게 보다시피 이게 피가 뿜어져 나서 다시 이제 페리페럴 리센스를 통해서 돌아올 때 이와 같이 약간 반응의 속도라든지 반응의 차이가 있습니다. 그래서 젊은 대동맥을 약간 실제로 떠난 걸 보면은 리바운드 때문에 이게 리플렉스가 이 부분에 걸치게 되고, 올던 스티프 에올타는 굉장히 빠르게 리바운드돼서 시스톨이 다이아스톨이 시작되기 전에 이렇게 얹혀진 이런 혹 같은 이제 생기게 돼서 소위 말해서 이제 펄스 프레셔 결국 모양은 이와 같이 차이가 나는 것 같습니다. 결국은 같은 이제 센트럴 블러드 140에 95가 될지언정 실제로는 올드 스티픈 에올타는 이렇게 펄스 프레셔 차이가 많이 나는 그런 원인을 찾게 되고, 이 노인 고혈압에서 보통 아이솔레이티드 시스톨 블러드 프레셔의 하이퍼텐션의 원인이 되는 것도 여기서 생각해 볼 수 있을 것 같습니다. 흔히 말로 브라키얼 아터리 프레셔가 이렇게 영거이든 올더이든 비슷하게 보이지만 실제로 동맥을 보면은 이 차이가 있고요. 동맥 두께가 이렇게 변형이 돼 있고, 이거를 잘 들어봐서 센트럴 블러드 프레셔 보게 되면은 여기서는 비로소 차이가 나게 된다라는 부분을 이제 이야기하는 것 같습니다. 이 센트럴 블러드 프레셔의 처음에 이제 펄스 토노메트리는 사실은 이제 1800년 중반에 이 프랑스의 의사 마레이 선생님이 이렇게 처음 그 프리미티브한 폼을 고안해서 지금까지 이렇게 됐습니다. 그래서 현재는 이 센트럴 블러드 프레셔는 인베시브하게 재는 방법이 있고요. 그리고 이제 우리가 알고 있는 캐로리드하고 그다음에 그 라디알 아터리 재는 방법이 그렇게 페리페라 있는데 스타디는 참 많이 있습니다. 많이 있고 이 중에서 가장 최근에 우리 현실에서 가장 많이 보는 것은 이 스피그모코하고요. 오므론의 햄 9000AI라는 장비가 되겠습니다. 스피그모코는 주로 라디아터리에서 이렇게 측정하는 거고요. 예, 마찬가지 방식이지만은 이게 그 베리에이션이 있기 때문에 햄 9000AI를 통해서 이렇게 고정을 시켜놓고 하는 방법이 있어서 조금 차이가 있는 것 같습니다. 이 펄스 프레셔를 이해할 때 중요한 것은 아까 말씀드렸던 이 리플렉스 웨이브가 온 다음에 이 리플렉스 웨이브를 중심으로 해서 추가된 혈압, 소위 오그멘테이션 인덱스가 있는데요. 이 오그멘테이션 인덱스는 P2, P1의 차이를 갖다가 이 펄스 프레셔로 나누는 게 되겠습니다. 예, 사실 이거는 이제 모든 사람이 다 똑같은 건 아니고요. 동맥의 스티프니스라든지 웨이브 리플렉션 정도 그리고 이제 이 트랜지션 타임 또는 이 나이라든지 키에 따라서 조금씩 달라질 수 있다는 부분이 허들이 되겠고요. 아무튼 이런 이렇게 측정하는 것을 갖다가 우리가 센트럴 블러드 프레셔로 이제 그 치환하는 방식에 있어서 이 하는 어떤 트랜스퍼 펑션이 있습니다. 그거를 좀 소개하려고 하고요. 이 센트럴 블러드 프레셔하고 브라키얼 블러드 프레셔는 사실은 약간 개념적으로 봤을 때 이 나이대로 보면요. 젊을수록 차이가 좀 있고요. 60대 초반이 되게 되면은 거의 차이가 없어지다가 나중에 70대가 되면 다시 차이가 이렇게 생기는 이런 특징이 있습니다. 그리고 특히 이제 우리가 좀 애매하게 보는 프리 하이퍼텐전하고요, 스테이지 1 하이퍼텐전의 환자들 보게 되면은 상당히 많은 부분이 물론 중복이 되긴 하지만은 이 설명이 안 되는 부분들이 조금씩 있어가지고요. 센트럴 블러드 프레셔가 조금 더 임상적인 역할에 있어서 좀 델리케이트한 그런 부분을 제공할 것 같습니다. 인베시브한 CBP 예를 들어보면은 제 환자 이렇게 실제로 이제 측정한 사람 제가 엔지오 방에서 한 건데요. 이 엔지오 할 때 보게 되면은 이렇게 실제로 120에 80이었는데요. 수파인 하게 되면 혈압이 올라가죠. 150에 90이고 이제 마침 그때 이제 얼거노미 테스트라고 했었는데요. 이렇게 150에 130, 150, 126 이렇게 보다시피 프레셔 차이가 나고 그다음에 이 어센딩 소라식, 디센딩, 그 앱도멘 에올타 이렇게 가면서 혈압이 계속 변하고 있습니다. 변하고 있고 이분 같은 경우는 이렇게 펄스 프레셔가 이렇게 차이가 별로 크지 않은 환자였고 이와 같이 우리가 보는 흔히 브라키얼 그 말초혈관과는 좀 다른 패턴을 보인다. 그 부분을 말씀을 드리고 싶습니다. 그러면은 이제 이런 그 센트럴 블러드 프레셔가 어떻게 우리가 임상적으로 적용시킬 것이냐? 사실 임상적인 적용에 있어서는 조금 거리가 좀 있을 수도 있는데요. 첫 번째는 이제 서로게이트 마커를 본 게 있습니다. 이와 같은 굉장히 많은 스터디가 있고요. 그리고 또 하나는 실제로 이벤트를 프리딕션 할 수 있느냐 없느냐를 갖다가 롱기튜드널 보스 스터디도 꽤 있습니다. 있는데 대규모 뭐 이렇게 연구는 없지만은 작은 이렇게 소규모 연구들이 꽤 있다고 볼 수 있습니다. 그리고 하나 특징이 이제 블러드 프레셔도 있어서 그러니까 페리페랄하고 이제 센트럴 차이는요. 이 보다시피 이제 브라키얼 블러드 프레셔는 이 BP를 떨어뜨릴수록 더 좋긴 하지만은 너무 많이 떨어뜨리게 되면은 이와 같은 이런 패턴의 커브 리니어 패턴을 보이게 되지만은 센트럴 블러드 프레셔는 이 커브 리니어가 그 스티프해지면서 많이 떨어뜨려서 좋다라는 쪽에 이런 데이터가 있어서 센트럴 블러드 프레셔를 기준으로 하게 되면은 훨씬 더 델리케이트한 어떤 그 임상적인 효과를 얻을 수 있지 않느냐라는 그런 예측이 있습니다. 우리가 이제 사실은 이제 임상적으로 필요는 없지만은 기계에서 이제 그 어널리시스 할 때 이제 공식적으로 사용되는 게 제너럴라이즈드 트랜스퍼 펑션이라는 GTF가 있습니다. 한마디로 말해서 브라키얼 아터리의 이 펄스 모양을 이 에올틱 루트에서 나오는 걸로 이렇게 변형을 시키는 과정인데요. 그거는 이제 여러 가지 수학자들이 잘 활용해가지고 만든 공식이고 이 보다시피 블렌드 알트만 어널리시스에 보면은 이렇게 크게 문제가 없이 잘 사용되는 걸로 알 수 있습니다. 표준 방법으로는요. 자, 두 번째 파트에서는 실제로 어떤 부분에서 이렇게 좋고 어떤 부분 나쁜지를 말씀을 올리도록 하겠습니다. CBP는 실제 이론적으로는 굉장히 너무나 중요하고 릴리번트한 방법입니다. 특히 뭐 LVH라든지 하페일러, MI 스트로크 같은 걸 진단할 때 굉장히 도움이 되고요. 그런데 문제가 뭐냐면은 여러 가지 좀 피폴이나 허들이 좀 있습니다. 특히 첫 번째는 이 인터 업저버 베리에이션이라든지 또는 인트라 업저버 베리에이션이 그 스킬에 달리기 때문에 그런 어떤 숙련도에 따라서 차이가 있을 수 있고요. 또 아까 GTF 공식도 마찬가지로 이 레디얼 아터리가 이제 그 트랜스포머에 근데 굉장히 많은 여러 가지 변수들의 어떤 그런 생략이라든지 가정이 전제되어 있기 때문에 다소간 이 적용시키는데 좀 경우에 따라서는 주의를 해야 될 필요가 있습니다. 특히 이 브랑키얼 프레셔 칼리브레이션이라든지 캐로틴 아트리가 조금씩 이게 다 틀리기 때문에요. 그래서 이런 부분에 할 때는 이 기계의 어떤 어널리시스 방침을 좀 리뷰하고 하는 게 좋을 거로 생각이 됩니다. 또 하나 이제 또 재밌는 것은 이 나이가 더 먹어가면은요, 이 스티프니스, 소위 PWV 수치하고 이 아까 말씀드렸던 이렇게 그 오그멘트 인덱스 값이 이렇게 이런 관계를 보이게 되고 적당히 봐서 이제 60 정도 넘어가게 되면요, 이 커브가 이렇게 커브 리니어해지면서 이게 서로 좀 불일치가 오는 부분이 있다는 부분을 말씀드려야 될 것 같습니다. 그리고 또 하나 이제 결정적인 것도 이제 섹스와 에이지가 중요한데요. 이 보다시피 CBP 같은 경우 우리나라 데이터입니다. 보시면은 이 오그멘트 인덱스가 봤을 때 이 남자와 여자 이렇게 81, 이렇게 88 차이가 나게 되고요. 그다음에 키가 이제 봤을 때 이 작은 사람은 81인데 큰 사람은 67 이렇게 또 여자도 마찬가지로 이 키가 크면은 오그멘트 인덱스가 떨어지는 경향이 있다고 볼 수 있습니다. 그 외에 나머지 문제들도 많이 있고, 근데 첫 번째는 혈압계 같은 경우는 밸리데이션 방법이 굉장히 딱 좀 명확하게 정해져 있는데 이거는 사실은 밸리데이션 방법이 좀 약간 애매할 수 있고요. 컷오프 밸류라는 게 굉장히 브로드하게 있어서 어떤 부분에 대한 특정 이 세라피틱한 어떤 그런 레인지를 잡는 게 좀 어려울 수 있을 거로 생각이 되고, 그리고 이제 클리니컬리 릴리번트하게 이제 할 수 있는 방법이 이제 브라키얼이나 센트라인이나 또 여러 가지 방법들이 있기 때문에 좀 고민을 더 해야 될 걸로 생각이 됩니다. 그리고 뒷부분 선생님들이 해주시겠지만은 지금 파퓰레이션 베이스드 롱기튜드한 데이터가 아직은 좀 부족한 편이다라는 부분을 말씀드릴 수 있겠습니다. 그러면 우리나라 사람들의 중심 혈압은 얼마나 될까? 좀 우리 선생님들이 많이 하셔가지고요. 보다시피 센트럴 블러드 프레셔는 이게 젊은 사람 지나갔다가 한 60대 보면은 127 정도 된다면은 이분들의 센트럴 SBP는 약 한 10 이상 차이가 나게 됩니다. 그리고 AI 값은 이렇게 29, 34 정도 될 것 같고요. 그다음에 이거 이제 보다시피 나이 먹을수록 점점 늘어나는 쪽으로 진행하고 있고, 연령대별로 차이가 다 있습니다. 있기 때문에 연령을 특히 조심해서 봐야 될 것 같습니다. 우리나라 이제 박정배 선생님께서 과거에 이제 스타디를 좀 많이 해놓으셨는데요. 이 스타디를 보게 되면은 전체적으로 봤을 때 이 센트럴 AI, 그러니까 오그멘트 인덱스 값이 이 리스크가 없는 사람에 비해서 있는 사람들이 대체로 조금씩 높습니다. 높고 담배 피우는 사람, 고혈압, 당뇨병, 이상 질병 봤을 때 남녀 차이가 당연히 존재하고요. 거기서 특히 이 하이퍼텐션 있는 사람들하고 다이아비티스 있는 사람들이 좀 비교적 리스크보다 높은 편이라고 좀 생각을 하면 좋을 것 같습니다. 실제 어떻게 사용되는지를 말씀을 올리도록 하겠습니다. 제가 뭐 생각한 영구적인 마인드인데요. 사실은 오피스 BP하고 이제 아웃 오피스 BP 측정 차이가 좀 생길 수 있는데, 근데 여기서 이제 흔히 이제 우리가 문제되는 게 화이트 코트하고 이 마스크 하이퍼텐션인데, 사실은 제가 임상적으로 봤을 때 이 두 가지를 좀 구별하는 데 도움이 되지 않을까 생각이 됩니다. 실제 이제 연구가 많지는 않지만은 이 초록이 제출된 몇 가지 보게 되면은 화이트 코트인 경우에 우리가 화이트 코트가 왜 그 카디오바스쿨 아웃컴에 그 노멀보다 더 영향을 미치느냐를 설명할 방법이 흔치 않은데, 이 센트럴 블러드 프레셔로 설명하는 초록이 하나 있었고요. 그리고 이 마스크드 하이퍼텐션도 마찬가지로 실제로 이제 이게 마스크든인지 아닌지 센트럴로 보면 좀 감별 잘 된다라는 그런 예시가 있어서 제가 보여드렸습니다. 제가 일했던 기관에서 이제 햄 9000 AI 장비가 있는데요. 이거는 또 고정시켜서 놓고 이렇게 좀 움직임을 적게 해서 이렇게 한 장비인데요. 보다시피 이 환자 같은 경우는 그 연세가 80세인데 아주 저항성 고혈압으로 해서 혈압이 막 160, 200 아무리 혈압약을 많이 써도 계속 다이어스를 떨어지면서 더 이상 못 갈 수 있는 혈압이었는데요. 이 센트럴 블러드 프레셔를 측정해 보니까 보다시피 이 시스톨릭, 그러니까 페리페랄 155인데 센트럴 140으로 해서 여러 가지 몇 번 더 해봤더니 이렇게 센트럴 블러드 프레셔는 심하게 낮지 않다라는 걸 깨달았고요. 요걸 타겟으로 해서 이제 제가 그 치료를 했던 기억이 납니다. 그리고 이제 화이트 코트 같은 경우도 이 환자 화이트 코트 티피컬한 60대 남자 환자였는데 실제 해보니까요, 이제 그 시스톨, 그러니까 페리페럴하고 센트럴 차이가 별로 없었다는 부분을 제가 좀 확인했었고요. 그래서 결국은 우리가 잘 모르고 우리가 임상적으로 설명이 잘 안 될 경우, 해석이 안 될 경우는 센트럴 블러드 프레셔가 도움이 될 수 있겠다라는 생각을 했었습니다. 그리고 이제 제가 생각했을 때 임상적인 적용 분야가 어떤 거냐, 아직은 좀 이렇게 연구할 분야가 많이 있다 생각이 되는데요. 특히 혈압약제에 대한 효과 판정에 있어서 굉장히 유리한 측면이 있습니다. 그리고 신부전 예측이라든지 투석한 환자들의 BP 플럭츄에이션이나 또는 BP 베리어빌리티에 도움이 될 수 있을 것 같고요. 제가 봤을 때는 오간 트랜스플란테이션에도 상당히 많은 도움이 될 수 있을 것 같습니다. 이제 보다시피 CAD 환자 같은 경우는 데이터가 많지는 않지만 ACS 예측 가능하고요. 리스너시스를 예측하는 데 도움이 될 수 있다라는 내용이 있고, 특히나 이제 하나 좀 말씀드리고 싶은 것은 엘더리 페이션트 같은 경우는요, 이게 잘 안 맞기 때문에 오히려 센트럴 블러드 펄스 프레셔가 더 정확할 수도 있다는 걸 좀 첨언을 드리고 싶습니다. 이 CBP 베이스로 본 이제 고혈압 연구를 보게 되면요, 이때 보다시피 이제 약을 쓰고 나서 이렇게 그냥 센트럴 블러드 프레셔 가이드로 하는 거하고 유저얼 케어 한 그룹 봤을 때, 물론 이런 스타일로 봤을 때 여기 이 그래프는 약을 이제 먹는 개수를 말하는 건데요. 시간이 지날수록 이 센트럴 블러드 프레셔를 가지고 이제 매니지한 그룹에서 약제 수가 훨씬 적었습니다. 블러드 프레셔는 똑같고요. 그리고 실제로 이제 높더라도 이 연구자들은 중심혈압을 알고 있기 때문에 자신 있게 약을 좀 줄여가는 과정을 겪은 것 같습니다. 항고혈압제 효과를 좀 잠깐 말씀드려야 되는데요. 이 베타블로커는 일반적으로 CBP를 올린다고 되어 있는데 사실은 다 같은 베타블로커는 아니죠. 이 네비블롤이나 카베둘롤 같은 경우는 확장 기능이 있는데 실제로 연구를 해보니까 보다시피 오그멘트 인덱스가 네비블롤 같은 좀 떨어지고요. 일반 베타블로커 1차는 이게 안 떨어지고 카베둘롤 좀 애매하게 나왔었습니다. 이런 같은 스타디가 이렇게 메타 연구를 보니까 대체로 약간 좀 이런 비슷한 경향을 가졌다라는 걸 말씀을 드리고 싶고, 그다음에 이제 마지막으로 말씀드리고 싶은 게 이제 우리나라에서 김학래 선생님이 이제 보람의 병원에서 했던 스터디인데요. 이 CBP가 LV 디스펑션 예측에 도움이 된다라는 걸 했는데 보다시피 CBP하고요 EOV 프라임이 잘 코릴레이션 되는 모습을 보여줘가지고 이 센트럴 블러드 프레셔를 가지고 다이스톨 펑션을 설명할 수 있지 않나라는 생각이 듭니다. 마지막으로 신장 이식 후에 카디오 리너 신드롬이 생기지 않은 것을 예측하는 스터디가 있었는데요. 보다시피 마이크로 알부민율의 정도에 따라서 이렇게 커브가 지게 되는데 이 페리페럴 블러드 프레셔는 이렇게 좀 변형이 있는데 센트럴 블러드 프레셔는 꾸준하게 계속 올라가기 때문에 예측에 가능하다 이런 부분을 말씀을 드렸습니다. 제가 드린 말씀에 이제 정리를 하자면은 말초혈압과 이제 그 중심혈압은 이 어떤 그런 제한점에 있어서 어떤 서로에게 상보적인 관계다 그래서 말씀을 드리고 싶고요. 그리고 이제 성별 나이라 동반자라다 참고치가 틀리기 때문에 조금 더 디테일하게 봐야 된다라고, 또 하나는 이 숙련된 기술 그러니까 검사자가 필요하고, 그다음에 이제 이 고혈압에 있어서는 이제 우리가 이론적으로 이상적이긴 하지만은 제한점이 있는 부분에 있어서 어떤 환자에게 필요한가를 좀 정리해야 되는데, 특히 항고혈압제 유용성이라든지 고혈압 합병증 예측할 때 도움이 될 수 있고, 앞으로 필요하면 더 많은 그 장기적인 규모 있는 롱기튜드널 데이터가 필요할 걸로 생각이 됩니다. 감사합니다.
박 교수 많은 데이터 고맙습니다. 그럼 그다음 연자로 넘어가겠습니다. 그다음 연자는 Clinical Application of Ambulatory Central Blood Pressure Monitoring. 가톨릭 의대 조은주 교수께서 해주시겠습니다. 네, 조은주 교수는 가톨릭 의대를 졸업하시고 거기다 현재 여의도 성모병원에서 교수로 계십니다. 조 교수 부탁드립니다.
네, 교수님 소개 말씀 감사합니다. 오늘 저는 24시간 암뷸레이터리 CBP 모니터링의 클리니컬 어플리케이션에 대해서 말씀드리겠습니다. 먼저 우리가 흔히 지금 말하는 센트럴 블러드 프레셔, 그 중에서도 암뷸레이터리 센트럴 BP 모니터링이 우리가 루틴으로 클리니컬리 자신 있게 사용되기 위해서는 거쳐야 되는 몇 가지 페이스가 있습니다. 처음 말씀드리면 이 지표가 아웃컴이 달랐던 그룹 간에 달랐느냐 하는 증거를 하나 대야 되고, 두 번째, 처음에 아웃컴이 전혀 CV 디지즈가 없었던 정상인에서 프로스펙티브하게 코호트 팔로우업을 했더니 CVD가 생겼을 때 애초에 이 지표의 차이가 있었느냐를 증명을 해야 되고, 세 번째, 이런 지표가 다른 것과 비교할 수 없느냐, 그러니까 이 지표 하나가 위험적인 독립위험자로서 작용하느냐, 그 다음 네 번째는 이 지표를 가지고 우리가 치료 방법을 달리 했을 때 과연 아웃컴이 좋았느냐, 다섯 번째는 이 지표를 타겟으로 해서 과연 우리가 치료를 목표로 할 수 있느냐, 여섯 번째는 코스트 이펙티브니스가 있느냐 하는 것입니다. 그래서 제가 지금부터 말씀드리는 내용이 이 페이스에 어떤 것에 해당되는지 한번 여러분들 스스로 같이 한번 보시면 좋겠습니다. 지난 수세기 동안 CV 디지즈와 코릴레이션을 가장 강력하게 했던 것은 스포라딕 한 번째는 오피스 브라키알 BP입니다. 오피스 브라키알 BP가 115 이상 되면 올라가면서부터 전 연령대에 따라서 CV 디지즈의 리스크가 증가하고, 이 블러드 프레셔가 떨어지면 또 CV 리스크가 감소하는 그런 효과가 있었지만 치료를 시작하고 그럼에도 불구하고 여전히 전 세계적으로 카디오바스큘라 디지즈의 어떤 아웃컴 때문에 사망하는 율은 캔서와 더불어서 1, 2위를 서로 다투고 있습니다. 그래서 그 다음에 이제 여러 학자들이 트라이한 것은 목표 혈압을 낮춰볼까 아니면 브라키알 BP보다 더 강력하게 CV 디지즈를 예측할 수 있는 다른 파라미터가 있는가를 보게 되었고 그 중에 하나가 24시간 암뷸레이터리 BP 모니터링입니다. 왜냐하면 오피스 BP는 화이트 코트 하이퍼텐션이나 마스크드 하이퍼텐션을 대변할 수 없고 실제로 시스톨릭이나 다이아스톨릭 두 파라미터가 클리닉에서 잰 소위 말하는 오피스 브라키알 BP보다는 나이트 타임이나 24시간 평균 BP가 훨씬 더 CV 아웃컴을 프레딕션할 수 있기 때문입니다. 이것은 우리가 24시간 내내 환자가 어떤 받는 그 프레셔의 버든을 감안한다면 좀 더 확실한 어떤 플라우지블한 그런 얘기가 되겠죠. 아까 박상민 선생님 제대로 얘기해 주셨지만 그런 노력의 일환으로 또 하나 우리가 찾아낸 파라미터는 바로 센트럴 블러드 프레셔입니다. 이것은 프록시멀 아울타의 프레셔를 직접 측정함으로써 이루어지는데 우리가 카디오바스큘라 디지즈가 가장 그 중요한 그 고혈압에 의한 타겟 오르간 데미지라면 심장과 뇌에서 가장 가까운 이 프록시멀 아울타는 그 프레셔 자체가 심장과 뇌가 직접 겪게 되는 직면하게 되는 프레셔이기 때문에 이 프레셔 커브를 분석하는 것은 굉장히 타겟 오르간 데미지 정도를 확인하는 데 중요할 것으로 생각이 되고 뿐만 아니라 시간이 지나면서 이제 심장을 떠난 그 블러드는 각각 분지마다 부딪히고 다시 리플렉션 되는 웨이브가 생성이 되는데 그 리플렉션 웨이브는 다시 프록시멀 아울타에까지 이르게 됩니다. 이 아테리얼 스티프니스가 있는 환자들은 딱딱한 이 혈관 때문에 좀 더 빠른 좀 더 빠른 펄스 벨로시티가 생기게 되고 그래서 아올틱 노치를 중심으로 해서 시스톨릭의 서메이션 되는 경향이 있는 반면에 부드러운 혈관을 가진 사람들은 아올틱 노치가 닫히고 다이아스톨릭 피리어드에 서메이션 됨으로써 코로나리 펄퓨전 그리고 다이아스톨 때 펄사타일한 그런 프레셔가 아닌 굉장히 그 스테디한 플로어를 중요 오르간에 제공을 하게 되겠죠. 그렇지만 노인이 될수록 아테리얼 스티프니스는 증가하기 때문에 젊은 사람의 프록시멀 아울타 프레셔와 페리페럴 아울타 프레셔는 상당히 차이가 있고 암플리피케이션이 뚜렷하지만 노인이 될수록 프록시멀 아울타에 서메이션 되는 그 플로우가 굉장히 빨라지기 때문에 시스톨 때 서메이션 돼서 페리페리나 센트랄이나 큰 차이가 없게 됩니다. 센트럴 블러드 프레셔의 가장 중요한 그 어떤 그 의미를 부각시킨 데이터는 아까 말씀드렸던 카페 데이터입니다. 간단히 말씀드리면 아테노롤 베이스드 트리트먼트를 하고 암로디핀 베이스드 트리트먼트를 했을 때 아웃컴에 너무 큰 차이가 나는데 두 군 간에 떨어진 브라키알 BP의 정도는 비슷했다는 거죠. 이 원인을 찾다 보니까 센트럴 아올틱 BP의 감소가 암로디핀 베이스드 트리트먼트에 더 나았기 때문에 베타 브로커는 단순히 브라키알 BP만 떨어뜨리고 센트럴 BP를 떨어뜨리지 못하는구나. 퍼스트 라인 초이스는 맞지 않다. 그렇지만 이게 아테노리였기 때문에 그럴 수 있어서 이건 좀 더 디베이트가 있어야 되겠습니다. 그렇다면 센트럴 헤모다이나믹이 진짜 이런 올코스 모탈리티와 카디악 아웃풋을 대변하느냐? 결론은 대변한다입니다. 그렇다면 올코스 모탈리티나 카디악 아웃풋을 대변하는 여러 가지 다른 파라미터 많은데 그것보다 더 낫느냐 하는 면에 있어서는 스트롱 하트 스터디라고 그 코호트 스터디입니다. 기존에 CV 디지즈가 없던 환자를 약 6년간 팔로우업 했을 때 브라키알 펄스 프레셔보다는 아올틱 프레셔의 펄스 프레셔 특히 50 이상 됐을 때 6년 이내에 카디오바스큘라 아웃컴을 더 나쁘게 만든다라는 그런 확실한 데이터가 있어서 우리가 스테디 스테이트에서 OPC에서 재는 센트럴 BP는 확실히 이런 그 코호트 스터디에서도 좋은 결과를 보였던 것으로 보입니다. 그렇다면 이 센트럴 BP는 브라키알 BP보다 더 나은가? 굉장히 간단한 그냥 R밸류를 비교한 연구가 있었는데요. 센트럴 아올틱 그 프레셔는 심장과 뇌에 가깝기 때문에 하이퍼텐션 메디에이티드 오르간 데미지 중에 유리나린 알부민 익스크리션에는 큰 영향을 미치지 못했지만 카로티드 IMT나 앨브 매스 인덱스는 브라키알 BP도 상관이 있지만 그거보다는 센트럴 BP가 조금 더 좋다라는 그런 결론을 냈었습니다. 그래서 2020년대까지만 해도 24시간 BP, 센트럴 BP 모니터링은커녕 센트럴 BP 자체에 대해서도 페리페럴 브라키알 BP가 센트럴 아올틱 프레셔를 대변하지 못하고 센트럴 아올틱 프레셔는 카페 스터디 결과 그토록 중요하니 측정하는 것은 좋다. 하지만 방법은 어떻게 할 거냐. 방법이 다 브라키알 아테리 프레셔를 가지고 그 메저먼트를 가지고 하는 거기 때문에 두 개를 어떻게 세퍼레이션 할 것이냐. 상관없다고 말할 증거를 제시할 수 있느냐. 이제 이런 문제들이 자꾸만 대두되었습니다. 거기다가 이제 전 세계적으로 센트럴 BP의 정상치를 측정하기 위해서 다양한 연령대로 다음과 같이 센트럴 BP를 측정을 해봤습니다. 남자, 여자에서 20대부터 70대까지 또 혈압이 옵티말 정상 혈압부터 스테이지 3 고혈압 환자까지 센트럴 BP를 다 측정해봤는데 여기서 굉장히 재미있는 결과가 나왔습니다. 즉 고혈압의 그레이드와는 상관없다. 나이가 많을수록 센트럴 BP와 페리페럴 BP, 즉 암플리피케이션이 거의 미미하다. 젊을수록 암플리피케이션이 굉장히 두드러진다. 그 말은 젊은 환자에 있어서는 센트럴 BP가 상당히 디스크리미션을 할 수 있다는 것이죠. 다음 그래프에서 보면 브라키알 BP와 센트럴 BP는 상당히 코릴레이션 합니다만 같은 브라키알 BP에 있어도 센트럴 BP 차이가 30까지 납니다. 그 차이는 무엇일까? 이 환자가 가지고 있는 인네이트한 아티리얼 스티프니스 정도에 따라 다르다는 것이죠. 실제로 브라키알 BP가 높으면 센트럴 BP가 높기도 하고 브라키알 BP가 정상이면 센트럴 BP가 정상이지만 그 둘 중에 하나만 높은 사람이 있고 센트럴 BP가 정상일 때 브라키알 BP만 높은 사람들은 사실은 초기 고혈압이고 그렇게 심한 고혈압이 아니다. 이런 이제 얘기가 될 수 있겠습니다. 그렇다면 우리가 이제 자연스럽게 24시간 브라키알 BP가 오피스 BP보다 그렇게 카디악 아웃풋을 대변할 수 있다면 당연히 24시간 센트럴 BP는 24시간 내내 심장과 뇌에 가해지는 버든이기 때문에 더 좋을 것이다. 생각이 돼서 브라키알 BP보다 더 좋은가 타겟 오르간 데미지를 보는데 처음에 두 가지 연구가 브라키알 BP 24시간 브라키알 BP보다 24시간 센트럴 BP가 나을 것이 없다라는 결론이 나왔기 때문에 좀 헷갈렸습니다. 그렇지만 이것은 크로스 섹셔널 스터디로서 당시에 타겟 오르간 데미지가 있냐 없냐를 따라서 두 개를 나눠본 것이었습니다. 그러니까 각 환자들이 가지고 있는 현재 먹고 있는 약, 그 다음에 하이퍼텐션의 듀레이션, 뭐 이다른 그런 인디비주얼라이제이션 된 어떤 사정이 고려가 되지 않았었습니다. 근데 두 연구 다 똑같은 코호트에서 똑같은 그 서브젝트에서 나왔던 결과였고, 그래서 이 결과를 보고 24시간 센트럴 BP를 굳이 잴 필요가 있느냐, 24시간 브라키알 BP만으로도 충분하다라는 결론을 얻었었는데, 그 뒤에 이루어진 프로스펙티브 스터디에서는 이 에어리 언더 더 커브가 24시간 브라키알 BP도 LVH를 대변하는데 정확하지만 조금 더 센트럴 BP가 정확하다. 그 다음에 LV의 다이아스톨릭 디스펑션도 역시 조금 더 24시간 아올틱 BP가 더 대변한다라는 결론을 얻었습니다. 하지만 아직도 이 정도 가지고는 브라키알 24시간 BP보다 센트럴 BP를 더 초이스할 만한 그런 이제 에비던스는 없는데요. 아까 좀 더 영 어덜레센트, 좀 젊은 초기 고혈압 환자에서 조금 더 미묘한 어떤 서틀한 그 타겟 오르간 데미지의 변화를 대변할 것이라는 그런 데이터가 이제 나왔습니다. 여기에 인롤된 환자들은 평균 18세 나이였고 고혈압이 의심되거나 정상인 사람들이었는데요. 그러니까 고혈압이 있어봤자 초기 고혈압이고 고혈압의 듀레이션도 젊은 사람들이기 때문에 거의 비슷했겠죠. 이런 사람들에게서 페리페랄 BP와 센트럴 24시간 BP, 페리페랄 24시간 BP를 서로 비교했는데 확실히 카디오바스큘라 아웃컴에 대해서 젊은 사람에서는 쿼타일별로 의미 있게 올라갈수록 센트럴 24시간 BP가 좀 더 확실히 코릴레이션 한다라는 결과를 주었습니다. 그 뒤에 이루어진 바소텐스 레지스턴스에서도 풀도 아날라이시스를 했습니다. 클리니컬 브라키알 BP, 24시간 브라키알 BP, 그리고 24시간 센트럴 BP 전부 다 모아서 카디악, 페리페럴 바스큘라, 레날 아웃컴에 대해서 봤는데 확실히 센트럴 펄스 프레셔가 바스큘라나 레날은 아니지만 카디악 데미지를 대변할 수 있다라는 그런 결론을 내린 바 있습니다. 그래서 그 다음에 나타난 것은 이제 당뇨가 있는 CKD와 당뇨가 없는 CKD 환자에서 왜 당뇨가 있는 CKD가 좀 더 마크로바스큘라 데미지가 더 심할까? 그 원인을 24시간 센트럴 BP를 보고 같은 CKD라도 당뇨가 있는 환자에서 훨씬 더 센트럴 BP가 높다. 이것 때문에 더 아웃컴이 안 좋은 것이다. 라는 결론을 낸 바가 있는 데이터가 있고요. 다음 근데 K 센트럴 스터디라고 저희 고혈압 학회에서 이때 한국에 24시간 센트럴 BP 기계가 들어오지도 않았던 상태인데 식약처를 통해서 들어오면서까지 이제 우리 총무이사로 근무하시는 지금 이혜영 선생님이 아이디어를 주시고 전 이사장이신 김중린 선생님의 지도하에 연구가 진행이 되었습니다. 이 연구를 우리가 자신 있게 실시했던 이유는 당연히 이 클리니션들은 24시간 센트럴 BP는 당연히 더 많은 가장 많은 어떤 프록시말 아올타의 어떤 프레셔를 대변하기 때문에 심장 그리고 뇌에 어떤 중요한 이펙트를 주는 파라미터로 이미 상정을 해놓고 이것을 좋게 하는 약제는 무엇인지에 대해서 연구를 했던 바였습니다. 근데 결론적으로는 카페 스터디와 동일하게 이런 그 라스브로커와 CCB가 라스브로커와 다이ure틱스보다 더 24시간 내내 센트럴 BP를 좋게 만든다는 내용이었는데 이 논문을 처음에 서미션했을 때 두 가지 이슈가 있었습니다. 오실로메트리로 24시간 잰 거 센트럴 BP 확실하게 재진 거 맞느냐? 두 번째는 이 지표가 그렇게 중요하냐? 그냥 24시간 BP 데이터로 하면 안 되냐? 저희들은 이 24시간 센트럴 BP가 이미 좋다고 상정을 해놨는데 한 두 단계 뛰어넘어서 스터디 디자인을 짰던 것이죠. 그 뒤에 나왔던 것은 이제 SGLT2 이니비터를 가지고 이제 한 연구였습니다. 이 연구도 이미 24시간 센트럴 BP는 하나의 중요한 지표로 상정해 놓고 왜 SGLT2 이니비터가 당뇨 환자에서 올코스 모탈리티와 하트 페일리어를 이렇게 줄여줄 수 있느냐? 그것은 센트럴 BP 24시간 센트럴 BP를 감소시키기 때문이다라는 그런 결과를 내서 1년 뒤에 이제 이 연구가 이제 좋은 곳에 억셉트 됐던 그런 경우가 있었습니다. 그래서 쭉 보면 이거 클리니컬리 그럼 잘 쓸 수 있느냐? 아웃컴감에 분명히 오피스 센트럴 BP와 암블레이터리 센트럴 BP는 지표 간의 차이가 있었고요. 프로스펙티브 코호스트에서 또 차이가 있었습니다. N수는 굉장히 작았지만 그렇지만 이게 기존에 있는 다른 파라미터보다 더 인디펜던트하게 리스크 정보를 줄 수 있느냐에 대해서는 아직 연구가 없고 이거를 보고 잘 조절 안 되면 치료 방침을 바꿀 수 있느냐. 아까 박상민 선생님이 이미 그걸 보고서 치료 방침을 바꾸셨다고 했는데 사실은 에비던스는 없습니다. 저희가 이제 클리니컬리 어떤 의사의 어떤 감을 가지고 이렇게 치료를 한 것이었고요. 그다음 이걸 타겟으로 해서 치료할 수 있을 만한 그런 에비던스가 있느냐. 그다음에 이제 이 기계 하나에 2천만 원인데 이게 과연 코스트 이펙티브하냐. 그것이 문제입니다. 그래서 결론적으로는 24시간 센트럴 BP는 확실히 타겟 오르간 데미지의 발생 연관성에 있어서 24시간 브라키알 BP보다는 좋고 다만 옵티멀 칼리브레이션이 어떤 것이 더 좋은지가 문제라서 클리니컬 엔드 포인트로서 모탈리티를 포함한 일단 라지 아웃컴 스터디를 빨리 진행을 해야 된다는 것이고 그것보다도 더 중요한 것은 이제 이것을 타겟으로 해서 우리가 치료 방침을 결정하고 그것을 낮추는 노력을 했을 때 아웃컴이 훨씬 더 좋아지는 것을 보는 것이 또 남은 숙제라고 할 수 있겠습니다. 이상입니다.
이쪽 교수 수고하셨습니다. 다음 두 개는 편욱범 교수께서 좌장을 봐주시겠습니다.
네, 다음 연자를 소개시켜드리겠습니다. 아마 다음 연자는 지금 이제 앰뷸러터리로 측정하는 것과 클래시컬하게 측정하는 CBP 메저먼트가 어떻게 다른지에 대해서 조정선 선생님께서 설명해 주시겠습니다. 조정선 선생님께서는 전남대 의대를 나오시고 현재 캐톨릭의과대학 대전 성모병원에 계십니다. 강의 부탁드립니다.
네, 소개 말씀 감사합니다. 제가 오늘 맡은 주제는 앰뷸레이터리와 클래시컬한 센트럴 브로드 프레셔 메저먼트의 차이점인데요. 사실 제가 이제 클리닉에서 직접 센트럴 브로드 프레셔를 앰뷸레이터리 브로드 프레셔를 사용하고 있지 않고 이제 가끔 이제 클래시컬하게 옴론 제품 센트럴 브로드 프레셔를 간혹 재고는 있습니다. 그래서 앞에 보여주셨던 여러 이제 많은 클리니컬한 스터디들과 많이 겹치는 부분이 있을 것 같아서 빨리 넘어가도록 하겠습니다. 저의 컨텐츠는 클래시컬한 그리고 또 앰뷸레이터리 센트럴 브로드 프레셔 모니터링 디바이스를 각각 알아보고 각각 디바이스들마다 사용하는 알고리즘이 있습니다. 그래서 그런 것들에 대해서 이제 소개해드리고 그리고 발리데이션 스터디 몇 가지를 보여드리도록 하겠습니다. 앞서 여러 교수님들이 이제 그 센트럴보다 브라키얼 그리고 브라키얼보다 레디얼 아터리의 압력이 높아지고 그것을 이제 프레셔 앰플리피케이션이라고 한다라고 앞서 말씀해 주셨었는데요. 그래서 이제 넌 인베이시브하게 센트럴 에로틱 브로드 프레셔를 예측하고 측정하는 방법에 있어서는 여러 가지 복잡한 알고리즘이 필요하다고 합니다. 그리고 이제 앞서 보여드린 그 말씀을 여러 번 해주시긴 하셨는데 이제 보통 이제 그 에어타 프레셔는 여러 가지 모양으로 보인다고 합니다. 타입 A나 C를 비교를 해보자면 나이가 그 많은 그 비교적 에어타가 약간 스티프하신 분들은 리플렉션 웨이브가 이제 PI라고 칭하는 리플렉션 웨이브가 이제 얼리 시스톨에 만들어지고, 그리고 비교적 젊은 이제 혈압 에어타 경우에는 이제 레이트 시스톨 때 만들어져서 오그멘테이션 프레셔를 잴 때도 위치가 조금씩 달라지는 웨이브 폼에 의해서 위치가 조금씩 달라지고, 그리고 이 웨이브가 도달하는 시간 라운드 트립 트래블 타임이 이제 나이에 따라서 또 에어타의 스티프 정도에 따라서 이제 조금씩 달라지고 있는 것을 확인할 수가 있습니다. 그리고 나이가 많이 들수록 이런 브라키얼과 에어타 프레셔의 차이, 앰플리피케이션이 점점 작아지고, 그럼으로써 이제 나이가 드실수록 센트럴 에어트 프레셔가 좀씩 올라가는 것을 알 수가 있고, 또 이제 키가 작을수록 센트럴 블러드 프레셔가 브라키얼 대비 이제 더 좀 올라가는 것을 볼 수가 있고, 그리고 하트레이트에서도 영향을 받아서 하트레이트가 작을수록 그런 센트럴 블러드 프레셔 오그멘테이션이 더 상승하는 걸 볼 수 있습니다. 그래서 이제 센트럴 블러드 프레셔는 이제 카테타로 또 캐로티드 토노미트리, 레디얼 토노미트리, 그리고 옥실로메트릭 브라키얼에서 재는 그 위치에 따라서 재는 방법들이 다양하고요. 그리고 이제 아래쪽이 앰뷸레이토리 센트럴 블러드 프레셔 모니터링이 가능한 기구들이고, 이제 위쪽이 이제 오피스 센트럴 블러드 프레셔를 넌 인베이시브하고 인다이렉트하게 잴 수 있는 디바이스들입니다. 스피모코모 코어 엑셀 트라이얼들을 이제 여러 다른 대학 교수님들이 사용을 하고 있는 것으로 알고 있습니다. 이거는 이제 캐로티드로 잴 수도 있고 레디얼 토노메트리도 이용할 수 있는 것으로 알고 있고, 햄 9000 같은 경우는 아까 그 앞서 연자 교수님 말씀해 주셨듯이 이제 여기 이제 손목을 끼워서 레디얼 아터리의 토노메트리의 웨이브를 확인할 수가 있고요. 이제 조은주 교수님 말씀해 주셨던 모바일 오그래프, 이런 브라키얼 커프를 통해서 이제 브라키얼 압력을 재고 또 펄스 웨이브의 모양을 분석을 해서 센트럴 BP를 이제 넌 인베이시브하게 잴 수 있는 그런 기구들이 있는데, 그 비프로 같은 경우는 이제 이것도 휴대용으로 손목에 이제 레디얼 아터리에 맞춰가지고 토노미트리 그림을 그래프를 확인을 해서 센트럴 블러드 프레셔를 이제 간접적으로 제공을 하고 있습니다. 그 외에도 레디얼 아터리와 이제 그 PTT 뒤에 이제 김주환 교수님 말씀해 주시겠지만 이제 EKG를 확인해 가지고 이제 확인을 할 수도 있습니다. 그래서 아까 이제 그 그림에서 보여드렸던 비프로나 스피모코, 그다음에 이제 햄 9000 같은 경우는 레디얼 토노미트리를 확인을 하고요. 그다음에 모바일 오그래프 요 장비는 이제 브라키얼 커프를 이용해서 하고, 각 기계마다 이제 캘리브레이션 메서드나 그리고 그 트랜스퍼 펑션, 이 트랜스퍼 펑션이라는 거는 이제 센트럴 블러드 프레셔 웨이브 폼을 확인하기 위해서 페리페럴 웨이브 폼을 이제 분석을 해서 센트럴 웨이브 폼을 추정을 하고 측정을 하는 것인데, 이게 이제 여러 가지 함수 방법이 있습니다. 제일 많이 사용되고 있는 것이 제너럴라이즈드 트랜스퍼 펑션이라고 하고요. 그 외에도 여러 가지 이제 그 에스티메이션 하는 알고리즘들이 있는데, 각각 회사들마다 조금씩 이제 그 고유의 알고리즘들은 그 이제 공개를 하지 않고 있어서 사실 연구에서 확인을 하는 건 쉽지 않았습니다. 여기서는 이제 그 저희가 브라키알 커프에서 재는 이제 커프로 브라키알 아터리를 에서 이제 시스톨릭, 다이스톨릭 블러드 프레셔를 재는 것은 실제로 인베이시브하게 카테터를 통해서 재는 것보다는 실제로 이제 시스톨릭 BP는 언더 에스티메이션 되고 다이스톨릭 BP는 오버 에스티메이션 된 것으로 알려져 있습니다. 그렇지만 저희가 이제 임상에서 그 브라키얼 커프에서 잰 혈압으로서 이제 모든 임상 스터디를 진행을 하고 있기 때문에 실제로 이제 카테타를 통해서 리얼하게 프레셔를 재는 것과 브라키얼에서 재는 것의 차이를 크게 의미를 두고 있지는 않습니다. 그런 것처럼 센트럴 브로드 프레셔도 여러 가지 장비들과 기구들을 통해서 이제 임상 스터디들이 많이 나오고 있기 때문에 실제로 그 카테타를 통해서 에오타의 리얼 프레셔를 꼭 똑같이 이렇게 할 필요는 없다라는 생각을 갖게 되었습니다. 그렇지만 이제 장비들마다 조금씩 차이를 보이고 있어서 그런 것들은 좀 장비들의 그런 특성들을 이해를 해야 되겠다라는 생각을 갖게 되었는데요. 타입 1 같은 경우는 이제 브라키얼 브로드 프레셔를 통해서 센트럴 브로드 프레셔를 추정을 하는, 그러니까 모바일 오그래프 같은 게 이제 타입 1에 들어가고요. 그다음에 타입 2 같은 경우는 이제 이런 인트라 아터리얼 센트럴 브로드 프레셔를 직접적으로 예측을 하는 것으로 해서 햄 9000이나 비프로가 이제 여기에 해당이 된다고 합니다. 그런데 이제 햄 9000 같은 경우는 이제 강조를 하는 바가 뭐냐면 실제로 이제 카테타에서 직접 잰 센트럴 브로드 프레셔와 유사하다. 이런 타입 1에 비해서 좀 더 높게 나오긴 하지만 리얼 에오타 프레셔와 유사하다라고 이제 강조를 하고 있습니다. 페리페럴 프레셔의 웨이브를 통해서 이제 센트럴 에오타 프레셔를 예측하는 방법들의 이제 펑셔널 GTF라고 말씀을 드렸는데, 이 GTF는 윈드캐슨 이펙트라고 해서 여러 이제 심장에서 나가는 이제 스트로크 볼륨과 에오타나 라지 아터리의 컴플라이언스, 그리고 스몰 아터리의 리시스턴트를 수학적인 공식으로 이렇게 적용을 해가지고 이제 센트럴 에오타의 프레셔의 폼을 이제 예측을 하는 수학 공식인데요. 이것을 적용을 하는 것이 이제 GTF입니다. 이거는 이제 스피그모코에서 이제 캐로티드 토노미트리가 에오타에서 이제 가장 가깝기 때문에 센트럴 에오틱 프레셔와 거의 유사하다고 알려져 있어서 이렇게 실제로 이제 PI가 앞쪽에 있는 에오타의 압력과 거의 유사한 모양으로 해서 각각 센트럴 펄스 프레셔와 센트럴 오그멘테이션 인덱스 이런 것들을 보여주고 있습니다. 그리고 이제 각 회사들마다 또 사용하는 알고리즘이 이제 레디얼 프레셔를 통해서 확인을 하는 알고리즘은 세컨더리 시스톨릭 피크, 이것이 이제 에오타의 프레셔의 웨이브와 유사하다, 동일하다라고 하는 현상입니다. 그래서 이것들을 통해서 레디얼 프레셔로 이제 에오틱 프레셔를 이제 확인을 하는 것이죠. 에오틱 아터리의 압력 모양은 이렇게 생겼지만 페리페럴 아터리, 레디얼 아터리의 경우는 이렇게 생겼습니다. 물론 이제 센트럴과 이제 높이는 같지는 않겠죠. 근데 오그멘테이션 인덱스도 이제 웨이브의 모양이 다르기 때문에 좀 다른 방법처럼 보이는 공식을 사용을 하지만 사실 의미는 똑같습니다. 여기서는 이제 오그멘테이션 인덱스가 펄스 프레셔분의 이제 오그멘테이션 시스톨의 피크를 하는 이제 압력값을 계산하는 것이고, 레디얼 아터리 같은 경우는 이제 P1이 이제 펄스 프레셔겠죠. 시스톨과 다이아스톨 펄스 프레셔분의 P2 센트럴의 숄더, 센트럴 에오틱의 프레셔로 예측이 되는 숄더 쪽 프레셔를 재서 이제 레디얼 아터리 오그멘테이션 인덱스를 이제 계산을 하고 있습니다. 그리고 이제 스피그모코에서는 이제 센트럴 펄스 프레셔를 함수를 이제 공개를 한 논문에서 했었는데요. 센트럴 펄스 프레셔를 이제 브라키얼 펄스 프레셔와 하트레이트, 키, 그리고 나이, 그리고 성별, 그리고 민 아터리얼 프레셔를 이용해서 이런 리니어 리그레션에 의해서 확인이 된 이제 이런 상수들을 곱해서 이제 계산을 하는 것으로 확인을 하고 있습니다. 저는 이제 외래에서 81세 여자 환자고, 이제 브라키얼 BP가 이제 160에 84로 혈압이 많이 높은 분인데 파킨슨 디지즈로 디멘치아가 좀 있으셔가지고 AMBP를 못 하셨습니다. 그런데 LVH는 있고 혈압이 정말 있나, 노인이라서 바로 쓰기가 좀 그래서 이제 센트럴 브러드 프레셔로 확인을 했었는데 레디얼 아터리에서 이제 PI에 해당되는 픽 벨로시티가 굉장히 높은 것으로 확인할 수가 있습니다. 그리고 이제 센트럴 브로드 프레셔도 역시 이제 173으로 굉장히 높은데요. 햄 9000 같은 경우는 브라키얼 SBP보다 이제 센트럴 SBP가 좀 높게 나옵니다. 근데 이제 이 센트럴 SBP가 실제로 카테터에서 체크한 SBP와 유사하기 때문에 유사하다라고 강조는 하고 있지만은 그래서 이제 알고리즘을 좀 바꿔서 이제 아이디얼하게 피지올로지각에는 브라키얼보다 센트럴이 더 높을 수가 없기 때문에 이제 SBP2라는 이제 센트럴 BP를 이제 두 가지로 모양을 보여주고 있습니다. 그래서 여러 가지 이제 옴론과 스피그모코의 밸리데이션 스터디들이 있는데요. 센트럴 브로드 프레셔가 이제 스피그모코어와 옴론 기계들을 비교를 해보면 옴론 기계들이 조금 이제 브로드 프레셔 센트럴 BP가 좀 높게 나오는 것을 확인할 수가 있습니다. 인베이시브 카테타로 비교를 해서는 스피그모코가 이제 R스퀘어가 좀 높은 것으로 되어 있고 앰뷸레이터리 브로드 프레셔를 확인을 하는 이제 모바일 오그래프 같은 경우는 R스퀘어가 좀 더 높습니다. 0.8로 좀 높은데 이제 다이스톨은 좀 낮은 것을 확인할 수가 있습니다. 그런데 이제 앰뷸레이터리 센트럴 브로드 프레셔는 이제 퀄리티가 좋은 것은 억셉터블하고 아무래도 이제 계속 앰뷸레이션을 하기 때문에 푸어 퀄리티가 많이 보입니다. 그래서 이런 각 기계들마다 이런 알고리즘을 적용을 해서 이런 것들을 이제 삭제하고 그렇게 해서 이제 기계의 정확도를 올리는 것으로 알고 있습니다. 이거는 앞서 보여드린 거하고 똑같고요. 그래서 이제 결론적으로 말씀드리면 이제 24시간 에어틱 브로드 프레셔 모니터링은 이제 LVH를 예측하는 R 코릴레이션 코에피션시가 0.51 정도로 오피스에서 일반적으로 재는 클래식한 에어틱 센트럴 브로드 프레셔에 비해서 이제 R스퀘어가 좀 그 코에피션시가 훨씬 높은 것을 볼 수가 있고 이는 이제 그 오피스 브라키얼 SBP와 이제 24시간 AMBP와 차이와 마찬가지로 앰뷸레이터리 센트럴 브로드 프레셔가 그런 클리니컬한 아웃컴의 예측력을 높인다라는 것을 볼 수가 있습니다. 이 연구는 이제 그 오실로메트릭, 토노메트릭, 앰뷸레이터리 브로드 프레셔 각각 기계로 이제 같은 환자들을 랜덤 스터디를 이제 동시에 잰 환자들인데요. 결론을 보시면은 이제 낮보다는 밤에 그 센트럴 BP와 센트럴 BP와 그 브라키얼 BP 차이가 적어서 센트럴 BP가 이제 밤에는 좀 덜 떨어지더라 이런 거를 보여주는 연구였고요. 그래서 각각 스페이스 랩은 앰뷸레이터리 브로드 프레셔고 비프로는 토노미트를 통해서 이제 체크한 혈압인데 각각의 기계들을 이제 브라키얼 브로드 프레셔가 센트럴 토노미트리로 잰 프레셔가 조금씩 낮은 것을 확인할 수가 있습니다. 그래서 마지막으로 이제 테이크홈 메시지 말씀드리면은 이제 앰뷸레이터리 센트럴 브로드 프레셔의 디바이스들은 오실로메트릭 그리고 토노메트릭 메서드 각 장비마다 사용되고 있는 이제 알고리즘이 일부 공개되고 있지만 공개되지 않은 여러 알고리즘에 따라서 측정되는 센트럴 BP가 차이가 조금씩 있습니다. 그래서 그렇지만 이제 오피스 BP가 앰뷸레이터리 브로드 프레셔와 관계처럼 이제 앰뷸레이터리 센트럴 브로드 프레셔가 클래시컬한 센트럴 브로드 프레셔보다 LV 매스나 타깃 오간 데미지의 예측도가 더 높을 것으로 생각됩니다. 감사합니다.
네, 감사합니다. 마지막 연자를 소개시켜드리겠습니다. 마지막 연자는 전남의대 김주환 교수님께서 New Device for Assessment of Blood Pressure Variability, Pulse Tracking Time에 대해서 강의해 주시겠습니다. 강의 부탁드립니다.
네, 방금 소개받은 김주환입니다. 제가 받은 제목은 New Device for the Assessment of Blood Pressure Variability입니다. 이번 섹션의 주 제목이 센트럴 BP의 베리에이션을 측정할 수 있느냐 아니면 그것을 임상으로 이용할 수 있느냐인데요. 제 제목에는 아예 주신 제목에는 센트럴 BP가 들어있지 않습니다. 그냥 블러드 프레셔 베리에이션을 어세스먼트하는 새로운 디바이스가 뭐냐. 그래서 그쪽에 대해서 말씀을 드리도록 하겠습니다. 블러드 프레셔 베리에이션이라 하면 뭐 민 브레이터 또는 펄스 프레셔 또는 이 BP의 베리에이션 이런 것들을 측정하는 거고요. 그 측정은 뭐 일주일 단위로 하루 단위 또는 뭐 몇 초 단위 뭐 이런 것들로 해서 결국은 초당 또 분당 또는 시간당 아니면 데이 투 데이 또는 비짓 투 비짓 아니면 시즌 사이에서 이렇게 베리에이션이 있는 것들을 과연 우리가 측정을 할 수 있느냐 이거고요. 그래서 지금 숏텀 BPD, 롱텀 BPV 뭐 이런 것들을 이제 임상적으로 이제 사용을 하고 있고요. 저는 이제 여기서 이걸 측정이 가능하냐에 대한 이야기를 좀 해보려고 합니다. 그래서 사실은 BP 베리에이션은 굉장히 다양하게 존재하고 있고요. 이것들을 어떻게 측정하느냐 이런 것들인데요. 결국은 처음에 보셨던 것 같이 혈압을 재고 그다음에 다음에 오실 때 또 혈압을 재고 해서 BP 차이를 보는 이런 것들이 있었을 거고요. 이제 기술이 발달해서 이제 집에서 BP를 재거나 또는 이게 앰뷸리터리 BP로 24시간 BP를 재면서 이것의 하루 동안의 변화 또는 뭐 날마다의 변화를 측정을 할 수 있었죠. 근데 이제 요새 세상이 바뀌어서 이제 이렇게 다니면서 걸어 다니면서 운동하면서 혈압의 변화가 어쩔 거냐 이런 것들까지 이제 해보고 싶겠죠. 그래서 결국은 우리가 이제 여러 파라미터가 있습니다. 뭐 코피시스 베리에이션 CV 또는 뭐 레지듀얼 BPV 또는 뭐 ARV라고 하는 이제 절대값 뭐 낮하고 밤의 차이 뭐 이런 것들이 있겠고 이런 것들을 위해서 이제 지금 보셨던 장비들 그러니까 다 이해하셨을 것 같은 장비는 그냥 정통적인 혈압계로 재서 차이를 보는 거 또는 24시간 혈압으로 측정을 했던 것에 차이를 보는 거까지는 이제 보셨을 거고요. 센트럴 BP가 과연 이게 가능할 거냐 뭐 이런 것들도 이제 되는데 파라미터는 이렇게 이제 뭐 차가 얼마냐 이런 것들이 되고 있고 각각의 기간별로 보려고 하는 목표 수치도 다릅니다. 근데 이제 그러면 차를 알고 싶다 아니면 베리에이션이 어떤지를 알고 싶다는 1922년부터 이미 누군가가 이걸 했어요. 펄스 웨이브, 그러니까 펄스 웨이브를 측정을 하면 펄스 트랜시션스 타임, 그러니까 펄스가 지나가는 속도를 측정을 하면 BP 베리에이션을 알 수 있을 거다라고 이미 예언을 하셨던 분이 계시죠. 그래서 결국은 이제 우리가 많이 하는 게 이제 펄스 트랜시션 타임을 측정을 하는 그런 장비가 지금 사실은 동맥경화도 검사라고 하는 PWB라는 검사들 있죠. 많이 하실 거고요. 이 PWB를 가지고 동맥이 얼마나 단단해지냐를 이제 증명을 하고 있으시고요. 그리고 많이 연구들을 하셨어요. 이제 뭘 연구했냐면 이 동맥이 딱딱해진 정도하고 혈압의 변동하고 수치를 봤더니 뭐 아주 감기가 좋다. 뭐 그래서 여러 가지 스터디를 하면서 롱텀 혈압의 변화 이것은 동맥경하고 일치한다. 여기까지가 이제 논문을 쓰신 선생님들의 이야기들이고 이제 최근까지도 이런 것들이 전혀 이렇게 한다고 이야기를 합니다. 그러면 결국 BP의 변화 이거는 에어트랄 스티프니스하고 거의 좀 왔다 갔다 그리고 이것들이 CV 이벤트를 일으킨다. 여기까지인데 기계를 만든 사람 눈에는 어떻게 보이냐면 아니 BP 베리어티 되려고 하루 동안 또 뭐 일주일간 혈압을 잴 필요가 뭐가 있냐. 에이트랄 스티프니스를 측정해가지고 똑같다는데 반대로 해줄 것이 없겠냐 해서 만들어진 장비들이 지금 나오기 시작합니다. 그래서 뭐냐면 그냥 PWB, 그다음에 AI, 오그멘트 인덱스 이런 것들을 구해가지고 그걸 가지고 너희들이 원하는 BP 베리에이션에 대한 함수를 우리가 만들어줄게 하는 것들을 지금 만들고 있고요. 특히나 이제 딥러닝이 되는 순간부터 이런 것들이 좀 많이 되고 있습니다. 그래서 지금 왜 뭐 이렇게 불편하게 하루 동안 재세요, 아니면 왜 불편하게 한 달간 재세요. 그냥 여기 앉아서 동맥경화도가 어느 정도인지 측정해 하시면 여기 원하시는 파라미터 만들어 드릴게요 하는 것이 이제 만들어지고요. 아까 보셨던 그 센트럴 BP에 모니터링을 한다. 센트럴 BP를 24시간 돌린다. 이거는 우리가 알고 있는 그 새로운 장비가 필요한 게 아니에요. 원래 우리가 알고 있는 24시간 BP 이것도 오실러미터로 해서 혈압을 재는 것이 있는데 거기서 24시간 혈압을 측정을 할 거고 시간마다 그 오실레이션 사이에 있어서의 그래서 오그멘트 인덱스를 구할 수 있거든요. 근데 사실 이게 맞냐 틀리냐 아까 치면 좀 얘기지만 라디알이 더 정확하다 뭐 이렇게 하지만 브라켈에서도 못 잴 건 없죠. 재면 약간 틀리긴 하지만 그러면 계산해서 주는 거죠. 그래서 이게 기계가 서로 틀린 게 아니고요. 같은 기계인데 소프트웨어만 더 들어가면 얼마든지 이게 재줄 수 있는 상태입니다. 그래서 이제 그런데 이제 그러면 새로운 장비들이 또 뭐가 있느냐? 뉴 디바이스를 설명하라고 해서 아까 내내 이야기 드렸던 옴론에서 그냥 그러니까 웨어러블 혈압계가 있고요. 그다음에 아까 비브로 보셨죠? 있었고 그다음에 피노메타, 그다음에 프로토페이퍼 이런 것들이 나오고 또 흔히 말해서 스마트폰으로도 혈압을 측정을 하는 것들이 나옵니다. 뭐 우리나라도 뭐 지금 손목 혈압계 이렇게 나오고 있는 것 같고요. 근데 이게 어떤 방식이냐 하면 옴론 방식은 오실로메트리를 이용하고 있고요. 비프로는 토노메트리를 이용하고 있습니다. 그다음에 다른 어떤 장비들은 설명해 주려고 하는 PPT를 이용한 것들이 있고요. 그러면 새로운 장비들은 커프가 없어야 되니까요. 그러다 PPG를 측정을 합니다. PPG라는 것은 우리가 흔히 알던 펄스 옥시메트리와 같은 장비인데요. 이걸 이용하면은 혈류량의 변화를 측정할 수 있습니다. 그러면 혈류량이 변한다. 그러면 이 혈류량의 변함을 어떻게 혈압으로 예측을 할 수 있을까라고 하는 것들이 나오죠. 결국 혈압은 혈류량과 혈강의 저항으로 이루어져 있고요. 정통적인 혈압 측정은 직접 재거나 아니면 오실레이션이나 아니면 오스컬테이션인데, 오스컬테이션이라는 것은 혈류를 차단함으로써 생기는 소리를 들어서 시스톨릭과 다이아스톨릭 BP를 측정하는 거고요. 오실레이션은 혈류를 차단했다가 혈류가 생기는 사이에 있어서의 오실레이션을 측정해서 민 블러드 프레셔를 측정하고 이걸로 시스톨과 다이아스톨릭을 예측하는 거고요. 아까 PPG라고 말씀드렸던 볼륨 클램핑 방법이 있는데, 어디에 혈류량이 변화인데 이 변화량을 가지고 우리가 알고 있는 혈압과 해서 혈압의 변화를 알 수 있죠. 그러면 이때는 혈관의 저항은 일정하다는 가정 하에서 하는 거겠죠. 우리가 말하는 스마트폰, 애플워치 뭐 이런 것들이 대부분 다 PPG를 통하고 이거는 혈류량을 측정을 하고, 혈류량이 변하면 혈압이 변하니까 기존에 있던 값에 어떻게 변하는가를 측정하는 방법이 있고요. 아까 토노메트로 했었던 비브로 같은 경우는 혈강의 저항을 측정을 하는 거죠. 그래서 양을 측정하지는 않고 저항만으로 압력으로 혈압을 측정하는 방법이 있고요. 요새 좀 새로 나오는 장비들이 PTT 베이스 블러드 프로저먼트입니다. 이것도 뭐 비슷한 이야기인데요. 펄스 트랜지 타임을 측정을 하면 혈압을 예측할 수 있겠다 하는 이야기입니다. 그래서 펄스 어라이벌 타임이라는 게 있는데, 이거는 심장에서 피가 나가면서 펄스까지 오는 시간. 우리는 어떻게 측정할 거냐? 심전도의 QRS부터 펄스가 올 때까지 시간. 그다음에 펄스 트랜지 타임은 두 군데죠. 두 군데에서 사이의 차이. 그렇다면 우리가 아까 여러 가지 방법으로 측정을 할 수 있지만 제일 간단한 것은 PPG일 거니까 PPG 센서 두 개만 있으면 펄스 트랜스 타임을 측정할 수 있을 것 같다 하는 개념으로 됩니다. 그래서 PAT, PTT를 측정을 하면 이게 어떻게 해서 혈압을 측정할 거냐라는 개념인데요. 혈압이 이렇게 올라가면 PAT가 줄어들 수밖에 없어요. 그 다음에 혈압이 떨어지면 PAT가 늘어날 수 있고요. 근데 이것만 갖고는 사실 정확하지 않기 때문에 요새 나오는 아까 피노타입의 그래프들은 세 가지를 측정을 합니다. 하나는 심전도, 또 하나는 임페던스, 또 하나는 PPG를. 그러면 임페던스 시작과 그 다음에 PPG 사이에 있어서의 타임을 PTT라고 측정을 할 수 있고요. 그다음에 심전도에서 더 쓴 PAT를 측정할 수 있고요. 이 PTT와 PA를 이용해서 혈압을 예측하는 방법, 이것들이 지금까지 했던 방법 중에서는 제일 좋다고 생각을 할 수 있습니다. 근데 애플워치나 갤럭시워치는 사실 장비로서는 심전도를 측정할 수 있고, 그다음에 임페던스도 측정할 수 있고요. 그다음에 PP도 측정할 수 있지만 PAT와 PTT를 쓸 수 없는 게 두 지점이 똑같습니다. 핸드폰 하나니까. 그래서 아까 보셨던 것 같이 스마트폰을 달고 거기다 손가락에다가 또 하나를 달아서 연결하는 선이 있거나, 아니면 이게 가슴에 있는 심전도하고 연결해 놓거나, 이 상황이 돼야 혈압을 모니터링할 수 있는 상태입니다. 그러면 이런 것들이 진짜 정확할 거냐에 대한 연구들이 있는데요. 일단은 뭐 맞는 것 같습니다. 더구나 이것이 에이트랄 스티프니스와 관련이 있냐는 연구나 아니면 모탈리티 연구나 이런 것들은 굉장히 영향을 많이 주는 것 같고요. 그럼 이런 디바이스들이 진짜 맞냐 안 맞냐 이런 것들에 대해서는 이미 규정이 만들어져 있고요. 그래서 이건 혈압이 맞냐 안 맞냐고요. 이것에 대한 베리에이션으로 다 지금 모든 장비에 있어서 혈압을 측정하는 것과 혈압의 측정에 대한 베리에이션을 어세스먼트 하고 있고요. 이런 것들이 지금 이미 다 이 규정을 통과해서 이미 상용화되고 있습니다. 잠깐 저는 그냥 BP 베리에이션을 좀 하고 있는 게 국책 과제로 뭐 하나 받은 게 있어서 지금 개발을 하고 있는데요. 이건 뭐냐면 홈 BP입니다. 이제 집에서 재는 혈압을 스마트폰에다 입력만 해주시면 저희 OCS로 혈압계가 넘어와서 여기서부터 우리가 원하는 베리어빌리티를 측정할 수 있는 방법들이 좀 있어서 이건 뭐 새로운 장비는 아니지만 이걸로도 제가 원하는 베리어빌리티를 좀 하고 있는 상태입니다. 정리를 하자면 혈압은 혈류량하고 혈관의 저항이고요. 새로운 장비, 혈압을 측정할 수 있는 장비는 옛날엔 브라키알민만 쟀었던 것을 다양한 부위에서 재주려고 노력을 하고 있고요. 그런 방법 중에 하나는 혈류량의 변화로 혈압을 예측하거나 혈관의 저항을 변화로 혈압을 예측하는 장비들이 나와 있고요. 지금은 PTT를 이용한 혈압 예측을 하는 장비가 나오고 있습니다. 근데 PTT는 조금 이게 두 군데 이상에 있어서 접지가 있어야 되기 때문에 우리가 흔히 말하는 그냥 스마트폰 같이 될 수는 없고 약간의 두 군데 아니면 세 군데의 접지가 필요한 것들이 생깁니다. 그러면 혈압의 변동을 알 수 있는 장비가 이것들이 맞을 거냐 하는 건데요. 사실 돌이켜 생각해 보면 혈압을 정확히 측정은 할 수 없지만 대충은 예측을 했던 장비들이 베리에이션에 대해서는 뭐 더 그러니까 수치가 정확하냐는 문제보다 베리에이션이 어쩌냐는 것에선 더 정확히 측정할 수 있을 것 같고요. 그래서 아마 새로운 장비들, 특히나 PTT를 이용한 장비에 있어서 혈압 변동은 더 이렇게 정확히 볼 수 있을 것 같습니다. 오늘 말씀드린 이 주제에 있어서 센트럴 BP에 있어서의 모니터링, 센트럴 BP의 변화를 예측할 수 있겠느냐? 일단은 지금 혈관 저항을 가지고 혈압을 측정하는 기계는 스핑고메트리하고 거의 같은 원리를 이용하고 있기 때문에 거기에서 오그멘트 인덱스를 얼마든지 구할 수 있을 거고 그래서 좀 뭐 비슷하지 않을까 하는 거고요. 그 다음에 지금 이미 사용하고 있는 오스컬테이션을 이용한 혈압계에 있어서는 그것보다는 정확하지는 않겠지만 일중 변화는 확실히 할 수 있을 거다 생각을 할 수 있겠습니다. 새로운 방식의 PTT 방식을 이용하면 센트럴 BP 모니터링은 훨씬 더 강력해질 수 있을 것 같긴 한데요. 이제 문제는 그거는 앰뷸러터리 BP 같이 이제 여러 군데다가 붙이고 다녀야 되기 때문에 뭐 샤워를 못 한다든가 이런 단점이 있을 수 있을 것 같습니다. 이상입니다. 경청해서 감사합니다.
네, 감사합니다. 이제부터 패널 디스커션을 할 텐데요. 저희 패널 선생님을 소개시켜드리겠습니다. 제주의대 김송희 교수님, 서울의대 김학영 교수님, 고려의대 나진호 교수님, 카톨릭의대 정우백 교수님 나와 계십니다.
멀리서 오신 김성희 교수부터 시작하시죠.
네, 알겠습니다. 예, 네 분 좋은 강의 잘 들었습니다. 센트럴 BP랑 뭐 BP 베리에이션에 대해서 이제 배울 수 있는 아주 좋은 기회였던 것 같은데요. 저는 조은주 선생님한테 좀 질문드리고 싶습니다. 저희가 이제 뭐 그 센트럴 BP가 이제 페리페럴 BP 모니터링에 비해서는 훨씬 더 이제 타겟오간 데미지를 잘 설명할 수 있고 또한 이제 단발성으로 잰 거보다는 이제 앰뷸라토리하게 그러니까 하루 종일 잰 게 이제 조금 더 타겟오간 데미지를 더 예측할 수 있다라는 걸 잘 이해할 수가 있었는데요. 그러니까 저는 개인적으로는 이제 앰뷸레이토리 센트럴 BP 모니터링을 한 번도 해본 적이 없어서 저희가 이제 그 진료실에서 많이 하고 있는 24시간 BP 모니터링을 저희가 결과지를 볼 때 뭐 거기에 굉장히 여러 가지 정보가 나오고 뭐 에버리지 혈압이나 데이타임, 나이트타임 뭐 모닝 서지가 어떤지 그런 걸 다 보게 되지만 사실 그 전에 제일 먼저 봐야 되는 거는 이 환자가 전체 혈압 잰 거 중에 이제 밸리드한 측정이 몇 프로가 되었는가를 아마 보는 게 가장 먼저일 것 같고 일단 뭐 저희 환자들 중에서도 실제로 앰뷸레이토리 BP 모니터링을 해보면 100% 다 잘 재져서 오시는 환자도 있지만 정말 어이가 없을 정도로 50%만 제대로 재지고 오시는 환자들도 있거든요. 근데 선생님 그 연구 진행하시고 뭐 이제 실제 그 검사 진행하실 때 그 보니까 그 아까 앰뷸레이토리 센트럴 BP 모니터링 기계가 저희가 그냥 흔히 보는 ABPM 기계랑 되게 비슷하게 생겼고 비슷하게 진행이 되는 것 같은데 그 밸리드한 측정이 몇 프로나 되는지 대부분 다 밸리드하게 측정이 되는지 그게 좀 궁금합니다, 선생님.
네, 24시간 센트럴 BP 재는 과정을 좀 설명을 드리면 생긴 거는 그 오실로메트리로 브라키알 24시간 BP를 재는 거랑 똑같은데 한 번 혈압을 잴 때 30초가 걸립니다. 그러니까 한 번 우웅 올라가서 BP를 한 번 재고 내려와서 그다음 몇 초 있다가 다시 또 우웅 하면서 이제 센트럴 BP를 계산하거든요. 그래서 환자한테 이제 단도리를 잘하죠. 한 번 올라가기 시작하면 30초는 가만히 있어야 된다. 근데 이제 환자들이 굉장히 모티베이션 된 환자들이기 때문에 애초에 이 연구에 들어온 사람들은 저희는 컷오프를 90%로 했습니다. 그래서 발리드 데이터가 90%가 있어야 억셉트 되는 걸로 이제 그렇게 산정을 했었습니다. 그리고 실제로 연구이기 때문에 대부분의 환자들이 그 레벨 안에 들어왔습니다.
실제 해보면, 그러니까 그냥 임상에서 만약에 적용이 된다면 그 정도를 얻기는 실제 쉽지는
더
않겠네요.
걱정은 기계가 너무 비싸서요. 이걸 기계를 달리고 환자를 집에 보내는 게 굉장히 불안할 수 있습니다.
예, 저는 그냥 코멘트를 좀 하고 싶습니다. 그 센트럴 BP를 재는 게 쉽지도 않고 데이터가 브라키알 BP하고 별 차이도 없고 그래서 좀 클리니컬리 잘 활용이 안 되는 것 같습니다. 그런데 실제로 저희가 그 센트럴 BP를 조금 더 활용해 볼 수 있는 분야라고 하면 이제 젊은 사람에서 이 수축기 혈압만 올라가는 경우가 있거든요. 대부분 젊은 사람 고혈압은 이완기 고혈압이 많은데 아이솔레이티드 시스톨릭 하이퍼텐션이 있는 그런 젊은 고혈압 환자에서는 이거를 치료를 할 것인가 말 것인가 상당히 이제 고민이 많이 되거든요. 물론 리스크 팩터 이런 걸 따져봐야 되겠지만 그럴 때 센트럴 BP를 측정을 해서 이제 높다면 조금 더 적극적으로 치료를 했을 때 환자 예후가 좋아진다라는 좋은 데이터가 있습니다.
고맙습니다.
네, 잘 들었습니다. 저는 이제 항상 하는 생각이 이런 센트럴 블러드 프레셔에 대해서 생각을 하기 시작하면 머리가 생각보다 복잡하더라고요. 왜냐하면 이게 생각해야 되는 이런 여러 가지 조건들이 좀 있고 사실 우리가 그냥 인베이시브하게 레디알 펑처를 해서 레디알 아터리의 프레셔를 재고 그다음 아우타까지 넣어서 아우타의 프레셔를 재보고 뭐 이러면은 이제 어려운 문제는 아닌데 이거를 이제 레디알 아터리에서 센트럴 쪽을 이제 에스티메이션 해 나가는 거잖아요. 그런 쪽에 있어서 할 때 생각해 볼 수 있는 게 굉장히 좀 다양한 이런 그런 것들이 있지 않을까. 그러니까 거기에 이제 그 교란되는 변수가 꽤 많이 있을 거라고 생각을 합니다. 특히나 우리가 흔히 생각하기로는 이런 리프렉션 플로우에 의해서 오그멘테이션 인덱스가 올라가면 아마 센트럴 프레셔가 많이 높아질 거다라고 그냥 막연히 생각은 하는데 사실 젊은 사람도 그렇거든요. 젊은 사람도 있어서도 센트럴과 그 페리페랄에 있어서 차이는 꽤 많이 나는 거기 때문에 제가 언뜻 생각하기로는 그것만 가지고 이게 그거를 다 설명하기는 조금 어렵다라는 생각이 조금 들었습니다. 그래서 이런 센트럴 블러드 프레셔를 할 때 제가 지난번에 아까도 뭐 카페 스타디도 나오고 그랬지만 실제로 뭐 이렇게 약을 써가지고 그 베타 블로커나 아니면 칼슘 블로커를 쓴 그룹을 비교를 해보면 실제로 이런 새로 지금 개발되고 있는 기계 가지고도 그때랑 비슷한 결과가 나오는지 조금 궁금한 그런 것들이 있고요. 하지만 저는 이런 센트럴 블러드 프레셔를 측정을 하는 게 비단 이제 페리페랄 블러드 프레셔뿐만 아니라 이제 혈압을 또 잴 수 있는 또 다른 혈압의 파라미터라고 생각을 하거든요. 페리페랄과는 조금 물론 관계는 좀 있겠지만 그래서 특히나 페리페랄은 어쩔 수 없이 우리가 그 커프를 감았다 펴야 되잖아요. 그 커프가 감길 때 우리가 어쩔 수 없이 혈압을 재고 있구나라는 생각이 들면서 그 순간 혈압이 오르는 그런 것들을 아주 무시할 수는 없습니다. 특히나 자고 있을 때 뭐 깨난다든지 뭐 이러면 그 혈압이 진짜 실제로 잘 때 혈압인지 아니면 그것 때문에 올라간 건지 알 수가 없는데 이거는 이제 전혀 그런 느낌 없이 잴 수 있다는 게 커다란 장점인 것 같습니다. 그래서 저는 이제 페리페랄 블러드 프레셔와 센트럴 블러드 프레셔가 어떻게 차이가 나고 뭐 이런 것도 물론 중요하겠지만 이런 센트럴 블러드 프레셔만의 이런 그 새로운 이런 그 노멀 레인지라고 해야 되나요? 아무튼 뭐 그런 것들을 조금 개발을 하는 게 어떨까 그런 생각이 좀 들어서 그냥 개인적으로 한번 말씀드려 보겠습니다.
네, 그다음 정 교수.
네, 저는 사실 제가 하는 일의 대부분이 에코방에서 에코를 보고 있는 일인데요. 이 강의를 들으면서 든 생각이 우리가 LV 이젝션 프랙션이 가진 제한점 때문에 그 LV 펑션을 평가하려는 여러 지표들을 연구를 해서 개발하려는 노력을 했고 그래서 스트레인 분석이나 뭐 스트레인 레이트, 뭐 3D 이젝션 프랙션 이런 것들이 나왔지만 결국은 어떤 치료를 결정하는 기준을 삼을 때 다른 뭐 인터벤션 하는 분들이나 신부전 하시는 분들이나 이젝션 프랙션을 기준으로 다시 가서 이제 서로 의견을 조율하고 이렇게 가는 걸로 봐서 이것도 좀 비슷하다는 느낌을 좀 받았거든요. 그러니까 브라키알 블러드 프레셔의 제한점 때문에 센트럴 블러드 프레셔를 이제 개념을 가지고 계속 연구를 해서 데이터가 쌓이고 분명히 이 센트럴 블러드 프레셔를 측정하는 것이 유용한 환자군이 있다라는 것도 알려져 있지만 실제로 외래에서는 센트럴 블러드 프레셔를 이렇게 광범위하게 진료에 이용하지 못하고 있는 상황이 아닌가 그런 생각이 좀 들었고요. 이제 그건 제가 강의글을 들으면서 든 생각이었고 저는 이제 연자분들께 질문을 드리고 싶은 거는 이제 오실로메트릭 블러드 프레셔 메저먼트를 할 때 저희가 AP 환자들의 경우에는 이제 그 측정이 정확하게 되지 않을 가능성에 대해서 항상 얘기가 있게 되는데 이 센트럴 블러드 프레셔를 측정을 해서 이 데이터를 할 때 이 AP 환자들은 어떻게 뭐 AP분 다 제외를 하고 들어가는 건지 아니면 지금까지 나와 있는 센트럴 블러드 프레셔 측정 방법 중에 뭐 AP에 대해서는 뭐 측정이 더 높게 된다거나 낮게 된다거나 어떤 이런 데이터가 있는지 그런 부분 혹시 네 분 연자 중에 답변을 해주실 수 있는지 궁금합니다.
데이터가 없는 것 같아서 답변하기가 쉽지가 않은 것 같은데.
저는 임상적은 잘못 아니고 기계적인 이야기만 하기로 했으니까 기계적으로 이야기를 하도록 하겠습니다. 센트럴 BP를 예측하는 것은 그 면적을 그러니까 면적이 또 서로 그러니까 트랜션 타임이 서로 틀리는데 면적으로만 계산을 해서 이제 혈압 수치가 올라가게 만들어 놓은 상황인 걸로요. 그렇기 때문에 이 기계에서 나오는 그것은 APB 3개만 섞어서 한다 해서 통계를 내면 뭐 똑같이 나오는 거죠. 그러니까 임상적으로 혈압이 서로 틀리냐 어쩌냐 이게 아니라 그러니까 세 비트의 이쪽의 에어레어와 예측된 에어레어와 똑같게만 기계는 나오걸래요. 뭐 여러 가지를 분석을 하겠지만 딱 그 펄스의 이쪽의 에어레어가 센터랄에도 같은 에어레어가 될 건데 이쪽은 더 작아지니까 혈압이 올라간다. 이 개념으로 돼 있습니다. 그래서 기계적으로는 APF에서 3비트 이상만 측정이 되면 큰 차이가 없다고 말할 수 있는데 이거는 기계적인 이야기지 임상적인 이야기는 아닐 것 같습니다. 그건 이제 연구를 해보셔야 될 문제일 것 같고요.
예, 조은주 선생님. 예.
먼저 우리 정우백 선생님 처음에 언급하셨던 그 에코에서 스트레인이나 뭐 3D나 뭐 이런 것들과 비슷한 것 같다라고 말씀하셨는데 사실은 맞습니다. 근데 이제 뭐 결론은 인터벤션 하신 선생님이나 하트페일리어 하는 선생님들이 결국은 크래시카란 EF로 돌아온다 하셨는데 사실은 아니죠. 여러 가지 파라미터를 알고 있는 것이 환자를 메티큘러스하게 치료하는데 굉장히 도움이 됩니다. 예를 들어 고혈압 환자인데 숨이 너무너무 찬다고 한단 말이에요. 숨 찬데 EF는 정상이면 정상이라고 그냥 내버려둘 거 아니지 않습니까? 우리는 좀 더 실력 있는 의사라면 이바 이프라임도 측정하고 여러 가지 다른 뭐 스트레인도 측정하고 해서 이 환자가 진정한 다이아스톨릭 필링 디펙트가 있는지까지도 확인해 주는 게 굉장히 중요하고 사실은 스트레인은 굉장히 많이 발전이 돼서 우리가 마이트랄 밸브 디지즈 OP의 인디케이션을 정할 때 롱디튜디널 스트레인 굉장히 중요하기 때문에 센트럴 BP도 잘 디벨롭하면 아마 그 정도까지 될 수 있을 거로 생각이 됩니다. 이제 두 번째 AP에 대해서는 오실로메트릭 메소드로 측정한 AP 환자의 BP는 오버 에스티메이션 되기 마련이라고 합니다. 그래서 그렇지만 이제 우리가 보통 우리 어떤 측정을 하더라도 AP 환자는 보통 5번 측정해서 평균을 내지 않습니까? 그런 면에서 24시간 BP는 좀 더 정확할 수 있을 것으로 생각이 됩니다.
예, 조은 선생님 혹시 나오신 김에 제가 한 가지만 좀 여쭤보고 싶은 게요. 금방 그 김재영 선생님께랑 같이 옛날에 뭐 센트럴 BP를 재보신 적이 있다고 그러셨는데 뭐 최근 일은 아닐 것 같고 꽤 오래전 일일 것 같고 그다음에 그 스테이지가 페이스가 있는데 뭐 한 2개는 됐고 나머지 4개는 연구가 필요하다라고 얘기하셨잖아요. 그 혹시나 이제 그런 연구를 하려면 그래도 그 누군가 이 믿음이 있어야 되거든요. 이게 반드시 우리가 해서 포지티브가 나와서 우리 임상에 적용이 돼서 사용하게 될 거다. 우리 혈압처럼 그런 믿음이 있어야 될 텐데 있다고 얘기하실 것 같긴 한데 그런 걸 갖고 계신가요?
저는 그렇습니다.
네. 아 예. 혹시나 더 추가 말씀 있으실? 김종민 선생님 혹시 예.
예. 그 조은주 선생님이 그 저희 케이스 센트럴 스터디에 대해서 잠깐 언급을 했는데 제가 조금만 좀 부언을 드리자면 저희가 그 학회에서 ISH 2016년 그 대회를 앞두고 이 케이스 센트럴 스터디를 진행을 했는데 사실은 뭐 여러분들 뭐 이제 그 프로토콜상 뭐 모든 스터디가 다 그렇지만 저희가 단순히 혈압의 어떤 변화를 보기 위해서는 이런 스터디를 디자인한 게 아니고 그래서 스터디의 그 프로토콜상에 페리페럴 블러드의 프레셔는 약제 간의 그 차이가 없게끔 그 환자 간의 그 타겟 블러드 프레셔가 도달이 되게끔 유도를 하고 그 다음에 센트럴 블러드 프레셔의 어떤 차이가 나날 보면서 이 스터디를 진행을 했었는데 확실하게 그 유의한 차이가 났었고 또 여러분들이 뭐 지적을 하셨지만 모든 우리가 진행하는 임상 연구의 가장 파이널한 골은 클리니컬 아웃컴의 어떤 차이를 보는가 이게 가장 중요한데 그러려면 아주 엄청난 그런 노력과 시간이 많이 필요하지 않습니까? 그래서 저희는 단순한 그 혈압 차이를 떠나서 이 센트럴 블러드 프레셔도 봤지만 이와 관련된 여러 가지 오그멘테이션 인덱스라든지 스티프니스 인덱스라든지 스무스 인덱스라든지 이런 등등을 보므로 해서 이 클리니컬 아웃컴은 아니지만 서브 클리니컬한 조금 그 중간 단계의 그런 데이터까지 어떤 차이가 나는 걸 봤기 때문에 그래서 나름대로 의미가 있다고 생각이 되고 앞으로 이런 게 클리니컬 아웃컴까지 보는 이런 스터디로 진행이 된다면 또 확실한 말씀을 드릴 수 있지 않을까 이렇게 생각을 합니다. 감사합니다.
네. 뭐 저희가 사실 실제적으로 느끼는 거지만 이런 아카데미컬한 밸리데이션보다는 테크니컬한 이 디벨롭먼트가 상당히 빠르게 우리가 느끼기도 어려울 정도로 상당히 빠르게 진행이 되고 있는 시대에 살고 있기 때문에 조금 더 관심을 갖고 팔로우업을 하시면 조만간 상당히 조은주 선생님이 확신을 갖고 계시는 한 그 좋은 결과로 아마 우리가 임상에 사용될 날도 멀지 않았다고 생각됩니다. 오늘 상당히 그 프로미싱하고 우리가 그 좋은 주제에 세션이 진행이 된 것 같고 강의를 해주신 분과 패널 디스커션 참여해주신 여러분께 감사드립니다. 이것으로 세션을 마치도록 하겠습니다. 감사합니다.
Good afternoon, dear colleagues. This is the session last to the end. So this session is optimizing hypertension management in the elderly. So we have 4 presenters, 2 foreigners. I am Ono Kim from Jeonbuk National University, and it's a very honor to this meeting. So, and serving with me as a co-chairman is Kwang-il Kim from Bundang Seoul National University. So I will chair the first 2 papers, and last 2 paper and panel discussion will led by Dr. Kwang-il Kim. So let's move on. The first speaker is Kyu from Catholic University. He is graduates Seoul National University Hospital, now working in the Catholic University. His topic is how to improve adherence in elderly hypertension patients. Please.
Thank you for the introduction. Today I'll be presenting about how to improve adherence in these elderly hypertensive patients. Actually, you can just delete the elderly because most hypertensive patients, most patients are all getting older and older. So I'll be talking in general about improving adherence. So the talk today will go like this. The ACC/AHA guidelines, the ESCC guidelines, and the Korean guidelines, they all say that patients over 65 years old, then you are being elderly. But these days, most of our patients are 60, 70, they're going up to 80, 90 years. Very old patients, over 80 years old, we could say that they are extremely elderly patients, but most patients have very many comorbidities, they have to take a lot of medications, so we need to consider how we can make these patients more adherent to our prescription medications. So as I said, as the ages go up, the number of comorbidities in these elderly patients also go up. And this is a problem because they are taking very many medications to control their blood pressure, their glucose, their cholesterol. And when these patients, you can see here that also for systolic and for diastolic blood pressure, in these elderly patients, the slope of the increase as the blood pressure goes up, the slope, how steep the cardiovascular events go up are less than those in the younger patients. But there is an absolute increase in the prevalence of these cardiovascular events. So it's very, very important to control these risk factors in these elderly patients too. So yeah, in the past we had compliance, we had persistence. Nowadays we say it's adherence. So if you say compliance, it kind of means that an extent to which a person's behavior coincides with the medical or health advice. That means the patient follows what the doctor tells them to do. So it's kind of it's not very. The patient doesn't have a really say in it. It's all the doctors what they're doing. And these days we call it adherence. It's less judgmental to the patient and more respectful of the role that patients play in their own treatment. You can see here that in the frail and frail patients, there is a very increased prevalence and treatment rate of hypertension in these old patients. However, as the frailty goes up, the control rates go down, and we kind of question why this is so. You can see here that as the ages goes up, non-adherence rates also go up. The right here is data from the Korean National Health Insurance Service data. You can see here that in the very elderly cohort and the adult in just the elderly cohort, these two have about a 6% difference in adherence. So this is why the treatment rates, the control rates are going down in these elderly patients. And poor adherence also increases adverse events. In these, compared to adherent patients, those with non-adherent patients will have more adverse outcomes such as ER visits and hospitalizations and death. And it's also this has also been examined in the Korean data in this Korean National Health Insurance Service sample cohort. You can see that for compared to those with good adherence, those with intermediate adherence and poor adherence have a very higher risk of mortality and cardiovascular and also stroke events. So it's very, very important to make these patients adhere to their medications. And why isn't patients adhering to their medication? Because one thing is that they have too many medications to take. We also all see in the clinic how patients come into the clinic and all complain of how many medications they are taking. Two for the hypertension, they have to take aspirin. They also have to take a statin, maybe for diabetes. So that's about 4 to 5 over there. And it has been reported that up to 20 to 30% of new prescription medications do not really get filled by patients. Of course, this is not really true in Korea because they just put it all in a small plastic bag, so they do get filled, but patients are likely not to take some of the medications they are being prescribed. So drugs don't really work if those patients don't take them. So like this here, the patient visits the clinic, he will take the medications for up to about 2 months and suddenly discontinue treatment and come back a year later. These days, we all have electronic health records. We see how many medications that we prescribe them, and there is a calendar that tells me that his medications should have gone. He doesn't have any medications for the past 6 months, but he still says that he has been taking medications that somehow he still has left over. So that means he is not very adherent to his prescriptions. Some patients might take those medications, they might try to take them every day at the same time, but they might go up. Sometimes they would take it in the morning, sometimes they would take it in the evening, sometimes they wouldn't take it, and when they are due back in the clinic, they will suddenly start to get them again. So there's a very old saying, the more you give, the less they take. So as the number of medications go up, the adherence rate goes down. So if you are giving up more than 6 medications, the patients are likely to take only half of them or only take half of the time taking medications. And why are these patients so non-adherent? One of the reasons is that a lot of side effects lead to non-adherence. Even in patients with well-controlled blood pressure, as the number of side effects go up, the percentage of non-adherent patients also go up. And this is more so when your blood pressure is not controlled well. So where we need to think when these patients are non-adherent. They may just be saying that they are taking all these medications, but we need to suspect some situations like when we are prescribing enough medications to control their blood pressure, but there is a lack of efficacy of treatment. His blood pressure is the same when I am giving him 1 medication, 2 or 3. It's always 150 over 90. That means that somehow he might not be taking the medications that I'm giving him. His blood pressure might have a very big variability. Sometimes his blood pressure might be good, sometimes it might be bad. That's also when to suspect non-adherence. He might have a lot of adverse events. That means that although he might be taking all the medications, he is very likely to get non-adherent. And also when there is resistant hypertension, it's also same as lack of efficacy of treatment. He might really not be taking his medications. So there are many factors influencing adherence. I've talked about the number of pills, polypharmacy, and the side effects, but there are also other influencing factors among older adults, like demographic factors. Age itself might be a risk for non-adherence. Female sex might also be a risk. There may be medical conditions. He might have very many comorbidities that make him take many more medications. And also behavioral factors such as patient preference. Some patients might not want to take any medications, even if the doctor tells them that they need to. And there are also economic factors such as he might not be able to pay for these medications. So previous studies have shown that maybe impaired vision is a risk factor for non-adherence. History of smoking, depression, and regimen complexity, they all have an increased risk of having the patient non-adherent to the medications. Also in Korea, this is one from this is a Korean data. You can see that if you're compared to those in the metropolitan area, in these big cities, those living in smaller cities and the rural areas have a tendency to not adhere to their medications. The funny thing is that if you have other comorbidities, I keep saying that having comorbidities and having to take more medications kind of lessens your chance to be adhered to the medications. But in this study, as you have more comorbidities, you are more likely to adhere to your medications. That means they might be more keen to their health. And also in this dementia score, if you have a cognitive impairment, it is also less likely that you might be adherent to your medications. There are many interventions that could increase adherence. You could have an educational intervention. You can change the behavior of the patients, or you can both mix these up. You could also educate the patients. The pharmacist could educate them, a nurse could educate them, a doctor could educate them. But the best thing is have both mix both education methods, and also have a very different kind of medical personnel teach the patient how to adhere to their medications. So what kind of medications are there? They could be behavioral, they could be educational, and they could be provider focused. I'll talk about some of them in this slide. So you could train the healthcare professionals in communication skills. We could educate the doctors, nurses to how to educate patients in adhering to their medications. However, these kind of previous studies have shown mixed results on adherence, and there has been no really significant impact on blood pressure. We could use single pill combination drugs instead of free equivalent combinations. These interventions have shown to have better adherence with single pill combinations, and also have a significant difference in lowering systolic and diastolic blood pressure. Also, we could use the effectiveness of fixed dose combinations. The same way as the single pill combinations, they have had a significant improvement in adherence. We could use electronic cues such as smartphone apps, which have shown to have significant improvement in adherence and also in lowering blood pressure. And also pharmacist-led interventions have shown positive outcomes on adherence. In case of treatment, how we should prescribe medications, we could simplify the drug regimen so the patient could easily take the medications. We could use single pill combinations, use long-acting drugs to once daily dosing to lower the number of medications the patient has to take. And we could also avoid high doses of medications and avoid adverse effects of those drugs. In the elderly, simple prescriptions is very important. So we want to start from a less intensive treatment, a lower dose of drug that would lower the risk of orthostatic hypotension. We could start at the half standard dose, how we should give younger patients. And we should also consider combination therapy and single pill combinations, and check orthostatic blood pressure once in a while to check to see if the patient has any side effects to these medications. And we should also remember to try to lessen the number of medications that patients are really taking. We just prescribe the patients 6 months, and they will come back 6 months. We'll ask them if they're okay for about 2 minutes, and we usually just prescribe the same medications again for 6 months. But we should really check to see if these elderly patients really need these medications. If there is a medication that does not benefit the patient, we should consider withdrawing the medications, follow them back up in about 1 or 2 months, see if there are any side effects or if their blood pressure has gone up. If it doesn't, if the patient is very stable, we could just delete that medication from their list, and the next time they come, we could try another medication, and we don't want to really copy and paste all these medications every time. And in the patient factor, we could educate the patients, tell them that taking these medications are very important. They should try to lower their risk factors by keep on their medications. We could use motivational interviewing to do this. We could promoting self-care, telling the patients to monitor their home blood pressure and to see how well they are getting treated. And we could also use electronic cues such as smartphone applications to remind the patients to take their medications, take home blood pressure records, and share this information with the medical personnel. And there are many electronic cues we can use: emails, websites, SMS, phone calls, and smartphone apps. You can see here that these two, phone calls and smartphone apps, are the most effective in lowering systolic and diastolic pressure, which means that the patients are more adherent to these medications. You will be really amazed at how many smartphone apps there are. I actually don't recommend patients to use the apps, but some patients, a lot of patients show me when I ask them how their blood pressure has been. Some of these patients take out their phone and show me the apps, and there are really colorful, well-designed, easy-to-use apps that there are on the market right now. Even though some people still write all their blood pressure on a paper and give it to me, I think the prevalence of patients using these smartphone apps are getting more and more. And if you look on Google Play Store or on the Apple App Store, there are very, very many apps that you could use. Also, these days, they also have a pill identifier. I still use a website to see what kind of medications the patients are taking. But these days, you just have to take a picture, and an app will tell you what that medication is, what kind of medication it is, how you should take them, and access the side effects and education materials are also in these apps. And also, very many people are using smartwatches, electronic cues that beep when you have to take the medications. So elderly people also use all these smartwatches, and this would also be a great way to help the elderly keep adherent to their medications. And these elderly patients, we sometimes think that they might not be really friendly with these smartphones, but you can see here that this is also a very old data, but there is a very high, these patients, elderly patients, are very keen to use new technology and new smartphones. So I don't think that was going to be a really big problem. And also, there has been a very evolution of these pill boxes. These weekly pill boxes have been very evolved to they have a smartphone applications showing that how many pills you take. They tell you that whether you took the pills or not, what kind of pills you should take, and you could locate what kind of pills in these boxes to see how patients are really adherent to these medications. So using these methods could topple the barriers of medication adherence, which has the biggest one is the time management, including forgetfulness. Using smartphone cues, electronic cues, and these pill boxes could help in the future. So my take-home message is that age itself is not really predictive of non-adherence. However, these prevalence of risk factors for non-adherence increases with age, such as polypharmacy, these cognitive dysfunctions, and poor social support. And physicians should continue efforts to eliminate these factors that could lead to non-adherence, especially in the elderly. Thank you.
Thank you, Dr. Oh. So next speaker is Choi Jung-yeon from Seoul National University, who is graduated Seoul National University and is now in Seoul National University. She will talk the title of Personalized Lifestyle Modification Program in Elderly Hypertensive Patients. Please.
Thank you for the kind introduction. It's my great honor to have this opportunity to have scientific session with therapeutic concept in this conference. I'm Jung-yeon Choi, Assistant Professor of Division of Geriatric of Seoul National University Bundang Hospital. Topic of this presentation is about personalized lifestyle modification program in elderly hypertensive patient. For the contents of my presentation, I will introduce general recommendation and their effectiveness in lifestyle modification for the hypertensive patient, including both elderly and non-elderly. Then we will talk about barriers to maintaining lifestyle modification among older patients in actual practice. And lastly, personalized lifestyle modification in older hypertensive patients will be presented. More than 50% of hypertensive patients have additional cardiovascular risk factors like smoking, obesity, diabetes, alcohol consumption, and sedentary lifestyle. So lifestyle modification is recommended for all hypertensive patients and also for the patients who are pre-hypertensive stage. To reduce blood pressure and complication of hypertension, lifestyle modification is the cornerstone and is the first line of antihypertensive treatment. So modification of lifestyles also known to enhance the effect of the medications. Various international guidelines were consistent in most recommendations, and recommended lifestyle modification for hypertensive or salt restriction, healthy diet and drink, moderate alcohol consumption, weight reduction, and smoking cessation. Because there is strong evidence for the relationship between high salt intake and increased blood pressure, reduce the salt adding or avoid consumption of high salt food or the processed food are recommended. And for the diet and drink, eating whole grain fruit, polyunsaturated fat, dairy product, and vegetables is recommended. On the other hand, sugar, saturated fat, trans fat, coffee, and tea is recommended to avoid. Positive linear association exists between alcohol consumption and blood pressure, prevalence of hypertension, and cardiovascular risk. So alcohol consumption should be limited under 2 glasses of wine or beer. Obesity, especially abdomen obesity, is risk factor of cardiovascular disease. And ethnic-specific cutoff for BMI are recommended to use. And according to the Korean Society of Hypertensive Guideline, hypertensive patients are recommended to reduce their weight to below BMI 25. Smoking is the major risk factor for CVD, COPD, and cancer. The risk of cardiovascular disease cannot be reduced if hypertensive patients continue to smoke, no matter how well they control their blood pressure. So smoking cessation and referral to the smoking cessation clinic should be advised for all hypertensive patients. Exercise is one of the key elements of the lifestyle modification and also known to be beneficial for hypertensive patients with lowering blood pressure, improving cardiorespiratory function, weight loss, and other comorbidity, as well as relieving stress. Regular aerobic and resistant exercise may be beneficial for both prevention and treatment of hypertension. Chronic stress known to be associated with high blood pressure in later life, although more research is needed to determine the true effect of chronic stress and blood pressure. Some randomized clinical trials examining the effect of meditation and mindfulness on blood pressure and suggest that this practice could lower the blood pressure. Depending on the type of the lifestyle modification actually causes some systolic blood pressure reduction and also diastolic blood pressure reduction. DASH diet and the regular aerobic activity exercise shows highest blood pressure lowering effect, and low salt diet and reduced alcohol consumption also lower blood pressure about 5 mmHg. An effect of body weight reduction on blood pressure also exists. Good diet and eating habit and regular exercise are known to improve not only hypertension but also frailty, sarcopenia, cognitive decline, and quality of life, which are primarily concerned in the older patient. In the older population, salt restriction and weight reduction was also validated to be helpful in lowering blood pressure in the TONE study. Older hypertensive patients aged 60 to 88 years were recruited and randomized to reduce sodium intake, weight loss, both, or usual care depending on the obesity status. All older hypertensive patients maintaining less than 5 grams of salt showed significant lower hazard ratio for composite outcome, and obese older hypertensive patients who are maintaining weight loss of over 4.5 kilograms or greater also lower their risk. And the patient group who underwent both weight loss and low salt diet showed the most significant risk reduction. Therefore, it has been proven that the weight reduction among obesity patients and salt restriction reduce blood pressure in older hypertensive patients. So there is many sufficient evidence that lifestyle modification can lower blood pressure even in the elderly, but there are many reasons to make it difficult to implement the lifestyle modification in actual clinical practice. There is a gap between reality and the ideal, especially among the older patient. In the case of middle-aged patients who have good physical or cognitive performance and not so complicated comorbidity, there is no major problem in treat them according to the disease-specific guidelines. But the clinical studies that are used as a reference for making guidelines, patients with incapable self-determination or with complex chronic disease are excluded. In addition, though the treatment goal of the chronic disease among the general population is to prevent long-term complication, but in case of the older patient, life expectancy, compliance to the treatment, or the side effect of the treatment, and quality of life should also be considered. Thus, there are many difficulties when providing evidence-based management for older patients. Though the beneficial effect of lifestyle modification for cardiovascular risk reduction and BP lowering is well recognized, compliance of lifestyle modification of older patients is low for many reasons. On understanding of the barriers that prevent people from achieving recommended level of physical activity or dietary modification is needed to inform the development of personalized strategies to promote the lifestyle modification in real clinical practice. So the previous research investigated and proposed time factor and the health-related factor like concerns of fallings and physical limitation according to the comorbidity or aging. The motivating factor was social encouragement, getting familiar with lifestyle modification, and improvement in self-esteem and self-worth, and factors associated with sufficient education. The detailed barrier to exercise and dietary modification among older patients were the older patients believe their physical activity or dietary behaviors are already healthy, and half of them were not aware of current guidelines. And 20% of patients are not know how to be physically active and which food is healthy. Some older patients expressed that dissatisfaction with eating wealthy food and complained about not having enough time to exercise. It is essential to know which factor or why it is challenging to maintain lifestyle modification in actual practice when providing them to individualized assessment and lifestyle modification programs. Some physiological changes and factors according to the natural aging could be a barrier to healthy lifestyle modification, or the cognitive dysfunction, a decreased sense of smell and taste, and dry mouth, malnutrition, sarcopenia, osteoarthritis, and loss of balance. These changes become a barrier to properly understanding the importance of lifestyle modification and its implementation. For the key consideration for successful implementation of lifestyle intervention among older patients, there are some points to consider in assessment, intervention, and outcome measurement. In frail older patients with diverse medical problem list, there are critical points to consider to increase compliance with lifestyle modification. To personalize strategies for lifestyle modification, I think that proper assessment for cognitive and physical function, nutritional status, willingness, and compliance for antihypertensive treatment is essential. And also for older patients with limited cognitive and physical function that are difficult to understand and understand about the lifestyle modification or to perform it, it is necessary to present them a more simplified education program and suboptimal intensity exercise regimen to both patient and caregivers. Because older patients are particularly easy to fall down and get injured during the exercise due to their limited joint and muscle function, provide them to tailored exercise suboptimal even if it is suboptimal program, or supervised exercise until they entirely familiar with it, will improve compliance and also safety. Since older patients have a reduced sense of taste and smell, if they maintain too strict salt restriction or DASH diet for an extended period, even if the blood pressure is lower, but the malnutrition and sarcopenia and their quality of life will be decreased because of their decreased appetite. Therefore, it is crucial to check compliance with the healthy or low-salt diet or lifestyle modification, but it is also essential to check their nutritional status in between. As outcome indicators, blood pressure or cardiovascular outcome could be the target of the lifestyle modification. But I think they have limited life expectancy. It is also important for older patients to evaluate functional and nutritional changes which can affect quality of life. So in particular, older patients needed very, very repeated education and education using audiovisual materials. It would be useful to educate and distribute them to educational book with visual materials, which food are good to eat or harm to eat, rather than the vague instructions like DASH diet or white meat. So, yes. And lastly, even if the patient has physical limitation or disability, even they have disability, it is important to encourage them to move even a little more, because there is a dose-response relationship between physical activity and blood pressure lowering effect. And it is better to sit or go out in a wheelchair than just lie in bed. Increasing physical activity also helpful for prevent or treat frailty, sarcopenia, and cognitive impairment, and could improve their health-related conditions and quality of life. This is end of my presentation. Thank you.
Thank you for nice presentation and extensive review. And next will be Professor Kim.
My name is Gwang-il Kim at Seoul National University, and I will introduce next two speakers. Next speaker is Professor Yuda Turana. He is the former president of Indonesian Society of Hypertension, and he is currently the president of the Indonesian Society of Gerontology and the chairman of the study group of neurogeriatry of the Indonesian Society of Neurology. His topic today is the cognitive aspect of hypertension management in the elderly. Professor Turana, would you please start?
Thank you for the nice introduction, and thank you also for the committee that already invited me in this very wonderful event. It's a great honor for me. So my topic today is about the cognitive aspect of hypertension management in elderly. This is my disclosure. I have no potential conflict of interest in the relation of this presentation. So population aging rapidly accelerating in Asia more than the other regions, and with the consequences of increasing of disease related to aging like cognitive decline and dementia. Until now, we cannot stop the degenerative process, so we should focus on the risk of dementia. And one of the major modifiable risk factors is hypertension that can preventable and treatable. So accelerated disruption of homeostatic in brain aging to become neurodegenerative disease can provoke by several risk factors like genetic predisposition, education, lifestyle, environmental risk factor, presence of disease like hypertension, brain lesion, and several pathophysiology mechanism also explain why hypertension as a risk factor of cognitive impairment and dementia. And I think in this slide we can see a lot of studies, especially the longitudinal studies. They shown the consistency of the hypertension as risk factor of cognitive decline and dementia, and the midlife untreated hypertension, treated but uncontrolled hypertension, and high SBP become the risk factor for the later life cognitive impairment. And we can learn also from the meta-analysis study about the association between BP lowering with antihypertensive therapy and the outcome of dementia or cognitive impairment. This meta-analysis that included 12 trials with more than 90,000 participants with follow-up up to 4 years, and concluded that lowering blood pressure may be associated with the lower risk of dementia or cognitive impairment. And the cognitive decline and dementia in older person, not only as an outcome of hypertension, but since cognitive decline and late life vascular depression, the illness perception can influence also the adherence, I think in line with the first speaker. And the adherence can influence the management of controlling hypertension. So this is become the bidirectional relation between cognitive impairment, dementia, and with hypertension. So as we know also in neurodegenerative disease, in very old elderly, not just only related with the high BP or chronic hypertension, but also with the low BP and hypotension. On Harvard trial intervention for high BP in the very old elderly did not significantly reduce the incidence of dementia. In the study, the orthostatic hypotension indicates an increased risk of dementia and cognitive decline. So based on this study, intensive BP treatment to prevent dementia must be cautiously, especially in very old and frailty person. This condition of low BP in very old older people can induced by several mechanisms like neurodegenerative process that affecting brainstem and hypothalamic nucleus, associated with the systemic changes like weight loss and increased frailty. Also the secondary to the onset of the cardiovascular diseases such as myocardial infarction and congestive heart failure. I think not only just only focus on the indication and effectiveness in lowering BP, but afterset effect is one of the consideration in the treatment of the hypertension, especially in the frailty elderly. Like in multicenter prospective observational cohort study, show us that the increasing number of antihypertensive was not associated with the lower systolic or diastolic BP or with the higher proportion of patients attaining target BP, but and the rate of the adverse health events was higher if we comparing with the other randomized control trial of the other antihypertensives. In this picture also we can see the relation between the midlife hypertension and late life very high BP that associated with atherosclerosis, hypertension in midlife, particularly when untreated, may give rise to increased arterial stiffness due to atherosclerosis, which itself associated with the cognitive decline and dementia. And the severe atherosclerosis will induce late life low BP and can influence cerebral hypoperfusion and make cerebral hypoxia and brain ischemia. Orthostatic hypotension also causes poor frontal lobe perfusion, which can affect executive function. How about the role of the blood pressure variability related with dementia and cognitive impairment? BPV is increasingly being recognized as having significant role in target organ damage. Several longitudinal studies have also reported that the BPV is significantly associated with increased risk of cognitive impairment and dementia. And exaggerate BP variability like nocturnal hypertension, 24 hours BPV, visit-to-visit BP variability, orthostatic hypotension can induce cerebral blood flow fluctuation, endothelial dysfunction, inflammation, oxidative stress that can make injury to our central nervous system with the consequences of cognitive decline and dementia and other neurodegenerative disease. In this figure, we want to capture that the BPV as the result of neuropathology in the brain, but also BPV as the risk factor of neurodegenerative disease. In neuropathophysiology of brain degenerative will involving several important areas in the brain that will make clinical manifestation of autonomic dysfunction, neuropsychiatric and sleep disorder that can induce the BPV. But the BPV itself will become a risk factor for dementia and Parkinson. And I think this is the old study also, that observational studies in elderly subjects that daily increase in BPV lead to the development of dementia in the form of either vascular dementia or Alzheimer's disease. So related to my presentation, I would like also to refresh about the result of the SPRINT, especially the SPRINT MIND trial. The SPRINT designed to test the efficacy and safety of lowering SBP with an intensive treatment goal below 120 versus the standard treatment on the major cardiovascular disease outcome. And the result we already knew, that the intensive one improved the CV outcomes and overall survival compared to the standard therapy. And the SPRINT MIND, a sub-study of SPRINT, evaluated the effect of intensive SBP on mild cognitive impairment and probable dementia with a subset of participants completing MRI brain. On this sub-study of SPRINT, try to answer some question about the ideal goal of blood pressure to preserve cognition, the brain function, and also the brain structure. In this table, we can see that the intensive lowering BP did not result in a significant reduction in the incidence of the probable dementia compared with the standard treatment. Mild cognitive impairment and the composite of mild cognitive impairment and probable dementia as the secondary outcomes in SPRINT MIND were significantly reduced in the intensive lowering group compared with the standard treatment group. The other outcome from the SPRINT MIND want to know whether the intensive lowering BP have a brain structural protective effect, and several structural variables in the brain like white matter lesion, brain volume, and cerebral blood flow were measured in the SPRINT MIND. We can see in this table that this is the outcome like white matter lesion, volume, and also the total brain volume. This is the intensive treatment, this is the standard treatment. And we can see in here in the intensive treatment have the smaller increase in white matter lesion. But the problem also the greater decrease in total brain volume comparing to the standard treatment. This is the unclear, still unclear why this happened in the intensive treatment, have the greater decrease in brain volume. So in SPRINT also the measure about the blood pressure variability, and the BPV have significantly correlation with dementia, and the rate of dementia was increased by the increase of the BPV. The conclusion in the SPRINT MIND and that among the hypertensive adults targeting an SBP of less than 120 compared with the less 140 did not significantly reduce a probable dementia, a smaller increase in cerebral white matter lesion volume, a greater decrease in total brain volume, although the difference is small, especially in male respondent, increase of cerebral blood flow, and there's a statement in the original paper that because of the early termination of the main study, SPRINT MIND might have been underpowered. So I think this is my conclusion to my presentation. The increase of mild cognitive impairment and dementia is strongly related to population aging and hypertension in Asia. Midlife hypertension is associated with the higher dementia risk irrespective of late life BP. Intensive BP control, SBP goal between 120 to 130, significantly reduce the risk of mild cognitive impairment and combined rate of mild cognitive impairment and probable dementia comparing to the control group. And effectiveness of hypertensive treatment on the cognitive improvement is still inconclusive, especially in very old people. Further research is needed to make evidence-based medicine recommendation. Beyond hypertension, higher BPP is a major clinical predictor of cognitive decline. BP in aged people should be carefully managed. Personalized care for patients with hypertension, especially for patients who are frail or very old, is encouraged. I think this is the end of my presentation. Thank you very much. Kamsahamnida. Thank you.
Professor Tuana. The last speaker is Professor Benetos, and it is a great honor to introduce Professor Benetos. He is the professor and the chairman of geriatric and clinical gerontology at the University of Nancy. He is the immediate past president of European Geriatric Medicine Society and the chairman of a working group of European Society Hypertension on hypertension in old adults. After watching his recording, he will join the discussion.
Dear colleagues, dear friends, I'm very pleased to be present online to your Congress, annual Congress, and to present you some principles, let's say, of the management of hypertension in older adults according to the frailty and functional status. Well, let's start. To answer that question, we have to make a first clarification. And this is what we are calling older or elderly. What's the threshold? Is it 60? Is it 80, 70, or whatever? I would like to clarify that from the beginning, because we know that the patients between 60 and 79 years old have clear benefits of the antihypertensive treatment on cardiovascular morbidity and mortality, as it has been shown, clearly shown in several studies during the last 30, 35 years. So the question is not the 60 to 79, and the target blood pressure levels of the treatment should be probably 140, less than 140 over 90, and maybe for some people less than 130 over 85. The question is, what about the patients over 80? In this population, we know there is a very important heterogeneity between the different individuals. So it's at the same time the most growing population and the most heterogeneous population. We know that the Hypertension study several years ago have studied that question and gave an answer. Active treatment versus placebo treatment, patients over 80, the Hypertension study showed clear benefits in favor of the active treatment as compared to the placebo, as you can see in this slide, for almost all the different cardiovascular parameters. But can we apply this data, these results, to all patients over 80, independently of their functional status and their frailty? This is an important question. The Hypertension study answered that there is no evidence that frailty modifies the positive impact of antihypertensive treatment in these patients. So they analyzed subgroups in Hypertension study with or without frailty, and they didn't find any difference. So they concluded what you can see in this slide. The problem is that this very important study had excluded from the beginning any person with several frailty or loss of autonomy, as you can see, living in a nursing home, having a limited autonomy, having a clinical dementia, heart failure needing medications, very known medications, orthostatic hypotension, renal failure, and patients presenting a high probability of having a major health problem during the next 5 years, during the follow-up period. So all these people with one of these criteria were from the beginning excluded. So we can compare more or less frailty, but the most frail are not in the study. So we cannot really conclude what we have to do from that study, what we have to do in the very old and very frail patients. And this is an important part of the people over 80. This is why we put the threshold at 80, because there are many people, as I show you, with a marked frailty and loss of autonomy after that age. And clearly, the latest European Society of Hypertension and Cardiology guidelines back in 2018 said that one of the major gaps in the knowledge of the management of hypertension concerns the role of frailty in older patients, as you can see here. So, very recently, in editorial in Hypertension, how low should you go in the presence of frailty? They said we have to have more clinical trials, pragmatic trials, which means in this population, the frail people, and in the meantime, high quality observational studies and epidemiological and statistical analysis may help to find some proposals for these patients, since for the very frail, we don't have many results from controlled studies. And I will show you some of these results from the observational studies. Back in a few years ago, we have published this study showing that in nursing homes, in people over 80, those with low systolic blood pressure, less than 130, and having more than one antihypertensive treatment, these drugs, more than one antihypertensive drugs, have a double mortality as compared to all others. Very similar results have been observed in several other studies. I show you just one other study. This is from the Leiden cohort from Holland. And in that study, they show that the population, in this population, 5-year follow-up, they found that low blood pressure, systolic blood pressure, was associated with higher all-cause mortality and faster annual cognitive decline in participants with antihypertensive therapy, not in participants without antihypertensive drugs. So, frail people, especially those with antihypertensive drugs, have inverse relationship, observationally speaking, between systolic blood pressure and events, mortality and morbidity. And also a very recent study in hypertension showed that the highest the frailty, the most pronounced this inverse relationship between systolic blood pressure and event, the risk of events. You see here, in non-frail subjects, we have an expected relationship. It's almost linear, lower than 130, and increases with high blood pressure. It's the opposite in the very frail people. The highest the systolic blood pressure, the lowest the risk, which is very curious result, but we have to take into account. So this shows that we use or use not a treatment or an aggressive therapeutic strategy not according to the blood to the age, chronological age, but mainly according to the frailty status and the functional status of the people. Of course, the older we are, the probabilities to have this alteration of a functional status. And about 6 years ago, in order to contribute to this effort, we have published a common group of experts of the European Society of Hypertension and the European Society of Geriatric Medicine have published this document proposing, for instance, accurate information on functional capacities and cognitive status, attention to multiple drug administration, very common in these ages, and stratification of the frailty status by one of the available rapid methods. So, in these people, we have, first of all, to treat, let's say, more individually, according to the frailty and all these problems that I show you an example right after. We have maybe reduced the treatment if systolic blood pressure is very low, or if we have orthostatic hypotension, we have to fight against blood pressure lowering factors, medications or diseases, dehydration, malnutrition, and so on, and fight against polymedication. So we have to integrate, we have to introduce all these parameters in our thinking for the management of high blood pressure. And 3 years ago, with two other colleagues from the European Society of Geriatric Medicine, we proposed this, let's say, example. We said, let's take these images in order to understand each other, what we are talking: fit, moderately, let's say, frail, with some, and very frail. So on the left, in the left part of your slide, here you have people that are fit. And for those people, we will see we will have one strategy. On the other extreme, in red here, you have examples of very altered people with severe frailty, with terminally ill patients, and so on. And in the middle, you have what we can call a big number of older patients over 80 who are slowed down. They still keep some autonomy, but they are really slowed down, and at the intellectual cognitive level and at the physical or the physical level. So we propose different strategies. In those with preserved, the first part, the fit people, we have to have very similar attitude and strategies as in younger people. But we will go a little bit slower. We start with one medication, we will increase treatment if necessary in a slower manner, but the aim is the same, 130, 140 of systolic blood pressure. At the other extreme, we don't have any real data. And we have to see for each patient, those very ill people, if it's very high, the pressure to decrease, maybe to decrease around 150, 140, and think of reducing treatment if it's less than 130 for the reasons I show you for the most frail people. In the middle, those in the middle, we have to see if they are closer to those with preserved function, you can see here, the most red, or closer to the let's say, this group of very important alteration. And for this group, it's very important, a very detailed geriatric assessment to understand which are the strategies to choose according to the functionality and the frailty status. So, what I want to say is that we cannot have a single strategy for people over a certain age. What I want to say is that the level of frailty and functional capacities and the autonomy are the main factors for determining the therapeutic strategies. All the data from clinical trials we have currently are coming from studies that have been done in older people, but fit older people. The very frail people have never been included in clinical controlled trials, never. So we are now running such a study in nursing homes in these patients. We don't have still the results, but this is a controlled randomized study. So waiting for the results for this study and other studies, what we can do is try to assess frailty. There are many ways to do that, to assess functional capacity, and the fitter are the patients, our strategy will be closer to what we do for younger people. And the more altered are the patients, the most important the loss of functionality and autonomy, the less aggressive we will be, and then we will also think about reducing the blood pressure treatment if necessary in order not to obtain very low blood pressure levels. Thank you for your attention.
Thank you. Now this session is open for discussion, and we have 4 distinguished panelists. Jae-hyung Park from Chungnam National University, Jung-hyun Choi, Busan National University, Kyung-guk Hwang from Chungbuk National University, and Seok-jae Hwang from Gyeongsang National University. And please connect the Professor Benetos. Professor Benetos, can you hear me?
Yes, very well. Thank you very much. Very pleased to be here with you.
Thank you for joining this discussion. And who will start the discussion? Jae-young Park, would you start?
Professor Benetos, how are you?
I'm fine. Thank you very much.
I actually impressed by your excellent lecture, and the frailty is an important influencing factor in the management of elderly hypertension patient. When I face the patient, especially elderly patient with vulnerable or mildly frail patient, when I give the medication for reducing blood pressure, I wonder whether he or she can have fracture after the medication. So how often do I follow up after giving the medication for reducing blood pressure, and how often do you follow up at that patient? Usually vulnerable or mildly frail patient, or other frail patient. Thank you.
Yes, this is a very important question, very practical in our clinical practice, of course. I would say that, of course, it depends on many factors. From the purely cardiovascular point of view, the frequency of visits, let's say at the beginning, we can see the patients every 3 months at the beginning. I give an example. The most important thing is what do we have to follow during these visits, control visits, in addition to what we do for everybody. And I think what's very important, and has been mentioned by the previous speakers, is the question about blood pressure also at the upright position. I insist on this point because we have to check for orthostatic hypotension even in patients, older patients without symptoms related to this orthostatic hypotension. So the frequency, I think it has to be at the beginning about 3 months. We don't have to be hurried. We don't have to want to reduce abruptly blood pressure, even if it's very high at the beginning in very old people. Is what I have said also, it's better to go slowly, and I don't think there is any benefit to try to reduce rapidly blood pressure and to control very often people, because in that case we may have problems about homeostasis, cardiovascular homeostasis, if we drop blood pressure abruptly.
Thank you.
Thank you for all speakers. I'm Jung Choi from the Busan National University Hospitals. I also question to Dr. Benetos. I really appreciate your inspired lectures, and I thought, I thought it is very important to make some phenotyping in elderly hypertensive patients, even though we have lots of variable definition of frailty, and also some variable we have to measure. So we cannot do every measurement in our real practice. So would you like to suggest 3 or 5 key things we have to measure in our practice?
This is maybe this is the most important question, because we are always saying, most of the people say you have to take into account the frailty level and the functionality level. And then the question is, how can I appreciate that when I'm a GP or a non-geriatrician especially? I don't have 30 minutes to do the evaluation and don't have big knowledge. So this is first also why in this paper we have chosen with my colleagues to put the pictures, because this gives us a common language. What we are talking frail, everybody after 80 has some degree of frailty, let's say, except some very, very, very fit subjects that go to run marathon or whatever. So this is why we put the images to give an idea, the frame, what we call fit moderately frail, and very frail. So now, from the practical point of view, what we propose, and we will try now in the next European guidelines of the Society of Hypertension to be more precise on that, is to say what is the tool that can help us for that. It has to be a tool that it's rapid, not more than 5 to 7 minutes for initial evaluation. It has to be a tool that can be used by non-specialists and not only doctors, physicians, but also other health professionals. And the third one, it has to be a tool that evaluates several functions. So I have some examples for that. For instance, the images can be an example we showed. A second, maybe more complete, is some small scores, like for instance, the latest WHO score called ICOPE, ICOPE. And there is about 10 questions in this questionnaire, and everybody can ask these questions. So to try to assess very rapidly, roughly, the main functions, which is cognitive, psychological, physical, sensorial, eyes and ears, and nutrition, with very basic questions. I will not develop that now, we don't have the time, but you can check that. And there are some other scales, for instance, the Edmonton's frailty scale, which also put questions about these 5 major late domains, plus polymedication, plus recent hospitalizations, and so on, and social life. So it's very important not to assess only physical frailty, but also, I repeat, cognitive, psychological, social, nutrition, sensorial. Very important. And of course, I finish with that. Our role also as geriatricians is to learn the other professional how to do this kind of evaluations. And if we have, after this first evaluation, very rapid evaluation, many doubts or difficulties, we have, for some patients, not for all patients, address the patient to a geriatrician specialist. Thank you.
Thank you.
Thank you for a nice and thought-provoking presentation. I'm Kyung-Guk Hwang from Chungung National University. I have basically the same question with Dr. Choi. Do you have any data or clinical practice principle in a very old population, especially in frail or living alone patients, poor family support patients?
You mean family support patients, you said?
Yes, it's living alone or lack of family support patients, especially in the very old population patients.
Yeah. Well, it's also very important and very large question, of course, because this is, I mean, I can tell you something, but I think you know that, everybody knows that, but my experience being firstly cardiologist and then moving to geriatric patients and geriatric medicine is that every time we see a patient, whatever the reason is we see, we have to have an idea about his or her global functionality and frailty. And there are many studies, not only hypertension, and many data now showing that, for instance, for patients undergoing more severe, let's say, therapeutic interventions like surgery or like chemotherapy for cancer or other, insulin therapy or whatever, we know that the ratio, this is the main thing, how to evaluate each time the ratio between risks and benefits. And this is not easy. I gave some tools, but the evaluation of functionality can help us a lot. And for the people with a very important loss of autonomy, we have always to involve the caregivers, either professional caregivers and or family caregivers. So this is something very complicated for sure, very important, and it's a whole culture we have to promote at the all health professionals how to deal with these patients. We cannot have the same attitude than in patients with a very good functionality. So this is some principle, but it's difficult to answer with details in this question.
I'm Seokjae Hwang. I'd like to ask Dr. Benetos. Thank you very much for your insightful lecture. I think your evaluation about the fragility and functionality in very elderly patients in office may time-consuming. So we have do you check the frailty or functionality of patient by yourself, or consult to a specialized nurse by aiding some special clinics? So that's my first question. And I'd like to ask how to evaluate, check the blood pressure exactly in very elderly patient. Just one measurement of the blood pressure in the office may not properly suggest the exact blood pressure. So do you perform some ambulatory blood pressure monitor in once a year or something like that?
Okay, thank you. Thank you. Again, very important questions, and thank you for asking these questions. It's our everyday practice, of course. First, I say again, yes, it's time consuming. This is why I proposed in my previous answer to the other colleague is to have some easy tools all physicians can do in 5 minutes to have an evaluation. This does not mean that we have to do this for one patient every 3 months, this evaluation. This means, for instance, if we see the patient for the first time, or if we see the patient and we have to change therapeutic strategies, we have to do this evaluation. And this is, we can do, I gave the example with the ICOP tool. There are some other scales, as I said. I gave the example of the Edmonton Frailty Scale. I gave the example with the images also. All these are simple tools that every physician can use for 5 minutes. So we can spend 5 minutes. Anyway, if we want to well treat very old people, generally old people, we have to spend more time than the time we spend for people which are 40 or 50 years old. So if this first evaluation shows that there are some important problems, we have to see, not only just to know it, but if we can improve some of them, if there are nutritional problems, if there are eyes problems, ears problems, risk of falls, which are the actions I can propose. In order to propose actions, we have to do a more detailed evaluation. And in this case, yes, I will send the patient to, let's say you have some specialized nurses that can do the global geriatric comprehensive assessment. And this is something that's much longer. It's about 1 hour and 30 or 2 hours sometimes. And this is something, a very special, let's say, consultation with a specialist, mainly nurses, that be sometimes physicians. So this is the strategy proposed also for the GPs. We say, listen, you have to learn some tools, as I said, rapid, multifunctional, testing several functions. I will not repeat what I said. And if there is a big problem, before starting treatment or starting treatment slowly, and then we can do a more complete evaluation. So this is for your first question. The second question is also very important. How to measure blood pressure in these people? There is something we all know, that especially systolic blood pressure is very variable after a certain age, because we don't have the mechanisms of homeostasis, and blood pressure can vary a lot. So we don't know if it's really high, the pressure, if we want to treat, or we don't know if it's not very low sometimes. So which are the tools we have that? Of course, we can use either the home blood pressure measurements or the 24 hours blood pressure measurements. Personally, for these very old people, I prefer to propose the home blood measurements, sometimes assisted by a caregiver, because people with severe dementia or severe frailty, so physical frailty, they cannot do alone, but repeat measurements at home or at nursing home, these may be very useful. The 24 hours blood pressure measurements, I use it, but not so often, because in the very frail people, this is, I mean, very disturbing. They cannot sleep with this machine. They have other difficulties. I have also, I mean, seen people that are very bothered with these machines. We will use it. It's very useful, 24 hours blood pressure measurement, but less than in younger people. So the home measurements, in my opinion, is the best way to see several measurements in the environment of the person. And I repeat, even people with severe dementia or other physical impairment can have assisted home blood pressure measurements. And always, as I said before, check if people can stay in the upright position, of course, check for 1 and 3 minute blood pressure levels in upright position, because orthostatic hypotension, it's a very frequent and very severe point that we have to check very frequently.
Thank you very much.
I have a question to Professor Turana. And you showed that there was a vicious cycle between the cognitive impairment and the increased blood pressure variability. The increased blood pressure variability can cause the cognitive decline, and also some patients with dementia cognitive impairment, they showed very exaggerated blood pressure variability. So my question is that is there any specific location region of the brain or any specific type of vascular insult that caused the increased blood pressure variability?
Thank you. Thank you for the nice question. The blood pressure variability is, I think, is one of the problem in the cognitive and dementia patient. I always say that if we have the patient, we must remember that when we think about the target organ damage, not just only measure the ECG or the albuminuria, but cognitive assessment. Because if we have the cognitive problem, the patient have the target organ damage in the brain, and this is the high risk, not just only about the cognitive, but the degenerative process, not just only in cognitive, but the other function of the brain. Because if the cognitive problem, the patient have the neuropsychiatric disorder, like in the cortical or in the hippocampus, that can influence about the behavior, also can make the PPV. Of course, if the lesion in our brainstem also make the autonomic unstable. There's the several area that important is like the brainstem, and also the hippocampus itself, the amygdala, and I think all the area of the brain can influence the blood pressure variability directly or indirectly. Thank you.
Thank you. And before closing this session, the KSH prepare a flag of appreciation to Professor Turana. Professor Turana, would you come to the podium?
Good evening. Welcome to the international session for hot topics in hypertension management. My name is Kuno Kim from Hanyang University, Seoul, Korea, and my co-chair is Professor Wok Bom Pyun from Yehwa Women's University, Korea. We have 4 distinguished world-renowned speakers for this session. After all talks are given, the speakers will join us online at the panel discussion. Let me introduce the first speaker, Professor Ramon Hermida from University of Vigo, Spain. Many years ago, I was very impressed with his work published in the Journal of the American Society of Nephrology, which demonstrated that among patients with CKD and hypertension, taking at least one antihypertensive medication at bedtime improved control of blood pressure and reduced the cardiovascular risk. He is currently president of the International Society for Chronobiology and president of the Spanish Society of Applied Chronobiology, Chronotherapy, and Vascular Risk. Today, he will give us his talk entitled Bedtime Dosing of Antihypertensive Medications. Please.
Good evening. I want to thank the organizing committee for their kind invitation to participate in this important meeting. 2 major unresolved questions in the field of cardiovascular prevention are respectively who should be treated and when true hypertensives should be treated. Indeed, there are marked differences between recent guidelines in the criteria for the diagnosis of hypertension. When based on ambulatory blood pressure monitoring, as you can see in the table, most guidelines still recommend using the 24-hour mean for diagnosis. This unsound recommendation disregards the fact that individuals with the same 24-hour blood pressure mean might have markedly different dipping patterns and therefore extremely different cardiovascular risk. Multiple prospective studies, and this is just an example from a paper published many years ago from the Dublin study, have concluded that sleep time blood pressure mean is a much better prognostic marker of cardiovascular risk than the daytime or the 24-hour blood pressure means or even office blood pressure. This statement, however, is only partially valid as the statement by itself implies that awake blood pressure might have prognostic value beyond that of the blood pressure during sleep. When relying on ambulatory blood pressure monitoring, individuals can be categorized in 4 groups according to the awake and the asleep blood pressure means, being either normal or elevated. Each of these 4 groups are represented in the 4 pictures in the slide. Results from the largest prospective ABPM-based clinical study published so far indicate that elevated blood pressure during sleep is a significant predictor of cardiovascular morbidity and mortality, regardless of awake blood pressure being either normal or elevated. Moreover, at any value of blood pressure during sleep, either normal or elevated, non-dippers and risers have significantly greater cardiovascular risk as compared to patients with a normal dipping pattern. Furthermore, the evaluation of the changes in ambulatory blood pressure during follow-up by periodic ABPM assessments in this study indicate that the lower the asleep systolic blood pressure mean might be reduced by therapy, the lower the cardiovascular risk. This cardiovascular risk, however, as you can see in the upper part of the slide, is only slightly and borderline significantly modified by reducing specifically blood pressure during daytime. Indeed, the progressive reduction in asleep systolic blood pressure mean and the increase in the sleep time relative systolic blood pressure decline towards a more normal dipping pattern are jointly the only significant and independent blood pressure-derived predictors of cardiovascular event-free survival. Accordingly, around-the-clock ambulatory blood pressure monitoring should be the recommended means of making the diagnosis of altered ambulatory blood pressure, a term that should substitute the misleading hypertension related only to the concept of elevated level of blood pressure, and therefore accurately assess cardiovascular risk for proper stratification of our patients. The second question, and with this perspective in mind, the second is when people with altered ambulatory blood pressure should be treated. In this regard, the pharmacokinetics of blood pressure lowering medications have been shown to be significantly affected by documented circadian rhythms that influence their absorption, distribution, metabolism, and elimination. On the other hand, differences in the pharmacodynamics of hypertensive medications result not only from these differences in pharmacokinetics, but also from multiple documented circadian rhythms, specifically those affecting the autonomic nervous system and the renin-angiotensin-aldosterone system that activates during sleep. A recent meta-analysis identified 155 clinical trials on ingestion time-dependent differences in the pharmacodynamics of hypertensive medications and their combinations. As this slide shows, the vast majority of these studies reported significant benefits of bedtime treatment. Most important, no single of these 155 reported trials was able to document and enhance blood pressure lowering or other potential desired effects of the traditional but unjustified by medical evidence morning treatment time scheme. These studies investigated a total of 37 hypertension medications in monotherapy of all antihypertensive classes and different pharmacokinetics characteristics, including short and long-acting medications as listed in this slide. The published trials also investigated up to 14 dual fixed combinations, and each one of them reported significant benefits of bedtime in comparison to upon awakening or unspecific morning dosing. The main documented significant advantages of bedtime versus upon awakening hypertension treatment are the greater decrease of blood pressure during sleep, a reduced prevalence of non-dipping, a greater proportion of properly controlled patients according to ambulatory blood pressure criteria, improved renal function, specifically decrease in albuminuria or increase in estimated glomerular filtration rate or both, reduced cardiac damage, a similar or even lower incidence of adverse effects, specifically when ACE inhibitors and calcium channel blockers are ingested at bedtime, and most important, lack of sleep time hypotension, as throughout the 155 papers, there was no single case of hypotension detected among the participants with ingesting medications at bedtime. A total of 53 of these clinical trials specifically target for recruitment high-risk patients, specifically those with a non-dipping blood pressure pattern, those with type 2 diabetes, established chronic kidney disease, resistant hypertension, or patients with a previous cardiovascular event. Among the 53, 51 reported again significant benefits of bedtime in comparison to upon awakening hypertension treatment, and 2 show no differences between dosing times. Again, none of these 53 trials reported any significant advantage of morning treatment. With respect to specific effects on ambulatory blood pressure, 62 of the reported trials conducted with ABPM assessments in the participants show changes and reporting changes in both awake and asleep blood pressure, indicated the results that bedtime therapy was associated with a larger reduction of up to 9 mm mercury in systolic blood pressure mean during sleep, without any loss in efficacy in reducing blood pressure during daytime, and therefore significantly increasing dipping. Current recommendations for the treatment of hypertension, however, disregard this body of evidence and suggest morning dosing with long-acting medications. This is not only unsound but misleading, as this approach cannot specifically decrease blood pressure during sleep further than during awakening, and therefore this approach is unable to revert the non-dipping blood pressure pattern. The recommendations also suggest targeting consistent 24-hour blood pressure control. Again, unsound and misleading for the same reasons above, because as shown in the previous slides, elevated blood pressure during activity only without conjunct elevation of blood pressure during sleep is not increasing cardiovascular risk. And the third recommendation is to avoid bedtime dosing of hypertensive medications because of possible harmful effects. However, the literature shows that such effects, contrary to the documented benefits that I just summarized, are only undocumented assumptions that had never been properly tested or documented in any prospective clinical study. Regarding cardiovascular outcomes, it might be worthwhile just to summarize in this brief lecture and compare the design and conduct of the two largest so far reported trials in the chronotherapy of hypertension, the HYEA chronotherapy trial and the recent TIME study conducted in Great Britain. Contrary to the HYEA trial, the TIME study investigated clock time spans instead of circadian timing, which is extremely more relevant in order to target medication according to the actual blood pressure pattern of the patient. Prescribing physicians in TIME were unaware of treatment time allocation by protocol, which in my honest opinion makes not too much of sense. In HYEA, prescribing physicians were the actual investigators, and they were recruiting the patients, and they were treating their patients and changing their medications when needed. In TIME, recruitment was restricted to treated patients diagnosed only on the basis of office blood pressure, and therefore with a high probability of recruiting individuals with white coat hypertension, and of course not recruiting and omitting from participation high-risk patients with masked hypertension. Moreover, these recruited patients have already controlled blood pressure in the large majority, as systolic blood pressure upon recruitment on average was just 135/79 millimeters of mercury. There was no follow-up blood pressure measurement in TIME, except for a small percentage of participants who provided at least one, but not consecutive, evaluations with self-assessed home blood pressure monitoring. Moreover, there was no recording of any other clinical relevant variable during follow-up, including laboratory data in blood and urine, renal function, potential development of target organ damage. There is no registration in TIME of the medications, doses, and changes in treatment during follow-up prescribed again by practicing physicians who were not participating in the trial and were not aware of the actual recommendation by email of treatment time, which eventually might confound the patient in as much as the practicing physician eventually might give them a totally different recommendation. The reporting of adherence, safety, and cardiovascular outcomes was, according to the authors of TIME themselves, subject to bias for multiple reasons. The large percentage of dropouts, patients with protocol violation, including up to 40% without documented adherence to their assigned treatment time, were all included in the final analysis by intention to treat. According to the authors, an unreported but apparently large number of participants assigned in TIME to morning dosing changed to evening dosing in response to the results of the HYEA chronotherapy trial that were published 3 years before closing of the TIME study. Finally, it is relevant to compare the reported event rates that were actually identical for the evening treatment group in TIME and HYEA, and all this information eventually suggests that the proportion of patients in TIME that were truly ingesting medications in the evening might have been very similar in both randomized groups, and therefore invalidating all the results and conclusions of this study. So, on the basis of all these collected findings, cardiovascular risk assessment and the corresponding diagnosis of altered ambulatory blood pressure should only be based on ABPM as currently recommended already by some international guidelines, mainly and specifically on the value of the asleep systolic blood pressure mean and the sleep time relative systolic blood pressure decline being the two most significant markers of cardiovascular morbidity and mortality. And as also shown in these slides, routine ingestion by these truly hypertensive patients with altered ambulatory blood pressure of their hypertensive medications at bedtime results in greater decrease of blood pressure during sleep, reduced prevalence of non-dipping, greater ambulatory blood pressure control, improved renal function, and reduced cardiac damage without actually increasing any adverse effect. Potentially, all these results leading to the already documented improved prevention of cardiovascular events. Thank you very much.
Thank you very much for your clear and paradigm-shifting message. The next topic to be discussed is renal denervation and will be presented by Dr. Konstantinos Geofis from Hippocrates Hospital, Athens, Greece. He has participated in lots of clinical trials, including spiral on and spiral off, and seems to have the answer today. He is also professor of cardiology, chief of First Cardiology Clinic, Medical School, National and Kapodistrian University of Athens. Now he will give us his talk entitled Recent Updates on Clinical Application of Renal Denervation in Hypertension. Please, probably pre-recorded video is ready.
Dear colleagues, dear friends, first of all, I would like to express my great thanks to the organizers for this kind invitation to participate in the meeting of Korean Society of Hypertension. I apologize for not being able to be there in person, but I hope this to happen next year. Let me share my screen and start my talk. I hope that you are seeing my slides. My task today is to discuss with you the recent update on clinical applications of renal denervation in hypertension management. I will try in the next 15 minutes to elaborate on the following 4 questions. Do we need additional tools to manage hypertension in 2022? What is the pathophysiological rationale for targeted neuromodulation? Does renal denervation represent an evidence-based method to treat hypertension? And last question, what should be the indication for renal denervation? Starting from the first question, the answer is given in this slide. We appreciate here the worldwide prevalence of hypertension and the prevalence of uncontrolled hypertension and undiagnosed hypertension. We see the unacceptable high rates of uncontrolled hypertension worldwide in countries with high income, Western countries, but also the situation is even worse in the countries with low income. So we have a lot of work to do to improve the diagnosis of hypertension and to improve the control of hypertension. Coming to the pathophysiological background, we know that primary hypertension, essential hypertension, is a multifactorial disease. Many factors participate in the pathogenesis of high blood pressure, including genetic factors, environmental factors, and also lifestyle, the way of lifestyle. But we all agree that 2 systems have a dominant role in the pathogenesis of essential hypertension. Renin-angiotensin system overactivity and sympathetic nervous system overactivity. On the other hand, although we know that this mechanism, sympathetic overactivity, renin-angiotensin system activity that leads to the plasma volume overload, participate in the pathogenesis of hypertension, we don't know which one has the dominant role at each individual. So today we cannot, let's say, clarify which is the dominant mechanism for each one individual hypertensive patient. And this we try to overcome this difficulty by prescribed combination therapy in order to blockade more pathophysiological mechanisms apart from simplifying the therapy and improving the medication adherence. We have plenty of data supporting that sympathetic nervous system is activated in hypertensive patients. As we see here, as we go from the controlled patients to normotensive patients, to hypertensive patients, to obese subjects, to those with sleep apnea syndrome, those to heart failure, metabolic syndrome, and renal failure, the sympathetic activity is increased. Here, the sympathetic activity is represented by MSNA, increased sympathetic drive, as we can record by using a microneurography. And for this reason, from the previous century, many attempts have been done to target sympathetic activity. The last century, surgical sympathectomy was performed for treating malignant hypertension. More than 65% of hypertensive patients were have controlled their high blood pressure after surgical sympathectomy. But this method was abandoned due to the systemic side effects, serious systemic side effects. And then in the mid of last century, we had the first antihypertensive medication targeting the sympathetic system, including alpha-methyl-dopa, ganglionic blockers, and as well as the very effective and well-known drugs, the beta blockers. In the last decade, a minimally invasive procedure, renal denervation, was proposed as an effective tool to reduce the sympathetic activity and to reduce the high blood pressure. The concept of renal denervation is not a new one. We know that kidneys are very rich innervated by postganglionic fibers, and we know that increased efferent sympathetic activity results in decreased of renal blood flow, increased renal secretion, and decreased sodium retention, leading to the increased values of blood pressure. On the other hand, in case of kidney ischemia, kidney hypoxia, there is increased sympathetic drive through the afferent renal fibers to the brain, and the increased central sympathetic activity does not only go back to the kidney, but also go to the vessel, cause vasoconstriction, and goes to the heart, promoting left ventricular hypertrophy, left ventricular remodeling, and increasing the arrhythmias burden. That means that by interrupting the renal sympathetic fibers, afferent fibers with renal denervation, we reduce the sympathetic activity, and by this way we achieve blood pressure reduction and also a number of other favorable effects by reducing the high sympathetic tone. The first randomized sum control trial assessing the efficacy and safety of renal denervation in controlling the high blood pressure was the Simplicity-HTN-3 study. And this study was at least neutral or negative for renal denervation. And at this period of time, it was a great disappointment, the results of Simplicity-HTN-3. But fortunately, very soon we understood the confounders that were implicated in this failure of renal denervation to prove its efficacy in reducing the high blood pressure. Based on this better understanding and also in the number of preclinical studies, a series of second-generation renal denervation studies were designed in order to test using a strict methodology whether renal denervation could work, whether renal denervation could reduce the high blood pressure. This is one consensus statement describing the clinical trials design which are the more appropriated for proving the efficacy and safety of renal denervation. Now, we are very happy to have an adequate number of studies in different clinical settings, in different hypertensive phenotypes, in patients naive of antihypertensive medications, in patients on 1, 2, or 3 or more antihypertensive medication. and also by using different technologies, radiofrequency energy or ultrasound energy, to disrupt the efferent and afferent renal fibers. And we see here a consistency in blood pressure reduction by using different technologies and in different clinical settings. Office blood pressure was reduced by 8 to 10 millimeter of mercury in favor of renal denervation compared to control group. And this was also the case for ambulatory systolic blood pressure. Ambulatory systolic blood pressure was reduced by 5 to 7 millimeter of mercury as an average in the renal denervation arm compared to some ablation. In all these studies, ambulatory systolic blood pressure was used as the primary endpoint. Also, all patients have been undergone as in a toxicological analysis to assess the medication adherence. Poor medication adherence, changing the number of hypertension medication, changing the dose of drugs was identified as a major confounder that was responsible for the failure of HTN-3. Additionally, now in the second generation renal denervation studies, the more, let's say, dedicated to anatomical considerations algorithm was used for delivering the energy. Apart from testing the efficacy of renal denervation in patients with uncontrolled hypertension, we have data that renal denervation is effective even in patients with resistant hypertension. The Radiance HTN-3 study assessed the efficacy and safety of renal denervation in patients with resistant hypertension, always on 3 antihypertension medication on a fixed dose, a triple fixed combination, and the patient were randomized to renal denervation into some procedure, and with the 2 months daytime ambulatory systolic blood pressure to be the primary efficacy endpoint. Similarly to the previous studies, Radiance HTN trio proved that renal denervation is an efficacious procedure to achieve blood pressure reduction by 8 millimeter of mercury in renal denervation arm compared to 3 millimeter of mercury in the SAM ablation arm. Nowadays, we have at least 3 systems to disrupt the renal fibers. The frequency renal denervation system, the spiral system introduced by Medtronic, the ultrasound renal denervation system, the peregrine system introduced by Rigor, and the alcohol-mediated renal denervation, the peregrine system introduced by Ablate Solution. We have data from randomized some controlled trials from the first 2 technologies, and now we are expecting data, similar data also from the third technology. My center has a great experience with using all these technologies, and just here an example, we perform an orthography in order to test if there is any accessory arteries. 20 to 30% of hypertensive patients has more than 1 renal artery per side, and after then, with elective engagement, we go to both renal arteries at the right and the left side, and by forward here, let's say the spiral catheter will deliver energy in each of the main branches in one side, and then go to the other side, here to the upper branch. So now we have definite data, solid evidence that renal denervation works. But what about safety? Fortunately, no one study, even the HTN-3 study, raised any concerns about the safety of renal denervation regarding kidney function deterioration or development of new renal artery stenosis. We have data from randomized control trials at 3 years follow-up here from the hypertension HTN-on study, but also data from the Global Simplicity Registry for at a follow-up of 36 months. However, we have to take into consideration some points regarding the use of renal denervation in the management of hypertension. First of all, what we say always on effect. We'll discuss very briefly how durable are the results of renal denervation, what should be the predictors of blood pressure response post-renal denervation, and also the use of renal denervation beyond hypertension. We are happy to see that renal denervation achieves an homogeneous reduction in blood pressure during the daytime and nighttime period. This is not the case for the medication, since their effect is dependent on the persistence and adherence of the patients to receive the drugs every day, according to the prescriptions. And did you know the importance of nocturnal hypertension and the morning blood pressure surge to adverse cardiovascular outcome? And about the duration of blood pressure reduction post-renal denervation, we are happy to have results from the HDN non-medication study showing that these blood pressure drops continue to be present even after 3 years of follow-up. And it is interesting to see that the longer the follow-up, the higher the drop of blood pressure. At 3 years follow-up, 83% of patients were responders to renal denervation compared to 43% in the SAM ablation arm. And same results from the global simplicity registry confirm the durable blood pressure drop post-renal denervation. However, there is a point that we have to take into consideration. Not all patients respond to renal denervation at the same degree. We see here that some patients, the blood pressure is largely reduced, even with 20 or even 30 millimeter of mercury. In some patients, there is no blood pressure reduction. In some patients, the blood pressure starts to raise post-renal denervation. This is the case independently of the method of the system that we have used to disrupt the renal fibers. So it is important to identify some phenotypes of hypertensive patients that would be the best responders. Towards this end, many research have been done to identify potential predictors of blood pressure response. In these lines, we have published here that those patients with increased plasma renin activity may be better responders compared to those with low plasma renin activities, and similarly, patients with high heart rate, office heart rate over 72 beats per minute, are more likely to be responders compared to those with low heart rate. However, up to now, we don't have any single predictor apart from the high baseline systolic blood pressure to predict the blood pressure reduction post-renal denervation. Renal denervation remains a blind procedure. There we have published a couple of years ago that trying to identify some sweet spots where we can ablate and this ablation to be effective by performing high-frequency stimulation and observing the blood pressure increase. And that means that it's indirect evidence that ablate at this point, maybe we will be more effective in reducing the blood pressure. On the other hand, now we are trying to identify to get some help in predicting the blood pressure response post-renal denervation by assessing the urine proteomics in patients who will undergo renal denervation. Hypertension is associated with other comorbidities, and also we know that sympathetic overactivity is present in patients with atrial fibrillation, in obese subjects, in patients with heart failure, in patients with CKD, and now a number of studies are running to assess the potential beneficial effect of renal denervation in these clinical settings. In this line, we assess the effect of renal denervation in hypertensive patients with uncontrolled hypertension and a high degree of stress, and we hope to see some positive results. Coming to the last part of my talk, I would like to make clear that we know that blood pressure reduction per se is efficient to produce a clinically significant reduction in adverse cardiovascular events. 5 millimeters of mercury reduction in systolic blood pressure could be translated in 10% reduction on the major cardiovascular events, and I think that this could be the case also for renal denervation. Based on all of this encouraging and promising data from these second generation renal denervation trials, since we have solid evidence that renal denervation works, a number of scientific societies worldwide, in Europe, in Latin America, in Asia, in Africa, trying to identify potential ideal candidates for renal denervation. Among all of these statements, I think one of the most well-placed and balanced position statement is that coming from European Society of Hypertension. Last September, we published this position paper reporting clearly that renal denervation represents an evidence-based option to treat hypertension in addition to lifestyle changes, in addition to blood pressure lowering drugs. It is important to make clear that renal denervation is an alternative or anti-treatment strategy, is not a competitive treatment strategy to lifestyle or to antihypertensive medication. Also, it is important to make clear that patients' perspectives, patients' preference, a stage of hypertension disease, including comorbidities, should lead to an individualized treatment strategy in a shared decision-making process that carefully includes the various options of hypertension treatment, including renal denervation. So, as a take-home message, dear colleagues, dear friends, I would lay that there is a strong pathophysiological rationale for renal denervation in patients with uncontrolled hypertension. Renal denervation safety is well proven. There are solid evidence for renal denervation efficacy in achieving a clinically relevant and durable blood pressure reduction by measured by office and ambulatory modalities. The burden of uncontrolled resistant hypertension remains high. Having this in mind, in 2018, the European Hypertension Guidelines provide Class 3 recommendation for the routine treatment of hypertension, because at this time, there is no available evidence regarding the safety and efficacy of renal denervation. In the meantime, from 2018 to 2022, we have all this evidence that I discussed previously. Evidence from randomized some controlled trials confirming the efficacy of renal denervation in reducing the high blood pressure in various clinical settings. Based on that, I think that the next edition of hypertension guidelines will provide some recommendations for renal denervation for the management of uncontrolled hypertension. I think that renal denervation may be used in patients with uncontrolled hypertension, at least for those with treated with at least 3 antihypertensive drugs. Always, we have to take into consideration patients' adherence to medication. Always, we have to take into consideration patients' preference. With that, I would like to thank you all for attending my talk, and I am open to any comments and discussion. Thank you.
Thank you very much for your comprehensive talk, and we will move on to the next presentation.
Thank you. We'd better move on to the next topics. Next topic will be presented by the Georgi Sturgiou from Sotria University, Athens, Greece. He is the International Society of Council member and he's chairman of the European Society of Hypertension Working Group on the blood pressure monitoring and cardiovascular variability. He will talk about whether novel automated auscultatory blood pressure measurement technique may or may not be a game changer. Would you please start the video?
Ladies and gentlemen, today I will talk about a novel automated auscultatory blood pressure measurement technology, and I will address the challenging question on whether this can be a game changer. And this is my declaration of potential conflict of interest in relation to this talk. So Stephen Hales was the first to measure blood pressure when he put a glass column in the artery of the horse. Then the cuff method was invented by Rivarocci and the Korotkov sounds by Nikolai Korotkov, and we ended up with this classic manual auscultatory blood pressure measurement. And this amazing device, the mercury sphygmomanometer, has stayed with us in clinical research and in clinical practice for almost a century. Then the automated oscillometric blood pressure measurement method was invented, and this was developed to replicate the blood pressure values taken by manual auscultatory method. So there is consensus today by the International Society of Hypertension and the European Society of Hypertension that the recommended blood pressure monitor should be upper arm cuff, electronic, oscillometric, and properly validated. So the STRIDE BP, which is an organization endorsed by the European Society of Hypertension, the International Society of Hypertension, and the World Hypertension League, provides updated lists of properly validated blood pressure measuring devices to guide healthcare professionals and patients in selecting accurate devices. The STRIDE BP also has accredited e-learning online modules for office, home, and ambulatory monitoring, and these are intended for healthcare professionals for proper use of these blood pressure measurement methods. Unfortunately, only 8%, less than 10% of the blood pressure measurement devices on the market have been approved by the STRIDE BP. The STRIDE BP provides lists of accurate devices for home use, for office hospital use, for 24-hour ambulatory monitoring, and separate lists of accurate devices for children and for pregnancy. And you can see that so far the STRIDE BP has received more than 250,000 downloads from almost 200 countries. So how we can validate a device and make sure that it's accurate? This is a 3 decades history, and you can see we have the American protocol, the British protocol, the German protocol, the European, and so on. At last, in 2018, all organizations around the world agreed on a universal standard for validating blood pressure monitors. And how this global standard works. First, we have the reference method, and this is manual auscultatory taken simultaneously by 2 observers. And then we have the test device blood pressure measurement, and these measurements are taken sequentially. And you can see here a picture from the validation lab in my unit in Athens. Here is the test device, and this here is where the patient is sitting. And these are the 2 observers with their 2 connected mercury devices, and here is the study supervisor. First, we take a mercury measurement to see where the blood pressure of the individual is. Then we take a test measurement to make sure that this device works in this individual. And then the validation session starts. And we take a mercury test, mercury test, mercury test, mercury. These are the readings sequentially. And in the end of the session, we end up with 3 pairs of comparison of test device measurements versus reference mercury measurements. And we have 2 criteria. One is for blood pressure readings, and one is for individuals, participants. So today I'll present you an in-body novel professional automated auscultatory blood pressure measuring monitor, which allows not only automated measurement, but also visual display and review of Korotkov sounds. And you can see here the device. This clearly is a scientific instrument for professional use. And you can see here the cuff with an embedded electronic stethoscope for automated auscultatory measurement. And here you can see the cuff pressure, inflation and deflation. These are the Korotkov sounds curve. And in the end of the measurement, the device automatically reports systolic and diastolic blood pressure and pulse rate. And you can see here how the systolic and blood pressure and diastolic blood pressure are estimated automatically by the device based on the Korotkov sounds. But you can see also that the user can review the Korotkov sounds curve. So the question is this device accurate? And we have performed a formal validation according to the criteria of the universal standard, which I just described to you. This study was conducted in Athens in collaboration with InBody in Seoul and a grant by the Korean government through the University of Athens in Greece. The results were already presented last month in the International Society of Hypertension meeting in Kyoto, and the full paper of the study is under revision in the journal Hypertension and expected to be published soon. So these are the key results of this study. Criteria 1, I remind you, criteria 1 is for readings. 85 patients means 255 readings. And this is the mean difference for systolic and diastolic and the standard deviation. And here are the thresholds, well below. And you can see these are the criterion 2 for systolic and diastolic blood pressure. This is the criteria for patients. Here are the readings, here are the patients, 85 patients, and you can see the threshold and the criterion for the study, which means the device passed all the criteria of the standard, the universal standard, for both systolic and diastolic blood pressure. And you can see here the blood pressure differences from test and reference measurements across different levels of systolic blood pressure, low, moderate, and elevated, similar accuracy across the range, and the same for diastolic blood pressure. And here you can see the accuracy of the device against the reference method across different arm size, small arm, medium arm, and larger arm. For systolic and diastolic, it's clear that the accuracy of the device is the same and sustained in smaller and larger arm size. So question 1, does it provide accurate measurements? Yes, it does, according to the most modern universal standard based on 85 patients. So the most crucial is the question 2. Is this device better than the modern automated oscillometric devices? I'd like to make some comments about the oscillometric devices. You remember that these devices produce an oscillometric curve based on the oscillations of the arterial wall during deflation or some device during inflation. And they estimate systolic and diastolic blood pressure based on an algorithm. They measure the mean blood pressure at the maximum oscillation, and they estimate the systolic and diastolic based on a mathematical algorithm which is specific for each manufacturer and maybe for each model. So several years ago we have reported that in some cases the oscillometric devices may not be accurate. We know that from several studies, but we wanted to see how often this phenomenon is, and we defined unreliable oscillometric measurement as a difference more than 10 millimeters mercury between reference auscultator and oscillometric for systolic or diastolic blood pressure. And we have a large database. We had 755 people, almost 2,000 visits, and almost 5,000 readings. And you can see how common the phenomenon is. It affected 15% of the readings for systolic and 6% for diastolic, almost 10% of visits for systolic and 5% for diastolic, 18% of subjects for systolic and 8% for diastolic, which means it's not a rare phenomenon. And from our analysis and analysis of others, we found that it is the pulse pressure, which is the stiffness of the artery, the arterial wall properties that affect the accuracy of these devices for both systolic and diastolic blood pressure. So if we look at the results of the validation study I just reported you for the InBody professional device, and you look at the thresholds, the pulse thresholds, you can see that the result here is comfortably lower than the thresholds. So the embodied device did not simply pass the protocol, but it comfortably passed with a large difference between the result and the threshold. Second, how does the performance of this device compare to currently available modern oscillometric devices on the market? And here are the results for criteria 1 I showed you. And here you can see the results for 24 automated oscillometric devices. These are the only modern studies that use the new standard in the last 3 years. And you can see here for criteria 1, the performance of the embodied device was better than the average oscillometric device, and this also applied for criterion 1. So the accuracy of the embodied device, automated auscultator, appeared to be superior to that of the average modern oscillometric device. Another aspect of this device is that the observer can review the Korotkov sounds, and they probably this can be a potential advantage for clinical practice. You can see here a normal curve of Korotkov sounds, but here you can see a low Korotkov sounds curve, another one with irregular sounds, and another with some artifacts. When a healthcare professional who is taking manual auscultatory measurement, they measure blood pressure by hearing the Korotkov sounds. They may also identify some measurements which might be rather unstable, unreliable. So in this case, with this device, the healthcare professional again may review and identify and potentially discard low quality readings. We don't have data to prove that, but for the moment, we have some data showing that the observers agree on which devices are potentially problematic, and we're working to show whether this can be useful. So my conclusion about the new professional automated auscultatory embodied device is that the device comfortably passed all the criteria of the universal standard, and it can be recommended for use by healthcare professionals. It has already been approved by the US FDA. In addition, its accuracy, according to the universal standards, appears to be superior to that of the average modern oscillometric devices as compared to recent validation studies. In addition, the visual assessment of Korotkov sounds might be useful in identifying some cases with low quality readings, yet this requires further investigation. So the first two is something we should expect about this device, but the other two, superiority of accuracy and potential advantage of reviewing the Korotkov sounds, are additional benefits of this device. So my conclusion, gentlemen, ladies and gentlemen, is that this novel technology has a good potential to become a game changer for measurement of blood pressure in the office. Thank you for your attention.
Thank you. I'm very happy to introduce the last speaker of this symposium. The last speaker will be Leanne Tuis from McGill University, Canada. I think that she was the president of the Canadian Hypertension Society, chair, High Blood Pressure Research Council in AHA, president of the International Society of Hypertension, and the president European Council of the Cardiovascular Research. She will talk about the advances in antihypertensive therapies. Would you please start the video?
Korean Society of Hypertension for inviting me today to share with you some thoughts on recent advances in antihypertensive therapies. It's important to put this into perspective when we look at the global trends in the prevalence of hypertension, and particularly here I would like to focus on the trends in the prevalence of hypertension in Korea. And what we can see is that from the 1990s to the 2010, there was a decrease in the prevalence of hypertension. However, more recently, we note that the prevalence of hypertension is slowly increasing over time in both men and in women. We can see also in age-standardized data a similar trend for an increase in prevalence, and importantly, we notice that in men and in women with aging, there is a significant increase in the prevalence of hypertension. It's important to appreciate that despite the fact that we have many antihypertensive drugs at our disposal, we are still not doing a good enough job in terms of treating patients to target. In this study by Drs. Park and colleagues, we can see that in Korea, using the old cutoffs of 140/90, the control of hypertension was only about 54%. In other words, of those patients treated, only 54% were reaching their target. If we consider the new blood pressure targets or thresholds of 130/80, the number of patients who are treated to target is only about 30%. And so we could conclude that actually we have a suboptimal control of hypertension. And this is present not only in Korea, but seems to be a global trend. And so there really is a need for improved treatments. We should also remember that suboptimal control not only relates to the class of drug used, but we should remember that there are many complex factors that contribute to suboptimal control, including adherence and non-compliance. So the field of antihypertensive therapies is very interesting. There have been some advances with respect to new classes and new approaches to treating hypertension. There has been a lot of work in developing new approaches to targeting the renin-angiotensin system. The endothelin receptor blockers are becoming increasingly researched with respect to targeting blood pressure in patients with resistant hypertension, phosphodiesterase inhibitors, siRNA approaches to targeting angiotensinogen, the sodium glucose transporter 2 inhibitors, the SGLT2 inhibitors, seem to have very potent blood pressure reducing effects and may indeed with time be used as antihypertensive agents. There are also the selective nonsteroidal mineralocorticoid receptor antagonists, which seem to be very effective in terms of reducing hypertension. But today I'm going to focus on another class of drugs that is evolving, the aminopeptidase A inhibitors. And at this meeting, we have discussed this interesting class of drugs before. In order to appreciate the importance of the aminopeptidase inhibitors, particularly in the brain, we need to look at the renin-angiotensin system, and certainly the renin-angiotensin system classically has been defined as a system that acts primarily peripherally, where the effects of angiotensin II on blood pressure regulation are really at the level of the peripheral cardiovascular system and the kidneys. But today it is known that there are also non-classical renin-angiotensin aldosterone systems, particularly local or tissue renin-angiotensin systems in the brain, the heart, the vessels themselves, the kidney, and the adipose tissue. And there's also the concept of the intracellular renin-angiotensin system. I'm going to focus in this talk on some systems in the brain, and particularly the aminopeptidase A system. Now, unlike peripherally, where the production of angiotensin II from angiotensinogen is the major peptide responsible for blood pressure regulation peripherally, in the brain, it seems that angiotensin II is metabolized by aminopeptidase A to angiotensin III. And it is angiotensin III in the brain that binds to the AT1 receptor that induces its effects centrally, including the regulation of blood pressure. It has been suggested that increased activation of aminopeptidase A causes an increase in the production of angiotensin III, which results in a contribution to an elevation in blood pressure. And so there's been a huge amount of interest of targeting the aminopeptidase A system using aminopeptidase A inhibitors. And I will talk a little bit about this class of drugs that seems to be especially interesting. And indeed, a class of orally active brain-penetrating immunopeptidase A inhibitors has been developed for treating hypertension, and this study was published in Hypertension in 2019. And if we look at the data that demonstrate the blood pressure lowering effects of immunopeptidase A, we can see that in a model of DOCA salt hypertension in rats that are treated using intracerebral immunopeptidase A inhibition, we can see that in these rats, EC33, which is the metabolite of the active component RB150, which is the immunopeptidase A inhibitor, causes a significant reduction in the activity of immunopeptidase A in the brain. The production of angiotensin 3 by these agents is significantly reduced compared to saline-treated DOCA salt rats, and importantly, these rats that are treated with immunopeptidase A inhibitors is significantly reduced compared to vehicle-treated rats. We can see also, if these drugs are given orally, a similar effect, a significant reduction in a dose-dependent manner in terms of mean arterial pressure in DOCA salt animals, and this is associated with a reduction in brain immunopeptidase A activity. Similarly, we can see with respect to a time course, the blood pressure lowering effects of this orally active drug remain for a number of hours, and actually after 24 hours, we can see blood pressure starts returning to its pre-treatment levels. Associated with the blood pressure lowering effects of these immunopeptidase A agents is an associated decrease in plasma arginine vasopressin, an increase in diuresis, and an increase in natriuresis in DOCA salt rats. So not only are these immunopeptidase A inhibitors that are targeting the brain system, reducing blood pressure, but they're also increasing natriuresis and diuresis. So if we look at this from a diagrammatic point of view, the active metabolite of the RB150, which is the orally active immunopeptidase A, EC33, is what actually inhibits immunopeptidase A, causing an decrease in angiotensin 3 with an associated decrease in blood pressure, an increase in diuresis, as well as a decrease in sympathetic activity I have not shown you. But in addition to these interesting effects on blood pressure, it has also been suggested that inhibiting immunopeptidase A in the brain may also have a protective effect on cardiac function in experimental models post-myocardial infarction. And in this study, rodents were treated with immunopeptidase A inhibitors or ramipril, and they were exposed to a myocardial infarction and studied for about 30 days. And at the end of the study, a number of parameters were examined with respect to cardiac function and cardiac structure. And what these authors found is that if we looked at the effects of these various drugs on the diastolic, systolic diameter of the heart and the diastolic volume and systolic volume of the heart, we can see that all treated groups, including those that had the immunopeptidase inhibitor, were showing an improved effect compared to vehicle-treated animals. We can also see that QGC606, which is an immunopeptidase A inhibitor, as is firbestat or ramipril, were associated with a decrease in biomarkers of heart failure, such as MHA7, atrial natriuretic factor, and also pro-BNP circulating. So it seems that these immunopeptidase A inhibitors have similar effects to ramipril, an ACE inhibitor, in improving cardiac function, in improving the potential for cardiac failure post-myocardial infarction. And similar to those protective effects, the effects on cardiac fibrosis were also attenuated by the aminopeptidase A inhibitors, as we can see by the green graphs, and by ramipril as indicated by the purple graph. And we can see here with serious red staining a marked improvement in those animals that were treated with these drugs. So these are all very interesting data at the preclinical level. But what do we know about these agents targeting aminopeptidase A in the brain in humans? Well, in Circulation in 2019, there was a study that came out to show that these drugs do have a significant effect on blood pressure lowering, as we can see here in a study where patients were treated with Variability, which is the orally active aminopeptidase A inhibitor, in a phase 2 study, and they were studied for about 56 days with a blood pressure lowering of about 10 millimeters of mercury. It has also been shown that using these drugs, there's a blood pressure lowering effect in both blacks and in whites, but that the blood pressure lowering effect seems to be much more effective in patients who are African American. More recently, there has been a study, a phase 3 clinical trial called the FRESH trial, which is a double-blinded, placebo-controlled, multi-center study. And this study was aiming to look at the effects of Variability on blood pressure in patients with resistant hypertension. And these patients were treated on top of their other medications. This is a very exciting study, and this study was going to be presented at the late-breaking science session of the American Heart Association Scientific Sessions Conference, which is taking place over the course of this weekend. The results of this study were aimed to be discussed at this late-breaking session. But it should be highlighted that very recently there was a press release from the company Quantum Genomics to actually announce that the FRESH study did not show improved effects in patients with resistant hypertension. And so, for all intents and purposes, this study did not show positive outcomes. So I've shared with you today some of my thoughts regarding advances in new antihypertensive therapeutic approaches. We know that blood pressure control is suboptimal globally and in Korea, and I know at this meeting there has been an enormous amount of discussion related to this. There are a number of new antihypertensive drugs that are in development, and also we'll see over the next few years whether drugs that are used to treat diabetes, such as the SGLT2 inhibitors, may also be used for treating hypertension. I've discussed with you this new and evolving class of agents, the aminopeptidase A inhibitors, that are known to cross the blood-brain barrier, that have blood pressure lowering effects by acting to reduce the amount of angiotensin 3 that is produced. And I should remind you that angiotensin 3 is the endogenous brain AT1 receptor agonist. Preclinical and clinical studies show that this drug has effective antihypertensive effects, and also that it seems to be protective at the heart in an experimental model of post-myocardial infarction. However, very recent phase 3 trials have actually failed with respect to the treatment in patients who've got resistant hypertension. So with that, I thank you for your attention, and I would like to thank the many people in my lab who have contributed to the studies that have related to those that have been shared with you today, and also to acknowledge the enormous amount of work done by Catherine Laurent-Coté, who really has been one of the founders in the field of aminopeptidase A and the brain-renin-angiotensin system. And with that, I thank you for your attention.
Thank you. As far as I know, all 4 speakers are connecting via online. Can you hear me? I think that okay, nice to meet you. Can you say hello to the audience in Korea for checking the technical success for would you please, who will start? Harmida?
Good evening.
Yeah, hey, thank you.
Yes, I can hear you very well. Thank you.
Thank you. And the Chiopis?
Yes, good evening.
Yeah, okay,
very happy to be with you all.
Thank you. The Sturgio?
Hello, everybody. Great to join this session.
And the Twiz.
Hi, good evening, everybody, and a pleasure to be with you today.
Yes, everyone is here. I think especially that Canada is early in the early morning. Thank you for joining these sessions. And we have the 4 panelists. One panelist is connected by online, Incher Kim from Keimyung University, and Yunjong Chan from Catholic University, Yuda Trana from Indonesia, and Yukchin Cha from Malaysia. As you know, that we are behind the schedule. Who started the discussion? Yeah, okay. Yunjong Chan, would you please start?
I'm Yoon from Seoul St. Mary's Hospital. It is a great honor for me to attend this session as a panelist. First, I'd like to express my deep gratitude for the 4 speakers for their wonderful talk. They were highly informative and well organized. I have one very simple question to Dr. George Stergio. You've nicely demonstrated that the new in-body ambulatory BP measurement devices are accurate and even some superior to the previous the oscillometric blood pressure devices. And in your opinion, to be a real game changer, can you suggest some more, improvements or modification of in-body ambulatory BP measurement devices? Can you suggest some more improvements or modification to be a real game changer?
Thank you for this question. First, let's make it clear that this particular device has been developed for office use by healthcare professionals. And particularly these features with the ability to visually review the Korotkov sound curve and potentially interpret in terms of the validity of each reading, I think can only be used within the healthcare environment by professionals. I made 2 comments about the potential superiority of this device. One is its measurement accuracy, and about that I'm convinced, because I have seen several data based on several patients, and I think there's no chance that this finding is wrong. This device has superior accuracy than the average modern oscillometric devices. For the second potential advantage, the ability of the observer to identify potentially inaccurate measurements by reviewing the Korotkov sound curves, well, this has not been proved so far. So we need data about that. The only thing I have to say, because we are looking at this, is that our observers agree on which of the readings are potentially wrong. I can't say whether these readings, which the observers think they are not very good, in fact they are good, because we haven't looked at that. But indeed, by visual inspection of the Korotkov sound curves, there is a possibility to identify different quality of the curves. It remains to be seen with proper research whether this can be translated to a clear advantage for clinical practice.
Thank you. Thank you for all speaker for the wonderful presentation. I would like to ask to Prof. Hermida. Thank you for your presentation. It's very nice, informative, and practical things about bedtime of inhalation of BP lowering medication. My question is there any specific group that more benefit or positive value in bedtime dosing?
Well, yes, indeed. As I tried to somehow summarize or embed in the presentation, patients with specific with sleep time hypertension, those with altered blood pressure dipping profile, also are for sure the more benefit, the ones that you should expect more benefits. indeed the effects on blood pressure lowering, the effects on reverse of left ventricular hypertrophy, the findings, most of the findings on the improved renal function had been specifically found in patients with non-dipping blood pressure pattern, in those with chronic kidney disease, and those with diabetes, which these two last groups are also clearly documented in the literature as more prevalent in terms of specifically having elevated blood pressure during sleep, or non-dipping, or even a rising pattern, which is has a prevalence, estimated prevalence from different studies of up to 30%, both in diabetes and especially in chronic kidney disease. So those will be, from my point of view and the experience of the close look to all the reported information, the ones who eventually will benefit the most.
Just a moment. 인철기, I heard you have the question to the Hermida, right?
Yes. Yeah, I'd like to thank you for all the lectures from all the four distinguished speakers. And I have a question to Dr. Hermida. We all know that patient compliance is very important. And do you think if there is a difference between the compliances between the bedtime treatment compared to the awakening treatment group? And do you also think that the compliance issue might have impacted your study results as well?
Well, thank you. It's a very interesting question. It's actually a matter of open debate. Just by revising the literature, as we did with the meta-analysis that I summarized, and of course by our own experience, we had been using or testing different medications in terms of morning versus evening treatment for the last 22, 23 years or so. What we found is that when a prescription relies on clock time, or basically an indication from the practicing physician of ingesting medications in the morning versus the evening, in such a case, just for convenience, morning treatment is associated with better compliance and adherence. The reason is clear. I mean, if you are recommended to take medication in the evening, or even with dinner, there are many times that you are out of home. The patients forget to take the medication. When eventually, when ingestion time is in the morning, is kind of perceived by the patient as more easy to remember. We came around with that, and there is a clear recommendation from the International Society of Chronobiology in terms of developing and designing new potential future chronotherapy trials with antihypertensives in humans. Our recommendations for the last 12, 14 years has always been the same. The patients are specifically instructed to keep their medication at the bed table, always, and either to take their medication immediately after awakening, if the prescribed timing is morning, or taking the medication just before turning the lights off when going to bed. This seems to be kind of simple. We repeat, I mean, the physicians and nurses repeat this message at every clinic visit with all treated patients. And what we found is that this is basically a small but very practical way of turning out compliance. And in fact, in the studies that we conducted, and in some others that have been reported in the literature, but many other independent colleagues, compliance increased significantly, both for morning and evening, and with no difference basically between, let's say, more properly awakening versus bedtime ingestion times.
Okay, thank you. Would you please? Yeah.
Professor Theophis, I'd just like to ask you, you've shown us some very convincing data
on the efficacy of blood pressure lowering by the different procedures. Because it's an invasive procedure, it's very expensive, you actually do not have any hard outcome data of the RDN. So how can we go about convincing regulatory bodies or funders to pay for this procedure for some of our patients?
Yeah, thank you for this really practical and important question. It is true that we don't have hard endpoint data about the effects of renal denervation in reducing cardiovascular morbidity and mortality. As everyone could understood, this is impossible to obtain such data because we need a huge number of patients. In the early stage of renal denervation, studies like that was designed, the Enlighten study, and it was estimated we will need 6,000 patients for 5 years follow-up. This is practically impossible today, also for ethical reasons. But we know from clear evidence from pharma randomized trials that reducing the blood pressure, even with 5 millimeters of mercury, this is equal to a reduction by 10 to 12% in the major cardiovascular events. And so this is the average reduction, 8 to 10 millimeters of mercury based on office systolic blood pressure, 5 to 7 millimeters of mercury based on ambulatory systolic blood pressure. So we can assume that this reduction of blood pressure achieved by renal denervation could be linked to the reduction of cardiovascular events. Of course, on the other hand, additional to that, we have data that renal denervation could reduce the left ventricular hypertrophy, reduce the aortic stiffness. That means it has a favorable effect in the intermediate endpoints. So I think that there is no need to obtain such data. Reduction of blood pressure per se, I think it's enough for introducing a new antihypertensive medication. This is what the FDA now recommends, but also I understand your points that here we discuss for one interventional procedure, although it's a minimal interventional procedure and well-experienced hands, it's associated with no side effects, no complications, and also we have data for at least 3-year follow-up about the safety of this procedure in terms of deterioration of kidney function or development of any renal injury. And if it is allowed, I would like just to comment in the previous question to Professor Hermida that this question about bedtime, night time, or early morning time of administration of medication has nothing to do with the renal denervation procedure. Renal denervation procedure, it's done at once and has this always-on effect. That means I'm not saying that renal denervation alone could reduce, let's say, could be enough for all patients for controlling the blood pressure. We know that only about 70% of patients are responders based on the available data, but it is important that renal denervation produce an homogeneous reduction of blood pressure during the nighttime and daytime period, and this also could have an extra effect, not dependent on the level of medication adherence that we know in all the clinical trials that is not too high.
Sorry, okay. This is the last session, and many of the audience is waiting for me to close the session. I'd like a last question to the Twiz. I heard, I'm sorry to hear the early withdrawal of the recent study for the difficult treatment or the resistant to control the hypertension. Can you explain us about the possibility of new classes of drug in hypertension management of the fidivastat?
Yes, thank you very much. Of course, those data were, I guess, unexpected and disappointing, especially that the trial is going to be discussed, I believe, at the American Heart Association scientific session. So I guess
the data were certainly unexpected and disappointing. I don't know where the field is going to go and whether there will be further investment in developing this drug. But I guess what's really important to appreciate is that certainly the preclinical studies, some of the early clinical studies for efficacy and safety were very, very convincing. And perhaps it was the wrong population group that was studied. They were resistant hypertensive patients on treatment who were studied in the FRESH trial. And I just wonder whether targeting different types of patients might be more appropriate, because actually the experimental studies, most of them were done in a salt-sensitive model of hypertension, and maybe, you know, that might be more appropriate in a clinical setting. So I'm not sure where the field is going to in terms of developing further, although there still obviously remains huge interest. I mean, the data have been very convincing. In terms of moving forward with new therapeutic approaches, I think the siRNA targeting angiotensinogen is very, very exciting. The idea of giving a vaccination every 6 months or 1 year, you know, to treat hypertension is really very exciting. And I know there will be some phase 3 trials that will be coming out. At least phase 2 trials are going to be published soon. So we'll wait and see. But certainly those data as well are very exciting. And then, of course, the SGLT2 inhibitors and others, we'll see what happens as time moves on. So I think it is interesting, and maybe we'll be doing a better job by stratifying patients into more appropriate therapies. Of course, we can only do this if we've got good diagnosis with all the fantastic technologies that have been discussed in the meeting today. So thank you very much.
Thank you. It's time to close the session, and I'm very happy to chair in this wonderful session with the distinguished 4 speakers and the 4 panels, and I'd like to close this session. Thank you.
예, 바로 이어서 폐회식을 진행하도록 하겠습니다. 이제 다른 룸에 있는 청중분들이 오시고 계실 텐데요. 오늘 아침에 있었던 이제 정기 임시평의회에서 보고된 주요 사항들 말씀드리면서 진행하도록 하겠습니다. 예, 안녕하십니까. 국총무이사 이혜영입니다. 어제 오늘 57회 추계국제학술대회에 참석하신 모든 분들께 감사의 인사 말씀을 드리며, 특별히 여기 끝까지 자리를 빛내주고 계신 분들께 다시 한번 감사 말씀드립니다. 지금부터 추계학술대회 보고 및 폐회식을 진행하도록 하겠습니다. 시작하기에 앞서 대한고혈압학회 이사장님 인사 말씀이 있겠습니다.
안녕하십니까. 오늘 이렇게 늦은 시간까지 함께해 주셔서 대단히 감사합니다. 오늘 간단히 보고와 함께 또 행운의 시간이 있을 테니까 여러분들에게 행운을 빕니다. Thank you very much all participants and overseas speakers and domestic faculties. So we are close to this ceremony, and then we are good luck for your new gift. Okay, thank you very much.
예, 지금 발표 자료를 준비하고 있고요. 이제 넘어오시죠. 초계 발표 말씀드리겠습니다. 이번 다음 슬라이드 부탁드립니다. 하나 전 주세요. 예, 어제 오늘 추계국제학술대회는 국내 연자 678명, 해외 연자 115분이 등록하셔서 총 793분이 등록하셔서 학회를 무사히 잘 마쳤습니다. 다음 슬라이드. 예, 우리 학회를 여러 회사에서 도와주셨고요. 다이아몬드 등급의 대웅제약과, 플래티넘 등급의 동아ST, 유한양행, 한미약품, 한국오가논, 골드 등급의 보령제약, 실버 등급의 한국세레비에, 삼진제약, 메나리니, 비아트리스 코리아, 종근당 등 17개 회사와 메인 후원사 17개, 일반 후원사 16개 회사분들이 많이 도와주셨습니다. 한번 명단을 기억해 주시고요. 다 같이 박수로 한번 부탁드립니다. 다음 슬라이드 부탁드립니다. 예, 우리는 고혈압 학회에서 계속 이제 일반 대중에게 다가가려고 노력하고 있고요. 유튜브 채널을 리뉴얼해서 카카오톡 채널을 매번 발송해드리고 있습니다. 한번 읽어봐 주시고 또 주위 분들께 추천해 주시면 감사하겠습니다. 다음 슬라이드. 예, 오늘 아침에 이제 보고드린 회칙 개정 사항을 말씀드립니다. 먼저 우리 편집장을 좀 더 독립되게 오랫동안 지속적으로 할 수 있게 하기 위해서 에디토리얼 오피스를 새로 규정을 만들어서 간행이사는 4년으로 이제 임기가 바뀔 때 좀 더 안정되게 할 수 있도록 규정을 정비하였습니다. 즉 편집장으로는 이전에 우리 학회 이사장을 맡아주신 편욱범 선생님께서 맡아주시게 했고, 그래서 앞으로 4년 동안 편욱범 선생님께서 이사장, 이제 편육범 전 이사장님께서 편집장 겸 간행이사로 수고해 주시겠습니다. 다음 슬라이드. 어제 오늘 강의를 여러 방에서 했습니다. 저도 뭐 발표하느라고 다니느라고 못 보고 싶었지만 못 봤던 강의들이 많은데요. VOD 서비스를 한 달간 홈페이지 통해서 진행할 수 있기 때문에 다 놓치신 강의 있으시면 들어보시기 바랍니다. 다음 슬라이드. 어제 오늘 등록하신 분들은 모두 다 받아보신 것처럼 하이퍼텐션 팩트시트 2022와 새로운 고혈압 진료 지침을 다 프린트아웃해서 가방에 넣어드렸고요. 홈페이지에서 다운받으실 수 있습니다. 오늘 아침 현재 벌써 70분이 이제 접속하셔서 다운받으셨고요. 계속 한번 지켜봐 주시고, 고혈압 진료 지침 뉴 가이드라인은 이제 2편의 논문으로 내년 1월에 클리니컬 하이퍼텐션의 게재를 준비하고 있습니다. 다음 슬라이드. 그리고 이제 12월 18일 다음 달에는 이제 프라이머리 피지션들을 위한 개원이 연수 강좌를 세종대학교 대양 A홀에서 아침 9시부터 4시까지 진행하려고 합니다. 다음 슬라이드. 그리고 ESH에서 하이퍼텐션 썸머 스쿨을 계속 운영해 주셨고요. 거기에 우리나라의 6분의 분들이 3번에 걸쳐서 가서 공부를 하고 왔습니다. 그런 분들을 이제 씨앗으로 해서 우리가 처음으로 내년 1월 7일, 8일에 KSH 윈터스쿨을 진행하려고 합니다. 고혈압 기초부터 임상 및 진료 지침까지를 다 아우러서 아주 깊은 강의를 한번 진행해 보려고 생각하고요. 우리나라 국적의 의사시면서 고혈압에 관심이 있는 40세 이하의 인력분들은 홈페이지를 통해서 지원해 주시면 심사해서 우리가 한번 모아서 같이 공부하는 시간을 가지도록 하겠습니다. 다음 슬라이드. 내년의 미팅 날짜를 달력에 표시해 주셨으면 하는 것입니다. 내년 스프링 미팅은 5월 19일에서 20일에 대구 엑스코에서 있고, 다음 슬라이드. 그 다음에 가을 학회는 다 11월 첫 주 금토일에 여기와 마찬가지인 여의도 콘레드 호텔에서 진행하게 됩니다. 오늘 이제 다양한 지난 이틀 동안에 많은 경연에서 수상한 분들에 대한 시상식이 있겠습니다. 다음 슬라이드. 먼저 클리니컬 하이퍼텐션 우리 학회지에 공헌해 주신 분들에 대한 시상을 하겠습니다. 다음 슬라이드. 이 심사위원을 계속 열심히 해주신 손희석 정우백 선생님께 심사위원장을 수여하고요. 논문 중에 많은 평가를 좋게 받으신 우수 논문에 선정되신 편욱범 선생님, 신진호 선생님의 학술상을 수여했습니다. 그 다음에 본인의 논문이 많이 인용돼서 클리니컬 하이퍼텐션의 임팩트 팩터를 올리는 데 도움이 된 논문에 대해 이제 2분에 대해서 공로상을 수여하였습니다. 다음 슬라이드. 어제 오늘 일반 연재의 시상을 진행하도록 하겠습니다. 우수연재 클리니컬 리서치 어워드의 2분이 수상하시게 되었고요. 동국의대 이무용 교수님, 가톨릭의대 정미양 교수님께서는 앞으로 나와주시기 바랍니다. 임상현 이사장님이 수상해 주시겠습니다. 시간 관계상 이무용 교수님의 수상 내역을 읽도록 하겠습니다. 클리니컬 리서치 어워드 동국의대 이무용 교수님, 상기인의 논문은 하이퍼텐션 서울 2022 57회 대한고혈압학회 추계학술대회에서 발표한 클리니컬 리서치 어워드에서 우수한 연구과제로 선정되었기에 이 상장과 상금을 수여합니다. 대한고혈압학회 회장 박창규, 이사장 임상현. 가톨릭의대 정미양 교수님, 아래 내용은 같습니다. 정미양 교수님 축하드립니다. 음악 좀 들려주십시오. 네, 다음 슬라이드 부탁드립니다. 다음은 영 인베스티게이터 어워드에 수상하신 두 분입니다. 서울대학교 공과대학의 이영로 학생, 그리고 연세의대 이혁희 선생님 앞으로 나와 주십시오. 두 분 중 이영로 학생의 대표로 읽도록 하겠습니다. 영 인베스티게이터 어워드, 서울공대 이영로, 상기인의 논문은 하이퍼텐션 서울 2022 제57회 대한고혈압학회 추계학술대회에서 발표한 영 인베스티게이터 어워드에서 우수한 연구과제로 선정되었기에 이 상장과 상금을 수여합니다. 대한고혈압학회 회장 박창규, 이사장 임상현. 네, 다음은 연세의대 이혁희 선생님이십니다. 이와 같습니다. 예, 그리고 다음은 베스트 이포스터 프리젠테이션 어워드에 수상하신 분들이 있고요. 오늘 아침에 했기 때문에 현장에 계신 분도 있고 안 계신 분이 있어서 다 호명을 하고 한꺼번에 나와서 모든 분이 사진 촬영을 하는 것으로 가름하도록 하겠습니다. 충남의대 김선희 선생님, 아주의대 정수인 선생님, 서울대학교 간호대학 이경숙 교수님, 서울의대 휘싱 선생님, 다음 슬라이드. 서울시립대 김현정 선생님, 서울의대 장용준 학생, 서울의대 추현욱 선생님, 연세의대 이양 선생님 앞으로 계신 분 다 나와주시기 바랍니다. 이사장님과 같이 사진 찍고 상장과 상품은 개별적으로 수상하도록 하겠습니다. 장용준 학생은 본과 2학년 학생입니다. 예, 다음 슬라이드 부탁드립니다. 네 분 들어가 주십시오. 다음은 트래블 그랜트 어워드에서 수상하신 세 분이십니다. 인도네시아의 아디카 줄리 알자나 선생님, 인도네시아의 코망 아구스 트리스티나 아미자야 선생님, 말레이시아의 마옹 휘챙 선생님 세 분이 트래블 그랜트에 수상하셨습니다. 예, 앞으로 나와 주십시오. 축하드립니다. 다음 슬라이드. 다음은 온라인으로 참가해 주신 선생님들께 수상자가 있고요. 여기에 참석은 안 하셔서 명단을 발표하겠습니다. 말레이시아의 반 파테인 나벨라 완 오마르 선생님과 맨체스터 유니버시티의 시아광 슈 선생님이 수상하셨습니다. 예, 다음은 우리 학회에서는 매년 학수연구비를 심사하여 수여하고 있습니다. 올해는 3분의 학수연구비가 수상하게 되셨고요. 다음 슬라이드. 건국의대 김성애 교수님, 서울시립대학교 제세영 교수님, 연세대학교 김태형 교수님께서 학수연구비로 당선되셔서 1천만 원의 연구비를 수여하시게 되었습니다. 예, 다음입니다. 아마 많은 분들이 기대하신 이제 럭키 드로우 시간입니다. 먼저 우리가 시간을 줄이기 위해서 아주 공정하게 부총무님께서 미리 추첨해서 파워포인트에 표시한 분이 있습니다. 5등은 스타벅스 상품권입니다. 다음 슬라이드. 수상자 명단 보여주십시오. 예, 10분의 추첨 결과입니다. 전성호 선생님 계시면 손 들어주시고 앞으로 나와주십시오. 박지혜 선생님, 리양주 선생님, 정미양 선생님, 다시 한번 하겠습니다. 5등 스타벅스 상품권은 강원대학교 병원의 김진아 선생님, 김광희 선생님, 이혜원 선생님, 김주환 선생님, 서혜은 선생님, 공민규 선생님, 정미양 선생님, 이랑주님, 박지혜 선생님, 전승호 선생님입니다. 계신 분 계시면 여기서 증정을 하도록 하겠습니다. 네, 학술이사님께서 증정해 주시겠습니다. 예, 다음 슬라이드 주십시오. 4등의 경우는 3분인데요. 자동 진공 와인 세이버입니다. 이 수상자는 강원대학교 병원의 김상진 선생님, 육군 군의관이신 강신혁 선생님, 인하의대의 정병원의 김문재 교수님, 그렇게 3분께서 수상하게 되셨습니다. 예, 학술회사님 감사합니다. 다음은 2등입니다. 3등입니다. 3등은 코닥 미니샷 3 이제 포토 프린터인데요. 양산 부산대학교 병원의 이상현 선생님, 세브란스 병원의 문지우 선생님께서 수상하시게 돼서 이사장님께서 전달해 주시겠습니다. 감사합니다. 예, 2등 한 번 더 수상해 주셔야 됩니다. 2등은 에어팟 프로이고요. 전남대학교 병원의 윤수진 선생님, 국립암센터의 광미양 과장님께서 수상하시게 되었습니다. 예, 2분은 저기 계십니다. 윤수진 선생님은 나오시고요. 광미양 과장님께는 배송하도록 하겠습니다. 예. 이제 5등부터 2등까지는 사전에 선정했지만 그래도 1등은 현장에서 뽑는 맛이 있어야 돼서 우리 회장님께서 1등은 추첨해 주시겠습니다. 1등은 정말 제가 가지고 싶었던 거고요. 발뮤다의 더 브루 커피 메이커입니다. 회장님 추천 부탁드립니다. 양용준 선생님 계십니까? 1등은 안 계시면 다시 뽑을 예정입니다. 양용준 선생님. 예. 이제 마지막으로 우리 대한고혈압학회 박창규 회장님의 인사 말씀 및 폐회 선언이 있겠습니다.
희망리에 학회를 마칠 수 있도록 끝까지 남아주셔서 후원해주신 여러 선생님들, 회원 여러분들한테 다시 한번 감사드리고요. 내년에 이렇게 더 좋은 모습으로 다시 여러 선생님을 만나 뵙고 더욱더 발전한 고혈압학회가 되는 길을 바랍니다. I really appreciate for your participation and devotedness. I hope to see you next year again. Thank you very much.
감사합니다. 이것으로 하이퍼텐션 서울 2022를 마치도록 하겠습니다.